in liver metastasis, I'd like to use abemaciclib in liver metastasis based on these findings. I don't think that the choice of liver metastasis with ribo or palbociclib is wrong, but this is how I do it. I don't have ribociclib in my practice, but if I do, I'll use it in premenopausal women based on the Mona Lisa 7. The rest I will use palbociclib or any of the above. So now continuing beyond progression, there is a real world evidence in continuing beyond progression, which just changing the hormonal partner from AI to fulvestrant and the opposite. That was in roughly around 30 patients cohort that was done in MD Anderson. It shows that the progression-free survival with continuing beyond progression is around 6 months, which I find it great. Now, do I do that? No, but have I done that in some cases? Yes, for those with questionable progression, I change the partner and continue the CDK4/6 inhibitor, especially if they don't have PIK3CA mutation. I would do that in certain situations, but in general, I think you should switch mTOR or some other agents.
Just a quick for your case that you have presented, you have described that she has some more kind of chronic loperamide user. She has diarrhea, it's ongoing.
Right, right.
With this diarrhea, could impact her quality of life, and you might think of switching to a different CDK4/6 in order to keep the cycle running on, or what do you think about that?
Yeah, well, actually, my assistant asked me that question, and I offered the patient, and I told her, "Do you want to switch?" She saw the response within a couple of months. She said, "No, I can live with the diarrhea. Just continue the medication." Yeah, so she's still on it.
So let's see if we have question from the audience while I'm searching for the question on the Q&A. If you have microphones, do we have? Yeah, there is a question from Dr. Ibrahim Qurashi. Go ahead.
Yeah, thank you, Dr. Ahmed, Dr. Abdullah, for this comprehensive presentation. Shows the difficult situation is when we have a patient relapse shortly after surgery while the anti-estrogen therapy meeting the criteria of primary anti-estrogen resistant. And sometimes those patients, they do relapse with visceral disease. So now this data is going to guide our choice. Like we have an evidence maybe that palbociclib is not working in the primary anti-estrogen resistant. So can we utilize this data for dissecting the, or just recommending for this difficult to treat situation, abemaciclib over others?
I think that it's a very good question. I will certainly, for this population, I will use abemaciclib for primary resistance. Though remember that the primary resistance was a minority of patients in the trial, but certainly the response is great. And I believe that these agents are different. I believe that there is a different molecular properties for these agents. And my next study, or my next presentation, sorry, in the main San Antoniao is about the Palace trial, and I will mention about the monarchy. So these agents are different, and but we tend to call them CDK4/6 inhibitors. But I think with time we'll see some differences. But certainly, to answer your question, yes.
Would you send NGS for those patients who?
No, it's not going to help us a lot, would it? I mean, NGS, more information is always good, but it's not going to help me a lot in terms of treatment. But let's say this patient has a PIK3CA mutation. Would you use it as first line? Maybe, or not. But certainly, more information is helpful, I'm sure.
Questions? Yeah, there's one question from the audience. It's probably it's not exactly with the topic of today, but it's where do you think the role of abemaciclib in the management of early stage breast cancer, hormone positive?
Okay, So there are multiple presentations about that, but I do believe that in high-risk patients and very high-risk patients, yeah, we should use abemaciclib in the adjuvant setting.
Okay. Yes, go ahead. Microphone, please.
Thank you for your presentation. Just I have a question for the panel. If I have a patient just newly diagnosed postmenopausal feed patient metastatic breast cancer with low burden disease, just show metastasis for 3 or 4 sites bone. So she is T2, N0, M1. How can I manage this patient regarding to give hormonal therapy plus aromatase inhibitor plus renocyclib, BARB inhibitor, CDK?
Got your question. Got you.
Yes,
Got it.
okay.
Got it. So first, this is a patient of yours in real life?
Yes, yes.
Okay, so you need to pay me for consultation. So I would go for CDK4/6 inhibitor with AI, basically. I mean, we know that some patients have bone metastasis with bone-only metastasis, have sort of indolent disease. The one that you're describing fits the criteria for oligometastasis. So one would argue, okay, should we go for curative intent? That's really arguable, and it's not needs more discussion. But bone metastasis, still they benefit from CDK4/6 inhibitor with AI, similar to any metastatic disease. Now, the degree of benefit is higher, for instance, that with abemaciclib and visceral metastasis, but still both the groups have benefited. So the answer is CDK4/6 inhibitor and AI.
Thank you.
Thank you.
Yeah, thank you so much. What about the local therapy? If you think if these lesions are within kind of same territory where you can treat with local treatment, probably radiation.
Yeah, go ahead. No, go ahead. You answer that.
So exactly what Dr. Ahmed described. I think by the definition are stage 4 disease. So they are M1 endocrine therapy, and CDK4/6 is the main treatment choice. Definitely, this is small volume disease. Definitely, those might have lived longer than everybody else. So that doesn't change the aim of the treatment, but probably in a certain situation where we call it oligomets, those might be fitted from a local therapy. So I will go with the probably last question, just because Dr. Khair, she will open the meeting. The last question is, we have, if patient progress on AI and fulvestrant, what is your strategy for using CDK4/6 inhibitor as, what is the partner? So that's what the question is. If patient has progressed on AI and fulvestrant, probably first and second line, or probably combination, what is the partner that you use with the CDK4/6, or would you use it a single agent as an option? Yeah.
Oh, well, one of the things that we need to note is when did they progress on this? Is it 1 month, 2 months, 6 months, or more than that? But generally, I think if you progress on fulvestrant for any number of months, if you want to combine it if you want to add CDK4/6 inhibitor, I think it should be with fulvestrant, I think.
Yeah.
But that needs to be, to answer this question appropriately, we would like to know more about the timeline of treatment and whatnot. Okay. Yeah. But it's still, even with PIK3CA mutation, you still can use CDK4/6 inhibitor. Yeah. Thank you very much.
Okay. Thank you so much. I think we reached the end of our satellite symposium. Thank you so much, Dr. Ahmed. Thanks everyone for the question and contribution. I would like to hand over now to Dr. Khair to open the meeting of San Antonio conference.
Thank you, and thank you for Lily. بسم الله الرحمن الرحيم، والصلاة والسلام على سيد الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. السلام عليكم ورحمة الله. Good afternoon, everybody. I would like to welcome you all to the 16th Middle East Best of San Antonio. This year, again, it is hybrid because of the COVID COVID-19 situation, unfortunately. Although it is hybrid, but we exceed the capacity of 5,000 online attendee. And now we made it as directly to YouTube, in addition to the registration on the link. Physical attendee around 89. Without further ado, I would like to start the meeting by inviting the chair of first session. There is Dr. Sam Al-Khatib online with us, Dr. Hashim Al-Hashimi, and Dr. Majid Al-Jahil, as well Dr. Lubna Sidqi. I think she's online, but I don't see her online. So the floor is yours, Dr. Hashim, to start the first session. I hope it will be a fruitful meeting and enjoyable and useful for everybody. Thank you.
Thank you, Al Khair, for inviting us as usual. Excellent meetings. Really, we are proud of you, this organization and the scientific contact. Would you like Dr. Hashim to start, or would you like me to start the session?
Start, please, Dr. Sami.
Yeah, thank you again for all the organizers, mainly for our dear colleague and friend, Dr. Al Khair, for this excellent job. So we'll start the early hormone receptor positive breast cancer update. We'll start with our first speaker that you know all, Dr. Ahmed Al-Wabari. Dr. Ahmed, after, of course, welcoming all the chairs of this excellent session. Dr. Ahmed, he is assistant professor at University of Arkansas, hematology and oncology consultant at King Fahd Specialty Hospital, and he will talk about the abstract GS107 adjuvant palbociclib in hormonal receptor positive, HER2 negative in early breast cancer. Please, Dr. Ahmed, the floor is yours.
Thank you very much. الخير أعطينا الغدا سفري ونخلص ونمشي. So thanks again, Dr. Sami, Majid, and Hashim. Thanks for Khair and the organizers. We always look forward for San Antonio, best of San Antonio and the actual San Antonio. So today I will talk about the PALACE trial. This was presented by Michael Gnant, the Austrian group. So for those who don't know, the PALACE trial is the adjuvant palbociclib in hormone positive early breast cancer. It has been presented multiple times. This is the final protocol planned analysis of the 5,761 patients. So this is his disclosure, Dr. Gnant's disclosure. And as I said, the PALACE was the addition of palbociclib in adjuvant hormone positive patient after completion of treatment. This is the final analysis. So the eligibility for the PALACE, as we all know, stage 2 and 3, ER positive, who those patients completed all their treatment, then they get randomized to receive palbociclib for 2 years through the same schedule, 125 milligram daily, 3 weeks on, 1 week off with the endocrine partner versus the endocrine treatment, whether it's aromatase inhibitor or tamoxifen with or without ovarian suppression, and the planned treatment was at least 5 years. There was a stratification point of age, chemotherapy, stage, and geographical region. And the primary endpoint was invasive disease-free survival. This was an open label study. So the endpoint, as I said, IDFS per STEEP, and then the IDFS excluding second cancer as a secondary primary, distance recurrence-free survival, local regional recurrence-free survival, overall survival, and safety. So this is how recruitment looked like in the US and the non-US. The enrollment period between September 2018 and November of 2018, the first analysis was September, or the first review was in September 19. Second interim analysis was in May 2020, and the final analysis was in November 2020, and it was reviewed in May of 2021, presented last year in December. So 5,761 patients randomized in the intention to treat analysis. Majority of those patients have high stage disease, 82% stage 2B and 3, prior chemotherapy in 83%, owing that these patients have high risk. Median age was 52 years, and the clinical definition, by their definition, the clinical high risk was around 60%. So, these are considered to be 50% or more, 60% high risk patients. One could argue that they are, given the chemotherapy and whatnot, they may be more than 50%. As far as safety goes, I mean, palbociclib has been there for almost now close to 10 years now. Is it close to 10 years? 2015. Yeah. So no new safety signal. And the deaths that were reported, 176 deaths in the trial were deemed not related directly to the use of palbociclib. So one of the really criticism of this trial was the discontinuation rate, the high discontinuation rate. But the final analysis data confirm earlier result that longer palbociclib duration, more than 70% dose intensity, did not markedly improve the IDFS. So the general discontinuation rate for this trial was around 45%. So the primary endpoint, IDFS, was negative. It was similar in both arms. You look at the key subgroup analysis, you can't generate any information, any significant information out of that. The distance recurrence-free survival, as well as breast cancer-free survival, was not significant. Local regional, as well as overall survival, were negative. So the bottom line that really the addition of palbociclib in this selected group did not meet the primary endpoint and should not be used in the practice as adjuvant treatment. Now, this was the question that I was asked during the satellite symposium. What about the Monarch E? The Monarch E showed a benefit in terms of invasive disease-free survival. The hazard ratio was 0.7. There are some differences between the Palace and the Monarch E. The first one was the patient selection, so more high-risk patients compared to moderate to high-risk patients. The duration of treatment was 2 years in both studies. The patient discontinuation rate in Palace was 45%, and it was not reported in the Monarch E, but it was less than 45%. And one last thing is that, is there a drug property that differentiate between palbociclib and abemaciclib? Is there a difference in the property of the drug itself, not necessarily as a class of medication? With that, I'd like to stop here and thank you very much.
Thank you, Dr. Ahmed, for your excellent presentation. And thank you, Dr. Khair, for your kind invitation, and congratulations for this successful meeting. Our next speaker is Dr. Ibrahim Al-Qurashi. Dr. Ibrahim Al-Qurashi is a consultant medical oncology at King Fahd Medical City in Riyadh. He is subspecialized in breast and GI and head and neck cancer. He will present the abstract GS108, a phase 3 randomized double-blind trial for placebo versus metformin in the early breast cancer. Dr. Ibrahim, the mic is yours.
Thank you so much for the organizing committee for inviting me to this recurring Best of San Antonio meeting. I'd like to present the MA32 phase 3 randomized trial results, which is presented in the last Ask San Antonio conference by the Pamela Godwin from the Mount Sinai Health System, University of Toronto, and other colleagues. And this is international phase 3 randomized double-blind randomized clinical trial. The background of this is the obesity, which is associated and observed to be associated with poor breast cancer outcomes. And the theory behind that has a multifactorial etiology, like the insulin levels may be correlated with the worst prognosis of the breast cancer. Other etiology like the cellular inflammation, and other postulated hypotheses. However, metformin, one of these agents that in the preclinical data showed to tackle this etiologies, and by moderating the weight loss and also lowering the insulin level by approximately 15 to 20% in non-diabetic patients. Also, there was a trend that, or early report that using metformin, the neoadjuvant systemic chemotherapy, reducing the Ki-67 in breast cancer, which may be a hint for anti-cancer effect. Also, in the preclinical, in vitro and vivo research, it's shown that metformin could slow the growth of breast cancer. So the metformin, there was an observation that the metformin treated patient who has diabetes mellitus and breast cancer, they do better than other diabetic patients who are not receiving metformin. And this is an observation which was during the MA32 trial. So this is the background of this patient, of this etiology, and it was presented by the Godwin in the JCO 2009. And in order to understand that, we need to know the difference between the normal cells and the cancer cells. The normal cells has an equal distribution of the growth receptors on the cell surface, which is regulated by PIK3, PTN, and other mechanisms. The cancer cells hijacked the PIK3CA, PTN, and AKT, and using this to recruit more GLUT cells in the cell surface. And this is the basic difference between the normal cells and the cancer cells. So metformin can reduce this by lowering the insulin levels, and lowering the insulin levels can reduce the stimulation of the GLUT receptors, which in turn stimulating the PIK3CA, PTN, and AKT pathways, which have a downward pathways for stimulating the RAS, RAF, and other growth factor pathways. So this is another indirect benefit of the metformin, and other direct metformin, that it is implicated in the regulation of AMP kinase pathway, and that down regulation of this pathway lead to the reducing the tubular sclerosis complex 2, which lead to reducing the mTOR pathway. And the mTOR pathway is merely observed as a negative prognostic for the breast cancer patient, and usually associated with the resistance to chemotherapy, tamoxifen, and also trastuzumab. So this is the background of metformin, and I'm just mentioning that this is a preclinical data need to be validated by phase 3 randomized clinical trial. So Godwin and others try to tackle this by generating MA32 objectives, where the primary outcome was measuring the effect of metformin in reducing the distant recurrence, as the primary input was the invasive disease-free survival, and the secondary objectives was the overall survival, and also distant disease-free survival, breast cancer free interval, and also breast cancer specific mortality and contralateral breast cancer. So also they are monitoring and also observing the new diagnosis of diabetes mellitus or cardiovascular hospitalization, and also they are testing the adverse event of metformin more than grade 3, and also the BMI and circulating metabolic factors with this study. So the population of this study, as you can see, was mainly focused to the moderate and high risk populations. T1C, if they have high grade or high K67 or oncotype diagnostic high, they are enrolled. Otherwise, it is a T3, N0 to N3 populations. And all the patients, they need to be non-diabetic. The fasting blood sugar should be less than 7. And all of the patients, they should have adequate liver, kidney, and heart, and also low consumption of the ethanol. So the randomization was to 1-to-1 randomization with the pre-specified analysis for the ERPR positive versus negative cohort, HER2 positive versus negative cohort, BMI less than 30 versus more than 30, and chemotherapy used or not. The experimental arm was the metformin by 850 milligram BID with a month ramping up the dose to reach 850 milligram BID for total duration of 5 years, and the placebo was double-blind caplet BID capsules for 5 years, and also with the ramp-up strategy over 1 month to reach the equivalent amount. So the follow-up for this study was started initially enrollment in the 2020. At that time, the power of the 80% to detect the hazard ratio of 0.76 with the required 431 events. In May 2012, the criteria were modified to include more risky people like T2N0 with adverse features. In the March 2013, because of the rapid accrual, the enrollment was completed. And in March 2016, second interim analysis showing a futility of the hormone negative, ERPR negative cohort. And the decision was to continue on the ERPR positive cohort for the intervention, and just to keep the ERPR negative cohort for continue labeling and also follow up without intervention. In 2018, the study complete in ERPR positive subject, and in 2020, because of the slow event observation, they just amend the trial to include 465 events with 80% power to detect the hazard ratio of 0.76. So this is the what mentioned about the statistical design of this trial. It is the primary endpoint was invasive distal free survival, and the Cox proportional hazard ratio was designed to look for the HER2 BMI and neoadjuvant chemotherapy analysis performed for the 3 main cohorts. The primary analysis for the hormonal positive cohort, regardless of the HER2 status, and the follow-up for the HER2 or for the hormonal negative cohort, and also at the 3rd cohort for the exploratory HER2 positive patient, regardless of the ERPR status. The primary analysis for the ERPR positive breast cancer cohort showed that they are very well balanced criteria between the 2, metformin and placebo, in terms of the age and the BMI around 30 in both arms, and most of those patients, they are T2, and the nodal around N1, and the grade around grade 2, and the HER2 was equally between the two arms, and the use of the neoadjuvant chemotherapy as well as the hormonal therapy and adjuvant duration was very well balanced. Here is the compliance in metformin, and this is give us that the compliance with metformin is less than the placebo, and this is mainly related to the grade 3 side effect, which is documented as a 21% of those population that develop grade 3 side effect to 850 milligram metformin, which is mainly related to the GI upset, nausea, or diarrhea. So this is what they found regarding analyzing the primary endpoint for the distant recurrence. They found that it is not affected by metformin, and metformin hasn't reduced the distant recurrence. Invasive disease-free survival hasn't been affected by metformin. In all forms, distant recurrence, local recurrence, contralateral invasive breast cancer, new primaries, and death. And this is the 2 curves for overlapping, showing the hazard ratio 1.01 with a p-value 0.93. So it's no benefit of adding metformin for the in terms of the reducing the disease recurrence or distant disease recurrence. Regarding the survival, the same thing applies, and we found that there is no significant interaction of adding metformin in terms of reducing the mortality, and the hazard ratio of the overall survival was 1.1, and the p-value is 0.47. So regarding the the determinant of the primary outcome was the same. There is no added benefit or observed effect of metformin. And the conclusion here is the addition of metformin to the standard chemotherapy is not have any benefit improving the IDFS or overall survival, and the metformin should not be a standard of care for those population. The follow-up protocol for the futility cohort for the ERPR negative patient has been released also in the San Antonio Breast Cancer Conference, and the result was initially presented as the first interim analysis at the 36th month, showing that the two lines of the IDFS and OS were overlapping, and there is no benefit. Here is the 96 follow-up showing the same as the 36.7 month, with the hazard ratio of the IDFS was 1.01, and the overall survival is 0.89 without any added benefit. And the conclusion is, as the ERPR positive cohort, ERPR negative cohort do not benefit from adding the metformin to the standard treatment, and metformin should not be used as a part of the breast cancer management in this population. Now, what is the new in this presentation is the effect of metformin for the HER2 population. And there was a phase 2 data showing that HER2 population benefiting from breast cancer patients, they benefit from adding metformin to the neoadjuvant systemic chemotherapy by increasing the PCR to 3-folds in the especially on those patients who have single nucleotide polymorphism, SNP polymorphism called C allele. Those patients who are carrying this SNP, they have 3-fold probability of achieving PCR in comparison to those who's not carrying this SNP allele. And this is an observation, and this SNP allele has, or C allele has been related to the ATM, enhancing the activity of the ATM, and the ATM associated with the AMPK dependent and independent differential expression of thousands of genes down the road. So the presence of the C allele also observed that associated with the benefit in glucose control in the diabetic patient as well. The HER2 population, our cohort comprised of 620 subjects. 99 of those patients, or most of them, they received chemotherapy and trastuzumab. And the plan to examine metformin versus placebo effect on breast cancer outcome by SNP status, by single polymorphism C allele status, which is documented in the HER2 positive population, around 70% of them carrying this allele. So this is the overall population, finding that the adding metformin to the anti-HER2 containing chemotherapy regimen has shown reducing in the invasive disease-free survival by hazard ratio 0.64 and reduction in mortality by hazard ratio of 0.53. And the same thing when they tested by the interaction of the presence of the C allele SNP, they found a better result even in terms of further reduction of IDFS by hazard ratio 0.51. And if they apply this result or apply this analysis for those who doesn't carry this C allele, they found that AA genotype, they do not benefit from metformin. So this is something related to this SNP most likely. So here is the scientific background behind that. We said that the insulin itself and stimulating glucose receptors in the cell surface has promoting effect for generating more addictive stimulation to the PIK3CA-PTN, which stimulate the growth factor down the road, reaching to the mTOR. And also metformin, this strategy is very well dependent on the HER2 population, and the trastuzumab blocking the HER2, maybe metformin is lowering the insulin level, having an additive effect on the trastuzumab itself, and by this way, indirectly or directly by inhibiting the AMP kinase, can help the chemotherapy containing trastuzumab regimen. So the conclusion here is subject with HER2 positive breast cancer patient carrying the C allele, they benefited from adding metformin in terms of improving IDFS and OS to the neoadjuvant systemic chemotherapy protocol or the standard practice protocol, as documented in the phase 2 data, which is improving the PCR in those population. So not to mention that this is data which is not a phase 3 randomized clinical trial. Pre-specified analysis is something need to be validated by prospective trial focusing on the HER2 population alone. So just capping up all our presentation, the metformin is not beneficial for the hormonal positive, hormonal negative cohort, HER2 negative population. For the HER2 positive population, the beneficial effect of metformin improving the IDFS and OS, notably found in those population who carrying the C allele, single nucleotide polymorphism, and this observation again need to be replicated in phase 3 randomized clinical trial. Thank you.
Thank you very much, Dr. Ibrahim, for this presentation and spending time. Now I would like to invite our teacher, Dr. Dahish Ajarim, to join us in the podium, please, to present the next speaker.
السلام عليكم. مساء الخير. I have the pleasure to present one of our colleagues. With my short vision, I will get help from the secretary to size. The second speaker is Dr. Ahmed Shahri. He's well known. He is section head of medical oncology, and also his main interest is breast cancer and GI and head and neck cancer site. He's in King Fahad Medical City. He's King Abdul Aziz. Cannot see it. Anyhow, he's assistant professor in King Saud bin Abdul Aziz University for Health Science, Jeddah, Saudi Arabia. The presentation will be discussed, very important, really, and very interesting subject. His main
okay.
Let me say it. It's the. Can I see? I have short vision. This subject is clinical utility of molecular tumor profiles result from the randomized trial SAPHIR-2 breast. Welcome, Dr.
Thank you, Dr. Dahan. Thank you so much. Thank you for the nice introduction. I would like to thank Dr. Khair for her kind invitation, and I want to congratulate her for the 16th meeting in a row. Actually, it was the first ever conference meeting since I came to this country, and now we are in the 16th version of it. So I have been given the task to present the clinical utility of genomic profiling in patients with metastatic breast cancer, results of randomized trial SAPHIR-02. So probably most of you are aware of this trial, which actually was originally presented at the San Antoniao Breast Cancer Symposium in 2019. And this is just another aspect of this trial, talking about the clinical utility of doing genomic profiling, or what we call next generation sequencing, or comprehensive genomic profiling, whatever you want to call it. And we want to answer several questions, as you can see here. We want, for example, to answer, is it effective to start with? How to interpret the genomic report? What are the predictors, and what is the actionability of these kind of genetic testing, and the molecular characteristics of cancer whenever we do these to our patients? And finally, which technology should we use for genomic profiling? So the SAPHIR-02 breast program trial is actually a big one that included patients with metastatic breast cancer, those who have HER2 negative, so all of them are HER2 negative, and either to be triple negative or hormone receptor positive. If they are hormone receptor positive, they are mandated to be endocrine therapy resistant. So they allowed maximum 1 line of chemotherapy in this group. So what they did, they took samples from these patients, either fresh samples or any historical sample within 12 months, and they have been tested with what we call it comprehensive genomic profiling or circulating DNA, including the BRCA1 and 2 genetic testing. And those, after doing all this exercise, those patients have been subjected to 6 to 8 cycles of chemotherapy. And only those who showed a disease response or stable disease, they have been taken to the next level, which is according to their genomic profile, they have been randomized to 9 different targeted therapies according to the genomic profile versus maintenance chemotherapy. One of the standard arms they use here, as you can see here, is the PIK3CA mutation and the use of the combination fulvestrant alpelisib versus maintenance chemotherapy. And then they have like 8 different targeted therapies. So they end up having 9 different targeted therapies, including the arm for the alpelisib and fulvestrant versus maintenance chemotherapy. And they have been randomized 2-to-1. Okay, so what are the primary objectives of this study? This is a hierarchical kind of testing. So step 1, they want to test for progression-free survival in those patients who have what they call actionable mutations of SCAT 1 and 2. What they mean by SCAT 1 and 2, there is a scale for the actionability. Okay, so from SCAT 1 to SCAT 5. SCAT 1 and 2 means those actionable mutations which have some clinical data of anti-tumor activity or improved clinical outcome. This is SCAT 1 and 2. Beyond 2, it means that they don't have enough data for anti-tumor activity or improved clinical outcome. So the step 1, they want to restrict to those people who have some data about clinical benefit or anti-tumor activity, what they call it SCAT 1 and 2, with regard to these actionable mutations. If this have been proven to be significant, then they will go to step 2, which is to show the improvement in progression-free survival on all those patients who have been tested with targeted therapies according to their actionable mutations. So these are the scales. This is the scale that I told you about. As you can see, 6 different scales. It's only class 1 and 2 where it showed some sort of anti-tumor activity or improved clinical outcome. And those are the population who have been included in the primary or the first step of the primary objective of this study. So as I mentioned, to have a targeted therapy match to genomic alteration as the first primary endpoint, in those patients who have SCAT 1 and 2 alterations, they calculated to have an improved progression-free survival by hazard ratio of less than 0.51 with a total of 85 events. Then if this proven to be significant, they will take it to step 2, which is the test for the total population who have been treated with targeted therapies. And they calculated an improvement of progression-free survival to be less than with a hazard ratio less than 0.66 and a total events of 205. So, and this is the final kind of diagram of the whole study. This is the part of the study, as you can see at the right bottom side of the slide, where they use the immunotherapy durvalumab and have been presented at the San Antoniao 2019 and proven to be some clinical activity of using durvalumab in triple-negative breast cancer who are PD-L1 positive. Okay. So we'll go to these questions they try to answer here. Has genomic profiling clinical activity in patients with breast cancer and how to interpret that? And to do that, they have this kind of like larger screening. They screened more than 1,462 patients. And out of those 646, they have been found to have a targetable alteration or mutation. And out of those, 115 are found to have what we call SCAT 1 or 2, alterable, actionable mutation, meaning that there is some clinical data of improved outcome or anti-tumor activity. And this is the first step of the primary endpoint, the progression-free survival, as we mentioned, in the SCAT 1 and 2 group. And as you can see, the progression-free survival has improved from 2.8 months for the maintenance chemotherapy to 9.1 months to those patients who have been treated with a targetable or a targeted therapy with a hazard ratio of 0.41 and a significant p-value, as you can see, of less than 0.001, as you can see here. And when they look at the subgroups, there was no significant interaction where most of these subgroups showed some sort of benefit. Once again, I'm talking about SCAT 1 and 2 targetable mutation. And so since that one was significant, they moved to the next step, which is testing the progression-free survival in the overall population, meaning the whole population who have been treated with targeted therapies versus, I think I lost my presentation. Yeah, excellent. So again, it's the maintenance chemotherapy. And look here, the improvement, there was an improvement of progression-free survival of 2.9 months for maintenance chemotherapy to 5.5 months for targeted therapy. However, the hazard ratio didn't reach the statistical level of significance. It was 0.77, where the target was less than 0.66. And the p-value, as you can see, was not significant. When they looked into the subgroup analysis, they found a significant interaction when they divided those patients into SCAT 1 and 2 versus those patients who have beyond 2, class beyond 2 actionable mutation, meaning that the benefit was only restricted to those who have SCAT 1 and 2 like actionable mutation, and those patients where we know that these mutations have some clinical data of improvement of the clinical outcome and anti-cancer activity. Okay, so let's move to the next question. What is the genomic landscape of metastatic breast cancer? There have been a publication, previous publication, not included in this presentation, but the author or the PI of this study focused on the copy number analysis. And the most interesting part of it, when you look into the metastatic breast cancer, especially those who have been like hormone receptor positive, they did a comparison between those who received CDK4/6 inhibitor versus those who didn't receive. And what they found that those patients who received CDK4/6 inhibitor, they have like 13 more genes that had been more frequently altered in comparison to those who didn't receive CDK4/6 inhibitor. And the most important one of them was the CDK4 itself, which was almost like 10%. There was like overexpressed in 10% on those patients who have been treated with CDK4/6 inhibitors before, as opposed to less than like almost 2% on those who didn't receive CDK4/6 inhibitor. So this might give us an indication like a suggestion of some sort of mutation that can be targeted in the future by, for example, increasing the dose of CDK4/6 inhibitor or to use more potent CDK4/6 inhibition in the future clinical trials. And the last question they want to answer, can we identify new genomic markers of drug sensitivity? And actually, they specifically did that with the patients who have germline BRCA mutation. And they found there are two groups of those patients, those who have loss of heterozygosity for BRCA and those who have homologous recombination deficiency, HRD score. They specifically have like significant benefit by olaparib as opposed to those patients who don't have these two different mutations. So as a conclusion of this interesting clinical trial, the author has concluded that genomic profiling has clinical utility in patients with metastatic breast cancer when driven by a validated framework of actionability, which means that you have to have a good framework for actionability. And if you have a good level of evidence that this kind of actionable mutation has anti-cancer activity or improved clinical outcome, then this kind of actionable mutation might serve as a targetable mutation with an like specific targeted therapy. The second conclusion, a subset of patients who became resistant to CDK4/6 inhibition may present with CDK4 amplification in their tumor, and this may serve as a potential targetable mutation in future clinical trial. And last but not least, homologous recombination deficiency and loss of heterozygosity are associated with longer progression-free survival in patients treated with olaparib. I'm talking about germline mutant, BRCA mutant population. With that, I would conclude my talk. Thank you.
And when you address the open discussion, or this is last one, or still one, huh? Okay, I think the question will be
Thank you very much, Dr. Malkhair, for inviting us for this successful 16th Best of San Antonio. I did attend the first one as Dr. Ahmed. So the next session will be a discussion session by Prof. John Nawaltz. Prof. John is a professor of medicine, consultant medical oncologist at King Saud University Medical City in Riyadh. Prof. Jones, the floor is yours.
Yeah, thank you very much for the introduction, and thank you for Dr. Mulkhair. I have come here virtually since the first one, so it's fantastic to see the number 16. So I was asked to, in fact, look at the discussion of the 3 abstracts which were just presented and give you a little bit of a spin on what we have seen. So the first abstract, GS107, is addressing the issue of adjuvant CDK4/6 inhibitor. Well, starting well. So you have to turn your head to the left, and it's just showing here that there has been four randomized trials. In fact, from the Penelope you don't see, but the Penelope was 1 year of palbociclib versus no palbociclib in adjuvant setting. You see the second one, which is the Palace we're going to talk about. The Monarch E and the Natalie will get results in 24-25, so we are still some time to, so this is fantastic. So this is the Penelope B. The Penelope B, as you see, was a small trial done by the German group, where the randomization was in adjuvant setting. A high-risk patient was actually a palbociclib versus placebo patient having hormone therapy. At the beginning, in terms of PFS, in terms of DFS, sorry, we had the impression something was happening very early, saying, well, maybe there's some effect. And then the curve went back together and are not statistically significant. It raised the question that maybe longer will be better. I mean, the 1 year we were kind of frustrated with these curves. Then the Palace, and the abstract which was presented is referring to that. This is the final presentation by Michael Gnant. Huge trial. I mean, as you can see, it was presented. I'm just going to focus on what's important. The population was not only high-risk population, was medium risk, high risk. This is important because the number of events might be less, actually, than what you can see in a high-risk population. And the randomization was palbociclib 2 years versus no palbociclib, all that with endocrine treatment as hormonal background. Large number of patients, statistically speaking, I am also a statistician, it was fine. I think the hypotheses were okay, so, but huge. So this is the population is well balanced between the arms. Well, you look at the primary endpoint, you don't need to be a brilliant statistician to realize that there is no difference. I mean, even if your glasses are not clean, even from the back of the room, and indeed the hazard ratio is 0.96, and clearly, and confidence interval crossed the 1, and the p-value is 0.65, so it's not significant. The subgroup analyses are useless, as it was said, and the rest of the endpoints, secondary endpoint, are all negative. I mean, you look at it, including overall survival. So there is nothing. Safety-wise, seems interesting because I mean the safety was fine. I think always in development in metastatic we learn about the safety profile, and then when we know to manage safety profile in adjuvant setting, usually we see better. Although we have had some surprises. You remember the bone toxicity with AI, we missed it in metastatic, not long enough exposure. So it's always interesting to have a little bit longer exposure and to see, but here nothing new actually. So the summary, well, the summary is there's no difference. So 2 years of palbo doing nothing above hormone therapy. When you put that in the context, it's interesting because Monarch E, and we're probably going to talk about that here in this meeting. We'll have talks about that. Is a large-scale trial about the same scale. Scientific hypothesis is relatively similar. Except the population was only high-risk population. So this is something you need to notice, which means you'll have more events quicker, which means that you might be able to confirm. So large randomization between the abemaciclib plus hormone therapy versus hormone therapy alone. We have got an update at the ESMO, which was very interesting because the first presentation, I was kind of leery because we were starting to see a difference. But my feeling was follow what we saw with the first palbociclib trial. Maybe after stopping at 2 years, maybe the curves might come back together. So that's why, for instance, last year I was talking about it, saying, well, it looks interesting, but I have some reservations. What was presented at ESMO this year is much more interesting because here we are getting to a longer median follow-up and the curves do not seem to even have the tendency to come back, which means that this is becoming interesting. Subgroup analysis, nothing as usually. Adverse event in this trial didn't show anything significant neither, although the side effects are different than palbociclib. This slide was presented, and I like the way the speaker presented it because patient selection, definitively, they are not the same population. So one population is high risk, the other one is not, is moderate and high risk. So you have more events in a high risk, so you might have earlier capability to see a difference. The duration is the same 2 years between PALAS and Monarch E. But there is a big difference in terms of disease-free survival, invasive disease-free survival. Drug exposure, probably because there were more decrease of doses in the and interruption of treatment in the palbociclib trial. The drugs, I doubt that the drugs will make a huge difference. I mean, they are very, very similar in efficacy. Treatment schedule, yes, it could be a difference, actually. You will notice that abemaciclib is given on 4 weeks in a row, while palbociclib as well as ribociclib is 3 weeks out of 4. Maybe there could be a difference in a schedule. Well, the conclusion of that, well, I believe I changed my slide from last year. The situation starts to clarify. I think, so with, I mean, would the duration of exposure to CDK4/6 inhibitor be important? Maybe, might be. I mean, we have a trial, a Natali trial, which is 3 years of CDK4/6 inhibitor with ribociclib. So it's a very, very interesting. We'll see. I think discontinuation because of toxicity, it might have a role in the difference between the trials. Any patient profile, we don't know at all which patient profile to choose. There is no the subgroup analysis as usually retrospective are not giving any information. So in fact, the final conclusion is I think abemaciclib, the data is starting to be interesting. So that's something going to be subject of discussion. The second abstract, I will be quicker. Metformin early breast cancer. I know very well Pamela Goodwin as when we were in Canada. I mean, she presented. I was member of the NCIC. We were together with Taher, actually, member of NCIC when I was in Edmonton, in Alberta. Pamela Goodwin already in '94 was talking about this program. So it's a long program. I mean, so the background intellectually is very interesting. I mean, you see, okay, there is something maybe very, very interesting. So she was dreaming when I was in Canada. I left Canada in '99, so I went to US after that. But she succeeded, and she was talking about a trial already at that time. So she succeeded to launch a large-scale trial, which is good for her. The trial is potentially a huge trial, actually. Looking at metformin versus placebo. So nicely designed trial, actually, when you look at all the details, statistically speaking, I think it's well done. The problem is by the primary analysis, which is the most important, ER, PGR positive, regardless of HER2, which is already introducing an issue. And the second is follow-up of fertility result, ER/PR negative, and then the exploratory analysis, So, well, when you start to look at the main endpoint, well, again, you don't need to be a strong statistician to realize that there is nothing here. Hazard ratio 1.01. P-value indeed is not significant. Subgroup analysis, well, and patient distribution is fine. So negative trial for the main endpoint. The second, the follow-up fertility for ER/PR negative this time. Well, nothing neither. So we are really kind of disappointed, and I'm sure Pamela is probably certainly very disappointed. Then you get into exploratory analysis, subgroup of subgroup. So we are starting to, as a statistician, starting to say, ooh, it's becoming complex. Well, clearly there may be something. The only thing you can say, well, when you look at these results, well, you can generate an hypothesis, okay? So maybe, but you need validation trial, large-scale validation trial in this case, and complex. I'm ready to bet that NCI Canada is never going to finance this type of trial. So unfortunately for Pamela, but going to be time to retire, I guess. So conclusion, there's a veterinary thing. The last one is very interesting. This is a French program. And as you know, I'm French by birth, and I worked some years, I was trained there, and before moving to North America. And when coming from US, I spent 5 years in France, in a Kansas Center University setting. So I know very well this program. I know exactly where it's coming from. Budget from the French government, 10 million euros. So they really gave a lot of money for this program. It was already presented before. So I want you to read the title, Clinical Utility. This is the key, clinical utility. Do we have a clinical utility in this case of the genomic profiling in patients with metastatic advanced breast cancer? The rationale, again, is very interesting. I mean, I'm not going to detail. It was very well done by the presenter. But clearly, we take a tumor, you look at the genomic profile, and from there, can you identify, doing the full profile, a target, and then you use a drug to try to find something. You need to understand that this program was designed before we had evidence with alpelisib in the PI3 kinase mutation, before we had evidence, I'm talking clinical, clinical evidence in BRCA mutated with PARP inhibitors, olaparib. So it was done before. So you need to keep that in mind. Then the study design is very subtle study design, super complicated, like the French like to do. So speaking as a French, so they like things which are a little bit convoluted. So it's getting, in fact, to interesting questions. Fundamentally, when it was designed like 10 years ago, was interesting. But then the first problem is coming. The first problem is coming because just problem of number. So inclusion, 1,500 roughly, a little bit less than 1,500. Presence of targetable alteration, 646. So already you understand that virtually 2/3 are out. And then you end up using the all the criteria we talked about to selecting some subgroups. So PI3 kinase mutation. So and BRCA mutation and so on. So I mean, a certain number of mutations, but the actionability of these mutations are limited actually. And you end up with a trial. They do a pooled analysis. It's a pooled analysis on top of that of 238 patients, SCAT1 and 2, 115. So which means that, as I'm not a mathematician, only statistician, 1460, you end up at 115, it's 8%. So the first question is, whatever we found, is it worth to do NGS to everybody to get to 8%, while in between we learned that you do PI3 kinase mutation, BRCA mutation, you're going to target, and you have phase 3 trial, non-debatable phase 3 trial. So they very logically, when looking at the actionability of genomic alteration, they use the SCAT classification, which is logical. 1 and 2 is making sense. 3 to, beyond that, that make great sense. So, as genetic profiling clinical utility in patient, well, this is SCAT1, 2, 115 patients. Okay, there is something, as I ratio 0.41. Confidence interval upper below 1, p-value 0.001. But we know perfectly well that in there you have the PI3 kinase mutated who have been treated with alpelisib. You have the BRCA mutated who have been treated with PARP inhibitor. So compared to control, well, it's not a big surprise. When it was designed, we didn't know. This is what you have to have in mind. So we didn't know. When you go to the overall population where you pull that, with people who do not have exactly the same level of targetability. So you end up mixing, so you dilute, in fact, and that's the reason why it's not coming out. You have no power, it's not coming out. So when I look here at this point at the clinical utility today, for me, it's zero. I'm not going to do NGS to all my patients to end up giving, saying, well, this one is not PI3 kinase mutated, or I go straight to PI3 kinase mutation and BRCA mutation. I don't need that. So that's my first. So clinical utility. That's what I was insisting with clinical. Other subgroups has no interest. So, but the landscape, that could be potentially more interesting because here you look at, can we identify for further trial? So that's research, it's not clinical utility. It is identifying of something which may induce something. It is true that when you have patients on CDK4/6 inhibitor, they are relapsing, they're becoming resistant, very interesting to understand why. What is, in fact, biologically speaking, the mechanism, and can we identify a potential target to develop a new drug against that? That, for me, that's interesting. But it's not clinical utility, it's a research utility. It's a slightly different. So, well, here the same. I mean, clearly, compared to control, you give olaparib in BRCA mutated, it's working. So now we know. But you can identify again some alterations induced by the treatment, which you could target within the resistance to this treatment and this subgroup. So that's interesting in terms of research. So it should be dug in terms of research. Well, overall, the message I want to give, I don't agree with as clinical utility. I think it's useless at this point. We have more precise and more focused approach today, but in 2010 or 2011, when this program was thought about, it was advanced. But the problem they didn't get quick enough, and other work were done on those specific mutations or alterations. On the other hand, it can open what is interesting. It can open new ways to develop new drugs in targeting. But that's the only conclusion I think I can discuss. So I hope we'll have some time for discussion because I would like to hear your comment on that. Thank you very much.
Thank you, Prof. Nabels, for the nice presentation and discussion. So we can open now the floor for question. We have like 10 minutes before we move to the second part of the first session.
Question to be asked to the presenter as well. I will see what the question is.
To the professor, Nabhals, thank you very much for this discussion, but I still have questions about ballast trials. You mentioned that there may be a problem in the schedule of the palbociclib. You suggest some alternative schedule for this, or if we use different schedule in the metastatic setting, we may improve our income. Second thing about stratification based on the risk factors, because they included different risk groups. There is any data about this stratification and result in high-risk population, this trial? Thank you very much.
Yeah, to answer the first question about the schedule, I think I don't know. I think we noticed that that was a question raised, I mean, a comment raised that maybe giving in a constant way will be better, but we have absolutely no data, and there is a problem of toxicity, clearly. You can give abemaciclib over 4 weeks at the dose prescribed, no problem. With palbociclib ribo, we have neutropenia, which is a limitation. And I think the week off was in fact for the neutropenia to get better. I'm not aware of trials with lower doses in continuous. I mean, at the beginning they did it, but in terms of efficacy, we don't know. So they chose this one as the best compromise. So, but this is a comment which is raised. I mean, if you stop 1 week the drug, what's happening? I think we know in hormone therapy, we do not like at all to stop the treatments. I mean, so just question raised. Second question is subgroups. Well, the stratification was done in the right way. The problem is the CDK4/6 inhibitors, they work in all subgroups. So that's the problem. There is no, so high risk, low risk, it works. The hazard ratios are very, very similar. The problem is complex because after that, if you want to choose, if you don't have access to, for all patients, you want to choose, well, it is your own judgment. This is called the art of medical oncology. To give it to select a group. If you believe that the high risk group need more than the low risk group, yes. If you consider that if you give to the low risk group, you might give much more in terms of month of benefit than for the high risk group, it's the same. I mean, so what I'm saying, I don't have the answer, and we do not have any discriminant factor which would allow us to, for sure, scientifically select one subgroup compared to the other one.
But if you have any comment.
Well, I think Dr. Naples have answered the question, but to answer your question regarding the stratification, you know, I was asked, will you use abemaciclib in adjuvant setting with this small degree of benefit? And the answer is for very high risk patients, you assume that those who generated benefit are those with very high risk. So I would, for instance, in two disease where the risk of recurrence is very high, I would use that. But the stratification of high risk versus or in general high risk is controversial. Yeah. It's very controversial. Also, is it high risk and high grade and poor morphology, or just in two disease, for instance?
Yeah. At the same time, in this trial, the decision, for instance, in the Monarch E, to take only high risk patients as opposed to other risk, it was purely strategic. In the sense that you have higher number of events in the high risk sooner, so you can get potential differences sooner. In the Palace trial, they included moderate and high risk, which means that the number of events is much lower actually. So and time is you need more time to potentially see a difference. Although in the Palace, I'm not sure longer follow-up will show, because I mean this is really, I mean you cannot be closer. It's not equivalence, but not inferiority, and it's like so.
Thanks, Jean-Marc. I'm Dr. Tuejri, consultant medical oncology at King Faisal. Let's go back now. I think there is an issue about abemaciclib. Let's take the abemaciclib. And I strongly believe that abemaciclib has not only the CDK4/6 inhibitor, has more function and mechanism beyond that. And I think that the company, they have to find out what is that, because it is not limited to the CDK4 and 6. Now, when we are taking the three molecule in the metastatic setting, we find that the hazard ratio are almost the same. They are close. But I strongly believe that abemaciclib, and I cannot release any information more today, they have a function that beyond the CDK4 and 6, that it made the company use this compound with a compound related to the immune better than the using of the hormonal therapy. And Ahmed, he mentioned very important slide that how much it is potent for CDK4 has nothing to do with the CD6 at all. And again, I'm not going to comment on this. This is number one. Number two, for the early stage, as you mentioned, for the abemaciclib, there is a big strike with the international group of the KI67 against this approval by the FDA. And there is a very nice publication in the last 2 weeks about that. The reason for that, we are doing the KI67, you are doing the KI67, you are giving number, I am giving the number. In the same lab, we have the problem. Now, the problem with this clinical trial, FDA has been approved a kit for the CDK, for the KI67, which is called DixArray, which has not been used in this clinical trial. Number two, the local negative control has not been used in this clinical trial. The four characteristic of the FDA 1, 2, 3, 4 for the KI67 has not been used in this clinical trial. Yeah. So the question about the early stage, you have to wait. Now the cohort one, which is more than 4 positive nodes or tumor sizes +5 or plus whatever the grade, I may give my patient abemaciclib at that point, because this is a very high risk group. Doesn't matter what is the KI67, 20, not a 20, and so on. Now we will come to Andrea for the study which he has been done. He knows since 2014 and 15, he's just playing a game with this. And we know that. And now what happens with this issue, I have a patient now as we speak. I did NG-S for her, and the question has been asked Ahmed about can we do it or not, can we do it in patients selected like this. It has been done for one of my patients who is using at the King Faisal the Oncomine. We are looking for 130 gene. It is very interesting for this patient that she has 2 targeted action. One of them is fibroblast growth factor receptor 1. And the second one, which is the first time we see that, the HER3 mutation, This patient now in Paris with this guy, she's starting on the clinical trial for anti-HER3, okay, which is U124 clinical trial. And she received the first dose on last Friday. So question about when you use, not to use the next generation sequencing, it needs a lot of experience. This is genomic or a clinical utility, as you see, you don't agree, I don't agree also. At the end of the day, even they didn't tell us what he did, okay? Yeah. So now we come to Palace. I am in clinical practice for 30 years. We did a lot of good work together. John Mark, this is the first time in my life. You have 2,841 on balbociclib. You have 1,199 patients, 42.2 discontinued the treatment after 3 months. That's never heard in history of clinical trial. And I am surprised, I am surprised how they continue for all of this to follow a patient, where is Femara versus Femara, because, the bulbo has been removed, or tamoxifen versus tamoxifen, and bulbo has been removed, and give me a curve. I don't know what's this. Anyway, this is a comment for everybody to know about what is going on in that one.
That's the problem of trial design. I think the criteria for decreased doses and discontinuation were very, very stringent. They were so afraid that there will be something, which is something we see in randomized trial as opposed to clinical practice. So that's one of the problems of this trial. Yeah, I agree.
Thank you. So Dr. Dah.
In the back, Dr. Mustafa.
What?
Okay, go ahead, Dr. Dahash.
More or less, a lot of patients bring, they said this is profiling of my cancer. Now, they took a lot of money from them, and this is the problem. Profiling of those type of tumors, especially breast and others. Which type of profiling you will request for your patient Exactly, because what they get done is business. It's really a big fuss for us. Patient could have any tumor, and he brought about 100 and 200 papers, and this is my profile. Which one we should concentrate now for doing it, especially for breast or whatever, for the most common?
Yeah.
Because what's done in the business now, where is it done? I don't want to talk about this. We're getting a lot, we're not using it, in fact. Exactly. And it's waste of money, waste of time.
I totally agree with you, Dr. Dahish. I totally agree with all the comments have been made about the next generation sequencing. This is one of the limitations actually of this study. Actually, it was mentioned by the PI of the study that one of the problems that this trial did not address, what kind of technology should we use for next generation sequencing? We have now in the market a lot of tests. We have some of them testing for 50 plus genes, one of them 130 genes, one of them 350 genes. So most of these genes, to be honest with you, in clinical practice, we don't use, as clearly said by Professor Paulus, that we have only certain genes that we are looking for. And to be honest with you, in the clinical practice, I'm talking about myself, the only indication from clinical point of view to do NGS, that I'm looking for NGS that will combine all the genetic mutations that's known for this cancer type, and it might be cheaper than using doing individual genetic mutation for each gene. So this is the way that I look at the next generation sequence. Sometimes in some studies, it showed that next generation sequencing might be a little bit cheaper than doing sequential genetic testing for each specific gene. So if you have a genetic sequence kind of test that will test all of the genes that you're looking for, I think this might give you the answer. But to be honest with you, I agree with you. This study did not answer what kind of next generation sequences should we use in clinical practice.
I think I agree completely. We might have an interest, again, if you find R3 and you know they are doing a trial specifically targeting, then you can send the patient. So but for me, it's not clinical utility, it's research utility, so it's different. So here, I think it could be interesting because this patient with R3 mutation, well, what do you do? I mean, so there are maybe 2 trials in the world looking at that. So then she may, because we don't know, the trials are going on. So, but for the clinical practice itself, well, it's debatable, no? Debatable. So, okay.
We have a question online. And the final answer, a final question with you, Mustafa, but we'll just take this online question from Dr. Hiba Dawahri regarding if we use the CDK4/6 that in the and it will be standard in the early breast cancer, should we do PI3K for all cases in early setting upfront?
Well, at this point, we have data for PI3 kinase in advanced disease. So I'm not doing it in early breast cancer. So so again, what we have seen is research. I mean, it's so, and it's extreme in this trial was extremely advanced patients for the genomic. In the other trial, they didn't look at it. So, yeah.
Last question.
Thank you very much. So question to Prof and Dr. Ahmed, Dr. Tahir, about the PALAS trial. I think there is a recent publication about they factor for the discontinuation rate to affect the trial result, and they found that it didn't affect the result actually. It's just in JCO published. So would this change your mind about?
Yeah. Tahir, you want to answer? Yeah. An answer. Yeah.
Yes. Okay. So it has been on the 6th of January has been published in GCO about that. I don't myself believe in this recommendation because you have to use a sense of mind that a drug has been removed for 42.2, and at the end of the day, they say the two arms are similar, which is giving, let's say, letrozole versus exemestane or tamoxifen versus exemestane and so on. They try to do that. However, when they published the first one in Lancet of Oncology, and then, in the Lancet, 3 publications for the same issue of the question. They are contradicting themselves. So ballast trial, however, it is negative, and that's, as Professor Jamal said, maybe with the follow-up. But what type of the follow-up if you have almost 50% they are not on the medication? I don't know how you're going to use this molecule.
Yeah, you are right. I think the scientific hypothesis in this context is so downgraded that it will be extremely difficult to show anything. So the problem you might, and redoing a trial with a better approach, I don't think time-wise it's making sense.
And other things, and I love to understand how abemaciclib is working. Anything has been published so far on the CDK4/6 inhibitors, 50% are not right.
Okay. Thank you very much, Dr. Tahir and all the panel. So I think now we'll move to the second part of our press session today. And I'll invite Dr. Sami again to present the next speaker. Dr. Sami, please.
Thank you. It's my pleasure really to present our friend, Dr. Metaab Al-Fahidi. Metaab, he is the president of the Saudi Cancer Society and the representative of Saudi Arabia and IMAC. Dr. Metaab, I think he will announce about our next Pan-Arab, which will be in Jeddah next month. So Dr. Metaab, he is consultant adult medical oncology department at King Abdulaziz Medical City, Ministry of National Guard Health Affairs. Dr. Metaab, he will talk about the abstract GS204 aromatase inhibitors versus tamoxifen. Please, Dr. Metaab, the floor is yours.
Thank you so much, Dr. Sami, for your kind introduction. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi ta'ala wa barakatuh jami'an. Thank you so much for the organizing and the scientific committee for their kind invitation. And yes, Dr. Sami, actually we are in collaboration with the IMAC in the Saudi Oncology Society. We are inshallah going to conduct our annual meeting, which will be on March 23rd for 3 consecutive days, and you are all welcome to join us. So I have been tasked over the next 15 minutes to discuss with you the aromatase inhibitor versus tamoxifen in premenopausal women with estrogen receptor positive early stage breast cancer who were treated with ovarian suppression. And this is actually a patient level meta-analysis of 7,030 women in 4 randomized clinical trial. And this was presented by Rosie Bradley on behalf of the ABC TCG. So this is the author background. As you know that the tamoxifen reduced the 15-year breast cancer mortality by approximately 1/3 in the estrogen receptor positive disease. And we know also that the aromatase inhibitor are even more effective than tamoxifen in post-menopausal women, but these are ineffective in premenopausal women. However, the AIs may benefit premenopausal women treated with ovarian suppression. So a meta-analysis of individual patient data for 4 trials of premenopausal women with early stage breast cancer treated with ovarian function suppression and were randomized to aromatase inhibitor or tamoxifen. The primary outcomes were recurrence and cause-specific mortality, which was analyzed by the standard ABCG TCG statistical method, and the p-value less than 0.05 was used for significant level for primary outcome, and that compensate for the multiple subgroup investigation.
A p-value of less than 0.01 was also used for the subgroup analysis. So those are the 4 trials which were included in this meta-analysis. So just to remind you, the ABC-SG12 trial, which was started in 1999, the gozerline was used as ovarian function suppression, and 1,694 patients were randomized to anastrozole versus tamoxifen for 3 years duration with or without zoledronic acid, with a median follow-up of 8 years. The second clinical trial is the TEXT, which started in 2003, and the triptylene was used as ovarian function suppression, and 2,635 patients were randomized to exemestane versus tamoxifen for 5 years, and a median follow-up of 9.1 years. The third clinical trial is the SOFT, which was also started in 2003, and was similar in design to the TEXT with 1,998 patients and a median follow-up of 7.9 years. And then the HOBO trial, which was started in 2004 and used triptylene as ovarian function suppression, with 700 patients were randomized to letrozole versus tamoxifen for 5 years and a median follow-up of 5.3. So overall, there are 7,000 patients with 8 years median follow-up. So to look at these clinical trials in further details, the investigator listed when the chemotherapy was given for each trial. So in the Austrian trial, only neoadjuvant chemotherapy was allowed. So there was no adjuvant chemotherapy, and only 5% of women received chemotherapy. In the TEXT trial, chemotherapy was optional, and if it was given concurrently with ovarian function suppression, and 60% of the patient had chemotherapy. In the SOFT trial, chemotherapy was given before randomization, but the patient had to remain premenopausal after completion of chemotherapy, and 54% of the patient had chemotherapy. And lastly, in the HOPE, chemotherapy was actually given before randomization, and again, approximately 2/3, 63% of the patient had chemotherapy. So pulling together the 4 trials plotted is the time to recurrence. And as you can see on the horizontal axis, up to 10 years, and the vertical axis gives the rate of recurrence. And out of 7,000 women, 40% of the patients were node positive disease. So there was 2.8% absolute gain in any recurrence. So 14.7, as you can see, versus 17.5% favoring the aromatase inhibitor over tamoxifen in a premenopausal women with estrogen receptor positive disease receiving ovarian suppression. So this slide shows whether its current event are coming from, and it is split by each clinical trial. So overall, for the 4 trial, the rate ratio was 0.79, which gives a 21% average proportional reduction in the rate of recurrence. There was a borderline significant heterogeneity between the 4 clinical trials, with a p equal to 0.04, and this was mainly due to the anastrozole, which was appearing to have been no better than tamoxifen in the Austrian ABC-SG12 trials. This is the recurrence by the follow-up period since randomization, and it's split by year 0 to 1, 2 to 4 years, 5 to 9 years, and 10 years or more, 10 plus. The main benefit from the aromatase inhibitor and recurrence was actually seen in years N0 to 4, and the period when treatment actually differ. There was no further benefit or loss of benefit was seen in year 5 to 9, and there was actually little follow-up beyond year 10. So it's very hard to comment on that. What about the distant recurrence and the breast cancer mortality? So here we have the plots for the distant recurrence on the left and the breast cancer mortality on the right. There is actually significant reduction in the rate of distant recurrence with a rate ratio of 0.83, a 17% average proportional reduction in those women randomized to aromatase inhibitor with a median follow-up of 8 years. On the other hand, there was no apparent difference in the breast cancer mortality at the mean time. So when the investigator looked more closely of the timing of the breast cancer death, this is a plot by the follow-up period, and we can see that there was a trend toward fewer breast cancer deaths in years 0 to 4 with tamoxifen, and fewer breast cancer deaths in years 5 to 9 with aromatase inhibitor. And this really shows the importance of longer term follow-up. And there was a 13 analysis investigating the possible variability in the recurrence rate reduction achieved with the aromatase inhibitor within different subgroup. And just a quick reminder that the B of less than 0.01 was used for the level of significance. And as you can see that the proportional reduction in recurrence did not actually vary by age, body mass index, tumor size, tumor grade, histological subtype, and presence or absence of chemotherapy. And here we have a subgroup plot for the nodal status, and this is was split by the node negative, 1 to 3 positive node, and 4 or more positive node. So there was actually a trend for a diminishing efficacy with increasing nodal involvement, and there is no apparent benefit from aromatase inhibitor in 4 or more positive node, and the p-value for a trend was 0.05. There is actually no good reason for anticipating that the proportional effect of treatment might be different by these different nodal status category. But the overall proportional risk reduction for this meta-analysis was 0.79, which may provide a better guide to the reduction that would be achieved in different nodal status group than in each of the nodal status group individually. So we have here the 10-year plot for the risk of recurrence, which was split by the nodal status. So node negative on the left, node positive 1 to 3 on the right. So if the proportional reductions are similar in different risk category, then the absolute benefit from AI over TAM should increase with increasing risk category. Here we can see that doubling of the absolute gain of the aromatase inhibitor compared to tamoxifen from 2.4 on the left in the node negative to 4.8% in 1 to 3 positive node. So the finding we see in the 4 or more node positive disease was again unanticipated, and we know from the 2000 meta-analysis publication in the ABC STG meta-analysis that compared the AI and tamoxifen in post-menopausal women and showed no suggestion of any lesser benefit in node 4 or more positive disease. So what about the bone fracture and the non-breast cancer death? So the investigator had a plot for bone fracture on the left left-hand side and the non-breast cancer mortality on the right-hand side, and more fractures in women allocated to AI than tamoxifen. We can see at 5 years, the bone fracture incidence rate was 5% with the aromatase inhibitor versus a 3.8% with tamoxifen. And because this meta-analysis was carried out in a premenopausal women, few non-breast cancer deaths have actually occurred, and only 54 in total. And there was no actually difference in the rate of non-breast cancer deaths between the two treatment arms. So in conclusion, using aromatase inhibitor rather than tamoxifen in premenopausal women receiving ovarian function suppression reduced the risk of breast cancer recurrence by approximately 21%. The reduction in distant recurrence was 17%, but there was no effect on breast cancer mortality. There was no effect in the overall survival. Longer follow-up is needed to assess this effect. And there has been no increase in the non-breast cancer death, but there was more fractures in women receiving aromatase inhibitor. And this is the author acknowledgement. And with that, I would like to thank you for your kind attention.
Thank you very much, Dr. Mithab, for this very nice and concise and stick to the time presentation. We'll leave the discussion and question to the end. Now, it is my pleasure to introduce the next speaker. The next speaker is Dr. Jamal Zacchary. Dr. Jamal is a well-known medical oncologist. He's a professor of medicine at Al Faisal University, consultant medical oncologist at King Faisal Specialist Hospital and Research Center in Jeddah. He will talk about the GS205 randomized trial, comparison of adjuvant aromatase inhibitor, exemestane plus ovarian function suppression versus tamoxifen plus ovarian function suppression in the premenopausal women with hormone receptor positive breast cancer, update of combined text and soft trial. Dr. Jamal, without any further ado, mic is yours.
I have to press. Okay. Assalamu alaikum. Thank you very much for your kind attendance. Thanks to Dr. Al Khair for arranging this meeting for 16 years now. And of course, thanks for inviting me and giving me the pleasure in sharing this meeting with you. This study, or these two studies, have been presented and updated a number of times in the past. The soft and the text. Today, I will reiterate the presentation that was in San Antonio at the end of last year with a longer follow-up in a combination analysis, trying to answer a number of questions. As you know, there are 3 questions in the adjuvant setting in premenopausal women that have been answered by these studies relating to the question of the benefit of adding ovarian suppression to tamoxifen and whether ovarian suppression is best used with tamoxifen or with an aromatase inhibitor. In both of these studies, the aromatase inhibitor was exemestane. And the follow-up in this combined analysis is 12 to 13 years in each study. And this is a reminder of what each study is. The soft study, slightly more complicated, has 3 arms, tamoxifen alone, or ovarian suppression with either tamoxifen or exemestane. The text study is slightly simpler with 2 arms, whether tamoxifen and ovarian suppression or exemestane and ovarian suppression. Now, there are a number of questions to be answered by this combined analysis. The first question is, which is best, tamoxifen alone or with ovarian suppression? And I still remember myself asking this question to my supervisor, Rob Coleman, I think back in I think it was 1996 or something, and we didn't know the answer at that time. The second question would be tamoxifen versus exemestane and ovarian suppression, i.e. which is best? And the third question, using data from both studies, which is best, tamoxifen or exemestane, when combined, each one of them with ovarian suppression? And as you would gather now, there will be lots of data, lots of analyses, and too many numbers, and most of those numbers are small. So my presentation might sound to be a little bit boring. So this is a table looking at both studies and dividing patients whether they had chemotherapy or not in the adjuvant or in the neoadjuvant setting. And there are minor differences. And as you would expect, those decisions of giving chemotherapy were based on clinical criteria. So in patients who did not receive chemotherapy, we can see 21% in the text had positive lymph nodes and 9% in the soft had positive lymph nodes. And if we look at patients who received chemotherapy in both studies, we can see 20% of them in the soft were relatively younger than 35 years of age, but that percentage was 12% in the text. Now, looking at the very detailed analysis, and really the investigators have to be appreciated of what they have done. Too many numbers. Now this is the question of tamoxifen or exemestane with ovarian suppression, and as you can see here, this is showing absolute reduction in distant recurrence and death of about 1.4 and the death of 2.3% at 12 years at longer follow-up. Exemestane versus ovarian suppression versus tamoxifen, the absolute difference in recurrence was 3% and death was 2.6%. And that was in the soft study. And in combined analysis, and I have a problem here, there's something that comes up. How can we make sure that black thing doesn't disappear? Yeah. This is the combined analysis of soft and text. And if we look at the question of either aromatase inhibitor or tamoxifen, when either one of them is combined with ovarian suppression, we can see a 1.8% improvement in recurrence rates or distant recurrence and 1% reduction in deaths. Is there a trick I can make sure that that black thing disappears? الخط okay. Looking at patients, there we go, it's again. So I can't read the title because there are too many analyses and I get confused. كيف الخط الأسود نخليه يروح حركة؟ نعم؟ طيب كيف بشوف سلايد أنا؟ طيب. Okay, this is soft study. That's it. This is the soft study in patients who did not receive chemotherapy. There was about 9% of them were lymph node positive. You can see very small differences between exemestane and tamoxifen when both of them are combined with ovarian suppression in either recurrence rates or overall survival, and the outcome was very favorable in these patients. Looking at patients in soft who received prior chemotherapy, and 57% of them had lymph nodes positive, and of course soft had 3 arms. We can see in the 2 arms of the ovarian suppression, whether they had tamoxifen or exemestane, there's an absolute reduction in distant recurrence by 2.6% in favor of ovarian suppression in addition to tamoxifen compared to tamoxifen alone. And the reduction in death is 4.7%. in exemestane plus ovarian suppression versus tamoxifen, we can see a 4.5% reduction in recurrence and 4% in deaths. And I promise you, these are the highest figures you're going to see. So let's not get overexcited. In the combined analysis, looking at patients who received chemotherapy, and as we said, about roughly 60% of them had positive lymph nodes, we can see a reduction of about 2% in the soft and 2.4% in the text when exemestane and tamoxifen were compared, and both of them have the addition of ovarian suppression, and also about 2% or 2.6% reduction in deaths in the text, but not in the soft study. And again, to make things even more complicated, they are looking now at certain risk criteria, for example, HER2 subgroups in both studies, and the HER2 negative cancer patients, which are the majority of patients, had an absolute improvement in overall survival of 3.3% at 12 years when tamoxifen and exemestane were compared, and both of them received ovarian suppression. And again, for looking at HER2 status here, HER2 negative cancers were obviously the majority. And this is again additional analysis looking at other risk groups, for example, patients who received chemotherapy and those who didn't, patients of different age groups, trying to see if younger patients get more benefit with more intense treatment, i.e. the addition of ovarian suppression or changing exemestane instead of tamoxifen, looking at lymph nodes and tumor size and what have you. And as you can see, there is always some sort of improvement in traditional high-risk groups. When I say traditional, I mean clinical high-risk groups, like those who needed chemotherapy, whether neoadjuvant or adjuvant, those who are younger than 35, or those who had 4 lymph nodes or more, or those who had bigger tumors. However, as you can see, we need to appreciate that all the confidence intervals do overlap in these analyses. So I don't know if we can agree on one conclusion of this sophisticated analysis. Definitely I'm confused, but the summary of the investigators is that distant recurrences still occur, and we know that's the case in ER positive disease after a long time, and that there is meaningful relative reduction in the recurrence and deaths with the use of ovarian suppression with either tamoxifen or exemestane, and that requires appropriate selection of patients. And I think we all agree with that, but how can we base our selection? At the time of text and soft, the selection was based on clinical data that are now almost futile, because we have genetic tests like Oncotype DX that we use to select patients for chemotherapy, even in those who have N1 disease. So that is a challenge. We need to see how we're going to live with these data. And they see also reduction in distant recurrence with exemestane plus ovarian suppression versus tamoxifen and ovarian suppression is consistent in premenopausal women as it is in postmenopausal women. Emergent later survival improvement with aromatase inhibitor and ovarian suppression shows improvement of about 3.3% for those with HER2 negative disease who have received chemotherapy based on clinical criteria. I was certainly confused, but I understand the analysis is very deep, and the investigators have to be congratulated for their good work. Thank you very much.
Thank you, Dr. Jamal, for your excellent presentation. Now we'll move to our next speaker, Dr. Assam Murshid. Dr. Assam Murshid is a consultant medical oncology and chairman of oncology department in Prince Sultan Military Medical City in Riyadh. He will present for us abstract GS206, taxane with anthracycline versus taxane without anthracycline, an individualized patient level meta-analysis. Dr. Assam.
Thank you, Majid. بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وصحبه أجمعين. First of all, I'd like to extend my thanks to Dr. Malkhair and the organizing committee for the kind invitation and for the great success, mashallah, tabarakallah, for the 16th year in a row. The abstract that I was assigned to present is, as Dr. Al-Jahil said, taxanes with anthracycline versus taxanes without anthracyclines. This is a patient-level meta-analysis carried out by the early breast cancer trials group. And when you hear this name, of course, you will think about huge number of patients or large number of patients included. We know that anthracycline and taxanes represent the backbone and the fundamental of reducing recurrence in early breast cancer patients as a chemotherapy. Nothing comes free. We are concerned about the toxicity related to these agents. For example, cardiovascular toxicity, including congestive heart failure for patients receiving anthracyclines, as well as small proportion of patients who can develop leukemia in those patients. Taxanes, on the other hand, debilitating actually neuropathy can happen in these patients, and it may represent a problem. So what we are trying to do is not to combine toxicity together, but in the term of the overall survival benefit, of course, and the recurrence-free interval, which is better. Sometimes you may actually submit to a certain level of toxicity, bearing in mind the quality of life should be assessed in these patients. And over the past many years, we have seen that the inclusion of anthracycline in breast cancer protocols is being decreased, and that is based mainly on the issue of cardiac toxicity. In this meta-analysis, it's a better characterization of the benefit and risk of anthracyclines versus non-anthracyclines, taxane-containing combinations. It's a meta-analysis level data of patients. All patients actually received treatment before 2012, and these trials included at least a minimum of 6 cycles of chemotherapy in each arm, and the primary outcome was the recurrence and breast cancer specific mortality. Around more than 18,000 patients included in this analysis, and these trials were actually divided into 4 groups, A, B, C, and D. For group A, the use of concurrent 6 cycles concurrent taxanes plus docetaxel plus cyclophosphamide versus, which is the TAC regimen as we know it, versus 6 cycles of the same dose of docetaxel plus cyclophosphamide. And the number of these trials, of course, 3. In arm B, we have sequential use of taxanes plus docetaxel versus higher dose, not the same dose in the combination, higher dose of docetaxel plus cyclophosphamide, and this actually represents about 8 trials of those. Group C, we have taxanes plus anthracycline versus higher dose of taxanes plus capecitabine, and these were about 3 trials. Taxanes plus anthracyclines versus higher dose of docetaxel plus carboplatin, and this represents about 2 trials. And as you can see, the distribution of patients in this table for all trials, the majority of patients actually they have received sequential versus docetaxel plus cyclophosphamide, the TC versus the AC. In the combined analysis of these trials from A through to D, you will see there is a modest increase in, improvement in the recurrence-free survival for patients who received the taxanes plus anthracyclines, the same for, which is a small benefit, as you can see in the patient receiving in terms of breast cancer mortality. This is a forest plot of the all these trials, which will show you the differential benefit among the four arms. And as you can see, actually, the concurrent versus sequential may carry a better benefit. Looking into each two arms alone, A and B, as you can see, individual data provided for about nearly 14,000 patients with a median follow-up of just above 5 years. In those patients, almost 2/3 to 3/4 of those patients were ER positive, 61% in group A not positive versus 46% in group B, and a very small fraction of patients were HER2 positive. The reminder of the protocol used, concurrent versus the same dose of docetaxel plus cyclo, and the B arm actually sequential use of anthracycline Texans versus higher dose of docetaxel plus cyclophosphamide. The only difference between the two arms, the anthracycline used in group A were doxorubicin with a total dose of 300 versus 450, or the same dose of docetaxel. In arm B, the anthracycline used was perobicin with a cumulative dose of 300 versus 300 versus 450 of the docetaxel dose. As you can see, there is a significant benefit in terms of in favor of the concurrent for the in terms of local recurrence or recurrence. And as you can see, the benefit was almost about nearly 6%. There was, and in the sequential arm, actually, there is no noted benefit. As you can see, the two curves overlap each other. When it comes to breast cancer mortality, the same, there was a marginal benefit in terms of the concurrent treatment versus no observed benefit, if any, for the sequential arm. When it comes to the ER/PR receptors, both patients, actually, both groups, the positive versus the negative, there was a benefit for the concurrent or for the use of anthracycline versus non-anthracycline's arm, and the benefit was greater for the negative patients, for the ER negative patients. Again, the forest plot graph, as you can see here, the greater benefit was for the concurrent arm versus the sequential arm. Again, also, when it comes to the nodal status, surprisingly, those patients with little bit of less in the risk category, they benefited more from the concurrent versus those who had the sequential treatment. As you can see here, the node positive, they have actually more greater response or benefit compared to three lymph nodes, and the benefit was there, though a little bit less for the more than 4 lymph nodes. Toxicity, as you know, this is a meta-analysis, so it's not a patient-reported toxicity or quality of life. And the issue that we were looking at is the death related to treatment, for example, death for cardiovascular diseases or the incidence of leukemia. There was no significant difference between both. And unfortunately, as I said, this is not a patient reported system, which they cannot do it. It's each trial, they should go into their own reporting system. In conclusion, there was a 15% proportional reduction versus 2.5 absolute benefit for the invasive disease, invasive recurrence for anthracycline plus Texans versus non-anthracyclines chemotherapy, a much larger 42% proportional reduction seen with concurrent schedules of Texans, same dose in both arms, and the only difference was addition of anthracyclines. Little, if any, benefit for the sequential use versus higher dose of Texans in the control group, and the proportional reduction in recurrence did not differ based on the ER receptor status, so the benefit was there for both groups. Thank you very much.
Thank you, Dr. Asa. Dr. Sami, the mic is yours. If you can introduce the next speaker. Doctor. Dr. Sami, you are mute.
So it's my pleasure to present our colleague, Dr. Abdullah El-Tawargi. Dr. Abdullah, he is consultant medical oncologist at the Comprehensive Cancer Center, King Fahd Medical City in Riyadh. So Dr. Abdullah will present the abstract GS207. Please, Dr. Abdullah, the floor is yours.
Thank you so much for the introduction, and I would like to thank everyone, and thanks to organizer for being part of such activity. Start to feel that we are not in COVID with such physical attendance. So so this will be, can you just go back to the abstract? Yeah. So this abstract is the RxPonder, and I think many of you know the RxPonder trial. This is more kind of an update for this trial. The RxPonder, as you know, it's a phase 3 clinical trial that have addressed the role of chemotherapy or adjuvant chemotherapy for early stage hormone positive breast cancer in a node positive up to 3 lymph node. We have similar trial that has been done in Taylor X, which is the node negative, but RxPonder, it's more kind of a similar in a way to look for them, whether the node positive 1 to 3 lymph node, they do benefit from chemotherapy, especially for those who are up to 25. So this is more kind of an update trial. So as you know, that the clinical utility of 20 gene Oncotype DX is becoming established for node positive, given the fact that we have this data, and this has been already presented and published. A few years ago, we have learned from this trial that the chemo benefit is depend on a menopausal status. So for example, in a post-menopausal woman, we have seen that there is no chemotherapy benefit when it comes to both invasive disease-free survival as well as the distant relapse-free survival, which are the important endpoint that has been looked into this trial. Premenopausal, or the story in the premenopausal, is a bit different. We have seen that the chemotherapy or the chemotherapy is benefiting those patients with the premenopausal, whether the benefit was chemo or something have to do with the ovarian suppression support. So, and this is why they have looked at this kind of more analysis. At this abstract, they have did an update first for the 2 primary endpoint that has been looked, the invasive disease-free survival as well as the distant relapse-free survival. As well as they have done a new analysis, which is another endpoint, one of the secondary endpoint called distant relapse-free interval. And we'll come to the definition of that endpoint probably in the next few slides. They also have done kind of post hoc analysis just to look for the premenopausal subgroup, which represent 33% of RxPonder trial, and look at the question of ovarian suppression, whether this is have some kind of impact or not. And that's really, so this is kind of a review of the scheme of RxPonder trial. Those patients with hormone positive early stage 1 to 3 lymph node positive who are able to get chemotherapy or they are fit for chemotherapy, there has been looked at Oncotype or recurrence score up to 25. If they have recurrence score up to 25 and hormone positive 1 to 3 lymph node, they will be randomized to either endocrine therapy alone or chemotherapy followed by endocrine. There were included up to 5,000 patients in this trial with a number of stratification factors looking at the lower score or moderate score up to 13 or 14 to 25. Menopausal status is one of the important stratification factors, plus the axillary staging. Those who are more than 25, those are, we know that they need chemotherapy, and that's why they are off study and they have been treated with chemotherapy upfront. So this is the primary endpoint or the outcome or the endpoint that has been looked in this trial. We have heard more about the invasive disease-free survival, distant relapse-free survival, and those are the endpoint that has been reported a few years ago. And as you know, that the invasive disease-free survival is more kind of composite endpoint where you look at the different endpoint at the same time. The invasive disease-free survival, it's contain all invasive, local, regional invasive recurrence, plus also second primary. It also includes the distant recurrence, death from breast cancer or death from non-breast cancer, while the distant relapse-free survival, it's mostly looking at the distant, whether the distant recurrence or the death, whether from breast cancer or non-breast cancer. The only difference when it comes to the new endpoint that has been looked in this analysis is it's called the distant recurrence-free interval, and it's almost exactly similar to the distant relapse-free survival. The only difference in this endpoint, they have not included the death from other primary. So if they die from colon cancer or die from other primary, they will not be included in. So it's more kind of specific endpoint to the breast cancer from distant or death. The update from this trial, we have seen that probably the same thing. This is more update in this trial at 6 years, and we have seen when it comes to postmenopausal women, they don't benefit from chemotherapy in both endpoint, including the invasive disease-free survival as well as the distant free survival. You can see the curve is overlapping. There is no any difference when it comes to postmenopausal with up to 3 lymph nodes. So it's more kind of reassuring that probably when it comes to postmenopausal women, what they need is chemotherapy if they are node negative, and definitely if they are 1 to 3 lymph node. And chemotherapy probably will not add much to this subgroup of patient. But the dilemma we have is mostly with the premenopausal women, and we have seen with the earlier presentation that when it comes to premenopausal women, they do benefit from chemotherapy. And this was seen in both endpoints, the invasive disease free survival, where we have seen a kind of a 5% or 4.9 absolute benefit in favor of those patients who have received chemotherapy, and that's benefit was seen even with the longer follow-up. The same thing when it comes to a distant relapse-free survival, where we have also seen continued or persistent benefit. It's a bit lower than what we have seen with the previous, but still around 2.5% absolute benefit that was seen at 5 years, or distant relapse-free survival at 5 years in favor of chemotherapy. So it's almost a longer follow-up, but we're still seeing a benefit when it comes to chemotherapy. The new analysis, which is the disease relapse-free interval, it's something not different from the distant relapse-free survival. It's here they did not include the death from other primary. We have seen almost similar benefit when it comes to postmenopausal. Postmenopausal, they don't benefit from chemotherapy, and that's what we have seen with this endpoint. But when it comes to premenopausal women, we still see some same magnitude of benefit when it comes to premenopausal who are getting chemotherapy, around 2.4% absolute benefit for those who are getting chemotherapy. They did also kind of stratification, as you can see here, is those with a recurrence score up to 13, or those from 14 to 25. All those subgroup, they do benefit from chemotherapy, even though they have the low up to 13 recurrence score. If they are 1 to 3 lymph node positive, they still have achieved benefit when it comes to chemotherapy. We also have seen at this San Antoniao also a number of post hoc analysis with a special focus on a premenopausal women. Those are the post hoc analysis that has been included. The first one is the invasive disease-free survival in patients with what they call it the micromets, those with node positive, but they have micromets. Given the fact they 2014 they start to stop or excluding those patients, but we have probably a few hundred or 200 that were still micromets, and whether they have achieved benefit, given the fact they have a small volume disease. The other two analyses are mostly looking for a premenopausal woman to see whether there is difference when it comes to invasive disease-free survival between the ovarian function suppression, whether they have received ovarian suppression or not. The first one was mostly in the endocrine or in the endocrine therapy arm, and the other analysis was mostly looking at whether the absence or presence of menstrual period would have an impact on the benefit of chemotherapy for the premenopausal subgroup, and that's probably one of the questions that always we ask. How they do benefit. Do they benefit from chemo or from ovarian suppression? And I'm not sure if we have an answer from this analysis, but we will go over the data. The first analysis was the micromets. Those patients with premenopausal women, if they have micromets, whether they do benefit or not. And here we have around 206 of patients that already have micromets, and when they look at the analysis, whether they do benefit from chemotherapy or not, and you can see the benefit also is there. The benefit around 7.3%, but this is a small subgroup analysis, and but what we learned from this, I think even those with a small volume disease, we still have probably there is benefit from chemotherapy, even though they have a small nodal involvement, keeping in mind that this is we're speaking about a premenopausal woman, and this is almost similar to what we have seen with the node positive in general. In the node positive, we have seen around 5% benefit, and that's why. But when you look at the micromets, we have to keep in mind this is a small number. You can see the hazard ratio is 0.4, but we have a very wide confidence interval. So that's indicate that this is still a small subgroup. But it's hypothesis generating. The other concept that also has been looked further from those unplanned post hoc analysis is looking at the role of ovarian suppression. It's just trying to tease the data as much as possible in order to get some information about whether the ovarian suppression it's really have some impact on the benefit that we have achieved with premenopausal women. And this is probably something that they have looked at. The first thing, what is the overall the ovarian suppression rate that was seen in a premenopausal woman in both arms? Here, what we can see here in an endocrine therapy arm, there was almost 16% that were having ovarian suppression in the first 6 months, while 3% with the chemotherapy arm. This is from the first recruitment. With a longer follow-up, we can see that there is still around 14% with the endocrine therapy arm at 60 months, and around 6% with the chemotherapy arm. So yes, probably there is higher in the endocrine therapy that we have seen ovarian suppression, but the ovarian suppression rate is remain somehow low, and it's sometimes somehow it's consistent between both arms in this trial. When they look at the endocrine therapy arm, and when they look at the invasive disease-free survival and whether they have ovarian suppression or not for a premenopausal woman, though majority they were not in ovarian suppression, but when you look at the disease-free survival or invasive disease-free survival by chemotherapy or endocrine therapy, we haven't seen really much difference when it comes to premenopausal if they are ovarian suppressed in the first 24 months or not. This is, of course, in the endocrine therapy arm, and they have defined what's really what they mean exactly by ovarian suppression is medical suppression for at least 2 6-month time interval or bilateral oophorectomy in the first 24 months. So we haven't seen any difference when it comes to endocrine therapy arm per se, but ovarian suppression doesn't mean that patients are ovarian suppressed, and sometimes also having presence or absence of menstrual period have some impact on that. So they have looked at this, and when they looked at the rate of regular or menstrual period in premenopausal women versus in both arms, the endocrine therapy arm, the red one, and the blue one, the chemo, we can see that 50% of patients in the first 6 months, they still have a period, while 25 with the chemotherapy arm. With the longer follow-up, we have seen 18% in the endocrine therapy, while 9%. So yes, probably we have higher patient with preserved period and the endocrine therapy arm, but the rate of endocrine or regular period is decreasing over time. So the number is probably higher with endocrine, but with the follow-up, it's lower, and the same thing with chemotherapy. But it's high to start with when it comes to endocrine therapy arm. Does this have an impact on the invasive or 2-year invasive disease free survival by having the regular period or not when it comes to a premenopausal women? We have 2 analyses. The first one in the extreme left, which is the endocrine therapy arm. Here we have seen that when it comes to those patients who have period, around 40%, while around 60% they have no period. What we have seen here when it comes to endocrine therapy arm, there was numerically improved invasive disease-free survival in a premenopausal woman when it comes to endocrine, and the same thing we have seen with the chemotherapy arm. Here, probably when it comes to chemotherapy, there was more patients who have no period, around only 20%. In fact, they still have period, but majority they have no period. And the same finding was seen. Those who have no period, in fact, they have better invasive disease-free survival, definitely for premenopausal if they get chemotherapy. Probably it give you a hint that ovarian have something to do with this, but still this is kind of an unplanned subgroup analysis. It might not really answer this question quite well. So this is the conclusion. For this unplanned, for this updated analysis, we have seen a longer follow-up for postmenopausal, and I think we are assured that if they are up to 25 postmenopausal node positive, up to 3 lymph node, they don't benefit from chemotherapy. And that was clear even with a longer follow-up. We still have dilemma with the premenopausal women, but right now, what we know, it's up to 25. If they are positive lymph node, up to 3 lymph node, they still benefit from chemotherapy. And we have seen almost more than 40% decrease in invasive disease-free survival, distant relapse-free survival, as well as the distant relapse-free interval, that the one that has been presented this at this abstract. We have a number of exploratory unplanned analysis for a premenopausal in a very small subgroup of patients, including the micromets, which we have seen that there is also benefit given the fact this is a very limited number of patients. And we also have seen that when it comes to premenopausal, around 60% of them patients on an endocrine therapy arm, and probably 80% on the chemotherapy arm, they're stopping having menstrual period in the first 24 months. And that might have led to numerically improved invasive disease-free survival, and that was regardless of the treatment arm that they were included. Still, even those are still our unplanned analysis affecting a small subgroup. So the our responders are really not powered to look for those subgroup differences, and the data interpretation when it comes to premenopausal is not conclusive and probably challenging, and there are a number of factors, confounding factors. So we have to be cautious when we look at this unplanned analysis. It's really still unclear if ovarian suppression can replace the chemotherapy when it comes to a premenopausal woman with hormone positive, HER2 negative, with node positive breast cancer. And to answer this probably well, we need to have a randomized control trial just to get to the bottom of this question, which keep having every year. So thank you so much.
Thank you very much, Dr. Abdullah, for this very nice presentation and sticking to time. So now it's my pleasure to invite a discussant of the session, Prof. Olivia Pagani. Prof. Olivia is a well-known medical oncologist worldwide. She is currently clinical director of the SUMA and Swiss Certified Breast Unit of Southwestern Switzerland at Institute of Oncology. She is well-known leader in many international oncology organizations and also well-known principal investigator of many clinical trials. Prof. Olivia.
Hi, everybody. It's a pleasure to be with you. I would have liked to be there. I like Saudi Arabia very much. Omar knows that. So I hope next year I will be able to come, if you invite me, of course. So I will share my screen. And I just will go. Can you see my screen?
It's clear.
Yeah. Okay, so I will just go through the previous four trials presented, and these are my disclosures. I will start, of course, with the update on soft and text, not because I'm involved in, but I think it is important to set the scene as far as the other trials are concerned. So you know very well the design of this text and soft. What I just want to mention is that they are different trials, not only for the arms of randomization, but also because in the soft trial, women receiving chemotherapy, they received it before being randomized. And they needed to be premenopausal, so to resume menses before being randomized. In the text, women receiving chemotherapy received ovarian function suppression together with chemo. So this is a very important difference as far as women receiving chemotherapy are concerned. As well, the population of patients is different. Let's start with the soft and text no chemo cohorts. Of course, you can see that in these patients, they were lower risk, but still in the soft and test chemo cohort, there were 9% of patients node positive in soft and 21% of patients with node positive disease in text. As opposed, the prior chemotherapy cohorts were associated with a higher proportion of node positivity, a bigger tumor size, and more patients with grade 3. And as you can see, the soft chemotherapy cohort included a slightly lower risk population. So this is to say they are not the same population, and this can explain to a certain extent the results that we found. The results presented by Meredith Reagan in San Antonio were a 12 and 13 median follow-up. So I just wanted to focus on the overall survival because this is, I think, is the most important message from these trials at this longer follow-up. So let's start with soft. 35% in the overall population were node positive and 12 years median follow-up. And you can see here that at longer follow-up in soft overall population, there confirms to be an overall survival improvement by escalating treatment from tamoxifen alone to tamoxifen plus OFS or OFS plus exemestane. And you can see, and this is very important, that the hazard ratio over time improved. It was 1 at less than 5 years, and now it is 0.7. In the soft and test combined analysis, patients at higher risk, a slightly longer follow-up, you can still see that in the overall population, there is no benefit by giving exemestane instead of tamoxifen plus OFS. But once again, the hazard ratio over time is improving. And this is a general message. So you need also in premenopausal women with ER-positive disease, long-term follow-up, because events and the outcomes as well tend to change over time. And the second very important message is that recurrences and deaths still occur long-term, which we know also in the postmenopausal population. So let's now talk, and these were, as opposed to other trials, pre-planned subgroup analysis. So the no chemotherapy cohorts, so low-risk patients, investigators decided they didn't need chemotherapy. In soft, as mentioned before, 9% were not positive. And you can see here that there is very small benefit, if any, in escalating endocrine therapy. These women do very well, despite some of them were not positive, without chemo and with tamoxifen alone. So these are the women in which you don't need to give ovarian function suppression. And the same is true in the soft and text combined analysis. 21% in text were not positive. You can see here a very small benefit in giving exemestane over tamoxifen in the presence of ovarian function suppression. Then the picture changes in women in the chemotherapy cohorts. In the soft trial, so higher risk population, you can see that there is a benefit which can be as high as 4.7%, the absolute benefit in giving tamoxifen plus OFS instead of tamoxifen alone. And the same is true in the soft and text combined analysis in overall survival. And the benefit is present also in disease-free survival and distant relapse-free interval. And you can see that in text, you start to see a 2.6 improvement in overall survival. What is going on in soft, in our opinion, is given by the heterogeneous population and the lower risk population, as I mentioned before. Then we looked also at HER2 status, and you can see here that in HER2 negative patients, you have a clear benefit of the exemestane over tamoxifen in the soft and text combined analysis. In the HER2 positive population, we will run a specific analysis on them. The picture is quite complex for many reasons, but overall we can say that ovarian function suppression is very important in these women, but apparently there is not such a big improvement by giving exemestane. And then another very important population in the majority of patients, 86% HER2 negative, at 12 years median follow-up, you can see in the combined analysis that a very substantial 3.3 absolute improvement emerge by giving exemestane over tamoxifen in the presence of ovarian function suppression. So there is a benefit which is emerging over time in soft and text. And we looked also at higher risk population in soft, women who received neoadjuvant chemotherapy, in women younger than 35, in women with more than 4 positive nodes, bigger tumors than 2 centimeters and grade 3. In all this population, it's worth escalating endocrine therapy from tamoxifen to exemestane plus OFS. So let's move to the other presentation in this group, which was the Oxford meta-analysis on the role of aromatase inhibitors in premenopausal women in the presence of OFS, 6,030 women. 4 trials were included. The biggest population was those of text and soft. There are some differences in the Austrian trial. The OFS with the goserelin was given for 3 years, and then the small Italian trial was included. What is really very important in this analysis is that the median follow-up is shorter than in the updated soft and text, so it's 8-year median follow-up. So these data for soft and text are those who were already presented in 2018, so they were included in this meta-analysis. What are also the difference in terms of chemotherapy? The Austrian trial is a very low risk population. Only 5% of them received chemo. In text, concurrent with OFS, 60%, and in soft, as mentioned before, as mentioned before, chemo first and then randomization, 54%, and HOBOE, 63% received before randomization, like in SOFT. So which are the results? The distant recurrence is improved by 1.9% at 10 years if you give an aromatase inhibitors instead of tamoxifen in the presence of ovarian function suppression. And this is almost what we saw in text, and didn't show you, but Meredith showed that in San Antonio. There is no improvement in breast cancer mortality. And I interpret that as to be related to a shorter follow-up. As I showed you before, the improvement in the combined soft and text in overall survival emerged only with this longer follow-up. Then they did a little bit what we did already to show according to the risk of relapse, and they decided to look at nodal status. And you can see that the recurrence overall, it is 2.4% in node positive. It was 2.8% in the overall population, and of course is doubled in women at higher risk of relapse. So what we already said, with different characteristics, not only nodal involvement. Bone fractures, of course, are increased if you give an aromatase inhibitors, but what is really reassuring, and I had no time to show, but it's also shown in soft and text, is that the non-breast cancer death is not increased. So the worry of giving aromatase inhibitors to premenopausal women in terms of cardiovascular risk are not supported by data. So let's move to the Eric-Sponder trial, which was discussed by the last speaker. So this is the design. I won't go into the details just by saying that all these analyses have very large confidence intervals, and all the subgroup analyses were not pre-planned and with really low numbers of patients. What I wanted to focus on is the latest analysis that they did according to the OFS rate. As you can see here, very few women premenopausal receiving chemotherapy developed chemotherapy-induced amenorrhea, and the rate of ovarian function suppression was low. Only 14% of these women received ovarian function suppression in the first 2 years. And as it was discussed already in San Antonio, this is just at 2 years. So this is a work in progress. We don't know how this, of course, changes over time, because these women do get older. And what they did look also, it was if the invasive disease-free survival did change in the endocrine therapy arm in women who were amenorrheic by chemotherapy effect or by treatment, and apparently there is no difference. But as it was already discussed, both in the endocrine therapy alone arm and in chemotherapy plus endocrine therapy, the women who developed, for whatever reason, developed amenorrhea just because they received chemo or because they received OFS, did better than those who did not. So this is reinforcing the concept that, at least in part, the benefit of chemotherapy in young women is associated by endocrine effects. And the conclusions were that overall premenopausal women do benefit from the addition of chemotherapy in all the endpoints they looked at, that this subgroup analyses were not powered and not pre-planned, and so they should be interpreted with caution, and it remains unclear if the OFS can replace chemotherapy. Unfortunately, the third trial that we tried to do, the PERK trial, in women randomized to receive chemo or not in the presence of ovarian function suppression, did close early due to insufficient accrual. I wonder if another trial with such a power will ever be conducted, but I think it is important also taking in mind all these genomic tests, which could help in selected patients. And just as a last slide in this talk,
You are muted now, Dr. Prof. Olivia.
It seems that she lost the connection.
Yeah, okay. So it seems that's Prof. Olivia disconnected. So
I think we can take some questions unless she reconnect with us.
So we can open the question now. Yeah.
Assalamu alaikum. Thank you for the excellent event, as usual. I have two questions. The first one regarding the use of AI with ovarian function suppression in a very young woman who's less than 35. Shall we go for the biochemical test for them before starting AI or just to start? The other question for Dr. Isam, from this meta-analysis regarding the use of concomitant anthracycline and taxane, shall we go back to old regimen like FEC or FAC instead of sequential?
Okay. Dr. Metaib, if you would like to answer this question. Yeah, the first.
Thank you so much for your question, Doctora. So the first question is, in very young patient aged less than 35 years or less, should the combination of AI plus OFS is beneficial? And should we do serial testing of the hormonal assay? So the answer yes. It's the clinical data of the soft text clinical trials showed that the benefit of exemestane AI plus the ovarian function suppression was actually profound in the very young patient. And we know that those young patients, they have a risk of approximately 1/3 that they will develop disease relapse. And the benefit actually is 13% benefit and absolute gain, which is really very huge number. So how do we do the serial testing? So usually it depends if you are going to start the concurrent LHRH with the chemotherapy or if you are going to start it after completion of the chemotherapy, as shown by the Olivia in the text trial, the LHRH was started concurrently while conducting the chemotherapy, while in the soft trial, the LHRH was used in those patients who completed chemotherapy and they were premenopausal. And I think there is a controversy between doing the serial assay, but really I think that in those very young patients, we should do the hormonal assay with the estradiol and FSH. And also we should avoid using the long-acting LHRH, for example, the every 12 weeks in those young patients. So we should use the every 28 days LHRH injections.
Okay. Second question, Dr. Hassan. Thank you, Dr. Mete. Okay. Thank you very much. Just to clarify, the trials that we're looking at, the use of Texans versus docetaxel, excluding the use of 5-fluorouracil. So 5-fluorouracil, which is part of the FIC and FAC regimens, are not part of this, and we know that there is no added benefit for adding 5-fluorouracil in breast cancer patient in the adjuvant setting or neoadjuvant setting. This is one point. The other point is that we cannot actually conclude from this analysis based on the old data. All the protocols were included patients before 2012. And we know that since then, so many things changed, and the dose, like the introduction of the dose dense, the use of, though a small fraction of patients were included with HER2 positive, the use of anti-HER2 treatment, etc. So whether we go back into the more intense regimens like TAC might be an idea, but I don't think that we conclude this from this analysis. Based, as I said, on the differential differences in the chemotherapy before 2012 and after 2012. But the reassuring thing is that the concurrent might be better if your patient can tolerate it, and this is individual decision. Those with very high risk, like 4 lymph nodes and more, actually the benefit was less than those with less numbers of lymph node compared to the maximum benefit was for the node negative, surprisingly. So I don't think still these answers are not very, these questions are not very well answered. The other thing is that definitely sequential might not be a good idea alone. But the use of dose dense might overcome this, and we know that the benefit of dose dense AC every 2 weeks. So I don't think that we can draw very solid conclusions out of this analysis that might, as all the early breast cancer trialist group work, because it was based on cohort of patient in early days, and it's only for some form of historical control. This is in my belief.
Thank you, Dr. Hassan. We have a question here. Yeah.
Thank you so much for all the speakers for this interesting review. My question for Dr. Mete and Dr. Jamal Zacchary regarding combination of aromatase inhibitor with ovarian suppression is better than tamoxifen, but in practical point of view, if as you know, all recommendations now favor the use of extended adjuvant endocrine therapy more than 5 years. For practice, can we go for aromatase inhibitors with ovarian suppression for more than 5 years as per recommendations, especially for young patients?
Dr. Jamal?
Shukran, thank you. Thank you for the question. I think there is there are two different questions and scenarios. Looking in general, extending the aromatase inhibitor treatment to probably 8 years at least is favorable in certain subgroups, and there are a number of studies, including some presented in ASCO, showing that maybe 5 years is not enough. And there was also a meta-analysis. So maybe 8 years will be suitable. Practically, how long we should continue ovarian suppression is an important question, not only based on data, but also practicalities. We know we use ovarian suppression LHRH agonists in women who are probably already postmenopausal because of chemotherapy induced ovarian suppression. The women in the clinic have challenges in tolerating monthly injections for long period of time. And I have some women who refuse it from the offset. So the question of how long we should continue the ovarian suppression by LHRH agonist in the practical session is also important. But I think a minimum of 3 to 4 years is indicated, and maybe a maximum of 5 years. But I think we need to continue in patients at least with high risk, like positive lymph nodes with aromatase inhibitors, for maybe 8 years. Thank you. If that answers the question, thank you.
Yeah, so I just would like to comment. I agree with Dr. Jamal that the duration, and we have now Olivia, the duration of the LHRH is not confirmed. So we have the Astra, the small clinical trial, which tested the duration for 2 years. And we saw from the meta-analysis, the Austrian ABCSG for 3 years and the soft and TIX for 5 years. So I think there is, I think it's very important to recognize that there is no evidence beyond 5 years. So using the LHRH for the well-conducted 5 years or between 2 and 3 years. Professor Naji Saghir, he has a question or comment.
Hi, hello, marhaba, and thank you. Nice to see you again. I wanted to ask a question and a short comment, if you allow me, and I hope Olivia is back also with us. I have to say that I was confused at San Antonio when I was listening to soft and text updates, and I'm still confused. You know, we're not sure really what should we change. We have been following the initial recommendations. Patients who require therapy, they benefit from ovarian function suppression. Better to give exemestane. Now, the patients who do not need chemotherapy are very well selected by, you know, MIND-ACT or Oncotype DX. So we know they are at very, you know, low risk. Initially, you said below age 35, they benefit from ovarian function suppression. Should we change this? Maybe if they have a low Oncotype DX, low MIND-ACT, maybe they can do well only with tamoxifen. And the other thing I'd like to ask you, if a woman is 48 or 40, close to menopause, I tend to try to avoid ovarian function suppression because with a short course, even chemotherapy, they will not have their menses. Sometimes I believe that, you know, 6 cycles of CMF is much less toxic than 5 years of ovarian function suppression. So really, we have to balance things out, but I'm not sure what to change this new presentation.
Hi, can I speak? Can you hear me?
Please.
Yeah, I don't know when I disappeared, so I don't know what you heard, but because I didn't realize I disappeared till the end.
Oh.
So I think that Naji, as usual, made very good points. Just to go back to duration, I think that in soft and text, we have approximately 20% of women who had extended treatment, but none of them with OFS. Those who extended went on with tamoxifen alone. We will comment this in the papers, but we do not have the outcome of these women yet, because it's very difficult to pick up in long-term follow-up. So we have no data in OFS extension. I think that overall, women who are, like in the Austrian trial, at low risk of relapse they do not need to go beyond 2 or 3 years. In women at higher risk of relapse, I think you need to go for 5 years. And the higher the risk, the higher the benefit with an aromatase inhibitors. I think that what Meredith wanted to highlight is that the benefit of the aromatase inhibitor started to emerge, but very slightly at the 9 years median follow-up. But it is quite clear now in the HER2 negative, the majority of patients, women who received chemo. There is a 3.3% absolute benefit in overall survival in these women, which is significant and did not occur with the aromatase inhibitors in postmenopausal women. So this is the most important message. HER2 negative.
Oh, sorry. Yeah. I wanted to ask you if you can comment on the patients who have low ERPR, 5 to 10%, for instance.
Yeah. This
benefit
is
from ovarian function suppression, eczema
yes.
stain. Or...
Yes, we really don't know. We didn't run this analysis. I think that, of course, the benefit in low ER and PGR is doubtful. We know there is a benefit, but I agree, we don't know if the additional toxicity of OFS is really worth. Going back to the very young women, please keep in mind that despite being the biggest trials, in soft and text, we had only 500 women less than 35 overall. And 94% of these women received chemo because very few investigators were confident in not giving chemo to these women because they are considered at high risk. So I think the picture there is really very confused. I had a meeting with Chinese colleagues in the beginning of this week. I encourage, I don't know if you in Middle East can do that, but I encourage countries in which very young women are a big population to run this kind of trials. In Western countries, we will never be able to run countries specifically in very low women. But overall, the benefit of ovarian function suppression is the highest in women less than 35, irrespective of all the rest. I don't know if I answered, Naji.
Yes, very clear. You want to ask? You want to answer one more question?
Yeah, of course.
Role of eczema stain versus tamoxifen in patients with HER2 positive disease.
So this we are discussing because we are, as you can imagine, we are writing the papers and we are discussing. So there is a big problem because, as you know, soft and text started in 2003. So only 50% of women HER2 positive received Herceptin. So this is the first confounding factor. And then there is a difference also between soft and text patients who received Herceptin or not, according to country as well. The timing where countries enroll patients over time, they decided, for example, in many European countries, when Herceptin was available, they decided not to enroll HER2 positive patients. So the picture is really complex. We are going to publish another paper in HER2 positive patients. And so we are decided to focus on HER2 negative. But overall, also at this latest follow-up, it seems that these patients do need ovarian function suppression. And then, despite they are considered to be at higher risk in general, the benefit of exemestane, if there, is not huge. So I think a very good treatment for these women is OFS plus tamoxifen. But maybe we will change our position when looking in more details. But remember, they are just 14% of the population, so the numbers get smaller.
Okay, thank you all. And for sake of time, we have to conclude this session. I would like to thank all the speakers and the moderators who are running the first session. And we will have a break for 20 minutes. So we'll be back on 5 p.m. Thank you.
Thank you, and sorry. Bye. Bye-bye.
Hi, Olivia.
Bye. Hi. Sorry for the inconvenience. I don't know what happened.
No problem at all. Nice to see you always.
Yeah, yes, of course. See you next time. Bye. Bye-bye.
It was excellent session. Thank you.
مع السلامة.
دكتور علاء كيف حالك؟ اشتقنا لك دكتور.
الله يخليك، ازيكم؟ انا وحشنا كثير والله، جدا جدا. نجي متعب، هي اخباركم؟ اهلا بيكم، اهلا بيكم.
ان شاء الله قريب.
Multinational pharmaceutical company that has been in business for nearly 3 decades. We were born in Foster City, California, which is the heart of the Silicon Valley. We are now present in over 35 countries. We have pioneered more than 25 breakthrough drugs in the last 30 years, approved by the FDA. Over 14 million people have access to Gilead drugs in low and middle income countries alone. We focus on virology, antifungals, oncology, cell therapy, and inflammation. And how is Gilead doing in the Middle East? Gilead Sciences has expanded its presence in the Middle East by opening a second office in Saudi Arabia. Between Gilead and its partners, around 100 people work to support the 12 markets we serve, and we have over 50 market authorizations in the region. What do we want to achieve both globally and in the Middle East? In medicine, we believe that our mission is to make the impossible possible. Only in this way will we be able to fulfill our vision of creating a better and healthier world for all people. Our aim is to develop and release 10 more medications in the next 10 years, along with the 25 we have already launched, to be a preferred partner for both the ecosystem we serve and our employees, and to create long-term value in a responsible way. We are studying viruses and virology, transforming HIV, as well as developing a portfolio of drugs for viral hepatitis B, C, and D. The COVID-19 public health problem is being addressed. Imagining a world in which cancer may be cured, Gilead is bringing oncology innovation to patients suffering from triple-negative breast cancer, bladder cancer, lung cancer, and other solid tumors. Gilead Therapeutics has built an internal pipeline with 13 tailored transactions to access external innovation in the last 2 years. These support mechanisms create less stress for the oncology team while allowing them to devote more time to other patients who are currently on active treatment. Gilead has partnered with Kite, a leader in cell therapy, to become the first company to have a cell therapy franchise with over 3,800 patients treated. The largest worldwide network with over 200 accredited treatment clinics spread over 18 countries. It has a strong research portfolio and significant relationships that allow for innovation across a wide range of cell therapy targets and modalities. The aim is to improve access, affordability, accessibility, and less unnecessary red tape for patients and their families. A story that many of you may not be aware of. In ancient times, there was a tree in the ancient world. Its resin had medicinal properties. This resin was used to make Gilead's balm, and it was the origin for our name. Gilead Sciences is a multinational biopharmaceutical company that has been in business for nearly 3 decades. We were born in Foster City, California, which is the heart of the Silicon Valley. We are now present in over 35 countries. We have pioneered more than 25 breakthrough drugs in the last 30 years, approved by the FDA. Over 14 million people have access to Gilead drugs in low and middle income countries alone. We focus on virology, antifungals, oncology, cell therapy, and inflammation. And how is Gilead doing in the Middle East? Gilead Sciences has expanded its presence in the Middle East by opening a second office in Saudi Arabia. Between Gilead and its partners, around 100 people work to support the 12 markets we serve, and we have over 50 market authorizations in the region. What do we want to achieve both globally and in the Middle East? In medicine, we believe that our mission is to make the impossible possible. Only in this way will we be able to fulfill our vision of creating a better and healthier world for all people. Our aim is to develop and release 10 more medications in the next 10 years, along with the 25 we have already launched, to be a preferred partner for both the ecosystem we serve and our employees, and to create long-term value in a responsible way. We are studying viruses and virology, transforming HIV care, as well as developing a portfolio of drugs for viral hepatitis B, C, and D. The COVID-19 public health problem is being addressed. Imagining a world in which cancer may be cured, Gilead is bringing oncology innovation to patients suffering from triple-negative breast cancer, bladder cancer, lung cancer, and other solid tumors. Gilead Therapeutics has built an internal pipeline with 13 tailored transactions to access external innovation in the last 2 years. These support mechanisms create less stress for the oncology team while allowing them to devote more time to other patients who are currently on active treatment. Gilead has partnered with Kite, a leader in cell therapy, to become the first company to have a cell therapy franchise, with over 3,800 patients treated. The largest worldwide network, with over 200 accredited treatment clinics spread over 18 countries. It has a strong research portfolio and significant relationships that allow for innovation across a wide range of cell therapy targets and modalities. The aim is to improve access, affordability, accessibility, and less unnecessary red tape for patients and their families. A story that many of you may not be aware of. In ancient times, there was a tree in the ancient world. Its resin had medicinal properties. This resin was used to make Gilead's balm, and it was the origin for our name. Gilead Sciences is a multinational biopharmaceutical company that has been in business for nearly 3 decades. We were born in Foster City, California, which is the heart of the Silicon Valley. We are now present in over 35 countries. We have pioneered more than 25 breakthrough drugs in the last 30 years, approved by the FDA. Over 14 million people have access to Gilead drugs in low and middle income countries alone. We focus on virology, antifungals, oncology, cell therapy, and inflammation. And how is Gilead doing in the Middle East? Gilead Sciences has expanded its presence who are currently on active treatment. Gilead has partnered with Kite, a leader in cell therapy, to become the first company to have a cell therapy franchise, with over 3,800 patients treated. The largest worldwide network, with over 200 accredited treatment clinics spread over 18 countries. It has a strong research portfolio and significant relationships that allow for innovation across a wide range of cell therapy targets and modalities. The aim is to improve access, affordability, accessibility, and less unnecessary red tape for patients and their families. A story that many of you may not be aware of. In ancient times, there was a tree in the ancient world. its resin had medicinal properties. This resin was used to make Gilead's balm, and it was the origin for our name. Gilead Sciences is a multinational biopharmaceutical company that has been in business for nearly 3 decades. We were born in Foster City, California, which is the heart of the Silicon Valley. We are now present in over 35 countries. We have pioneered more than 25 breakthrough drugs in the last 30 years, approved by the FDA. Over 14 million people have access to Gilead drugs in low and middle income countries alone. We focus on virology, antifungals, oncology, cell therapy, and inflammation. And how is Gilead doing in the Middle East? Gilead Sciences has expanded its presence in the Middle East by opening a second office in Saudi Arabia. Between Gilead and its partners, around 100 people work to support the 12 markets we serve, and we have over 50 market authorizations in the region. What do we want to achieve both globally and in the Middle East? In medicine, we believe that our mission is to make the impossible possible. Only in this way will we be able to fulfill our vision of creating a better and healthier world for all people. Our aim is to develop and release 10 more medications in the next 10 years, along with the 25 we have already launched, to be a preferred partner for both the ecosystem we serve and our employees, and to create long-term value in a responsible way. We are studying viruses and virology, transforming HIV care, as well as developing a portfolio of drugs for viral hepatitis B, C, and D. The COVID-19 public health problem is being addressed. Imagining a world in which cancer may be cured, Gilead is bringing oncology innovation to patients suffering from triple-negative breast cancer, bladder cancer, lung cancer, and other solid tumors. Gilead Therapeutics has built an internal pipeline with 13 tailored transactions to access external innovation in the last 2 years. These support mechanisms create less stress for the oncology team while allowing them to devote more time to other patients who are currently on active treatment. Gilead has partnered with Kite, a leader in cell therapy, to become the first company to have a cell therapy franchise, with over 3,800 patients treated. The largest worldwide network, with over 200 accredited treatment clinics spread over 18 countries. It has a strong research portfolio and significant relationships that allow for innovation across a wide range of cell therapy targets and modalities. The aim is to improve access, affordability, accessibility, and less unnecessary red tape for patients and their families. A story that many of you may not be aware of. In ancient times, there was a tree in the ancient world. Its resin had medicinal properties. This resin was used to make Gilead's balm, and it was the origin for our name. Gilead Sciences is a multinational biopharmaceutical company that has been in business for nearly 3 decades. We were born in Foster City, California, which is the heart of the Silicon Valley. We are now present in over 35 countries. We have pioneered more than 25 breakthrough drugs in the last 30 years, approved by the FDA. Over 14 million people have access to Gilead drugs in low and middle income countries alone. We focus on virology, antifungals, oncology, cell therapy, and inflammation. And how is Gilead doing in the Middle East? Gilead Sciences has expanded its presence in the Middle East by opening a second office in Saudi Arabia. Between Gilead and its partners, around 100 people work to support the 12 markets we serve, and we have over 50 market authorizations in the region. What do we want to achieve both globally and in the Middle East? In medicine, we believe that our mission is to make the impossible possible. Only in this way will we be able to fulfill our vision of creating a better and healthier world for all people. Our aim is to develop and release 10 more medications in the next 10 years, along with the 25 we have already launched, to be a preferred partner for both the ecosystem we serve and our employees, and to create long-term value in a responsible way. We are studying viruses and virology, transforming HIV care, as well as developing a portfolio of drugs for viral hepatitis B, C, and D. The COVID-19 public health problem is being addressed. Imagining a world in which cancer may be cured, Gilead is bringing oncology innovation to patients suffering from triple-negative breast cancer, bladder cancer, lung cancer, and other solid tumors. Gilead Therapeutics has built an internal pipeline with 13 tailored transactions to access external innovation in the last 2 years. These support mechanisms create less stress for the oncology team while allowing them to devote more time to other patients who are currently on active treatment. Gilead has partnered with Kite, a leader in cell therapy, to become the first company to have a cell therapy franchise with over 3,800 patients treated. The largest worldwide network with over 200 accredited treatment clinics spread over 18 countries. It has a strong research portfolio and significant relationships that allow for innovation across a wide range of cell therapy targets and modalities. The aim is to improve access, affordability, accessibility, and less unnecessary red tape for patients and their families. A story that many of you may not be aware of. In ancient times, there was a tree in the ancient world. Its resin had medicinal properties. This resin was used to make Gilead's balm, and it was the origin for our name. Gilead Sciences is a multinational biopharmaceutical company that has been in business for nearly 3 decades. We were born in Foster City, California, which is the heart of the Silicon Valley. We are now present in over 35 countries. We have pioneered more than 25 breakthrough drugs in the last 30 years, approved by the FDA. Over 14 million people have access to Gilead drugs in low and middle income countries alone. We focus on virology, antifungals, oncology, cell therapy, and inflammation. And how is Gilead doing in the Middle East? Gilead Sciences has expanded its presence in the Middle East by opening a second office in Saudi Arabia. Between Gilead and its partners, around 100 people work to support the 12 markets we serve, and we have over 50 market authorizations in the region. What do we want to achieve both globally and in the Middle East? In medicine, we believe that our mission is to make the impossible possible. Only in this way will we be able to fulfill our vision of creating a better and healthier world for all people. Our aim is to develop and release 10 more medications in the next 10 years, along with the 25 we have already launched, to be a preferred partner for both the ecosystem we serve and our employees, and to create long-term value in a responsible way. We are studying viruses and virology, transforming HIV care, as well as developing a portfolio of drugs for viral hepatitis B, C, and D. The COVID-19 public health problem is being addressed. Imagining a world in which cancer may be cured, Gilead is bringing oncology innovation to patients suffering from triple-negative breast cancer, bladder cancer, lung cancer, and other solid tumors. Gilead Therapeutics has built an internal pipeline with 13 tailored transactions to access external innovation in the last 2 years. These support mechanisms create less stress for the oncology team while allowing them to devote more approved by the FDA. Over 14 million people have access to Gilead drugs in low and middle income countries alone.
cancer. So I would like to invite the chairperson for this session, Dr. Ali Al-Faqih and Dr. Mohammed Al-Ghamdi.
Assalamu alaikum. Good afternoon, everybody. First, I would like to thank the organizing committee for the nice organization, and special thanks to Dr. Al-Khair for the kind invitation. So it's my pleasure to co-chair this session with my friend Dr. Mohammed Al-Ghamdi. Without further ado, I would like to introduce our first speaker, Dr. Sana Al-Sukhan, who is a consultant medical oncologist in Amman, Jordan, and she is going to discuss the abstract randomized control phase 3 trial, etinostat once weekly class 1 selective histone acetylase inhibitor in combination with exemestane in patient with hormone receptor positive advanced breast cancer. Dr. Sana, the mic is yours.
Thank you, Doctor, for the kind introduction. Assalamu alaikum. Good afternoon from Jordan. You know, I thought I will share with you what we are going through in Jordan. The view behind me is indeed from the balcony of my house. We've been hit by a snowstorm for the past couple of days, and we are stuck at home. I'm sorry I couldn't join in person, but indeed, the roads were blocked for the past couple of days, and you can see from my house how is it. You cannot imagine it's from Jordan. It's not from Michigan. So let's see. Thank you, Al-Khair, for inviting me to be part of the traditional Best of San Antonio of the region. And as we were introduced, I will be discussing this interesting abstract. Let's see. Am I sharing now?
Yes.
Yeah, good. Okay. So I will be discussing the abstract, but before we go there, since we haven't discussed histone deacetylase inhibitors, I thought I'll review with you some basic science. And as you can see here, a quick back rewind to our med school days. Indeed, the histone, to remind you, is a basic protein. It acts as a spool around which meters of DNA are do wind so that they form what's called a nucleosome. Instead of having meters of DNA, we have the DNA condensed through nucleosomes into chromatin into a 0.09 millimeter within the cell. So these histones, they are rich in arginine and lysine. These proteins inside the chromatin, they have modification, post-translational modification by the addition of methyl group or acetyl group or citrulline group, depending. And this post-translational modification is important to recruit non-histone proteins to the chromatin structure. As you can see, they are put in order to facilitate transcription of different proteins. Very simple. So if you remove these acetyl groups, as you can see here, transcription, if you remove these acetyl groups by histone deacetylases that could be bound to estrogen receptor or other actually transcription factors, it will impair the recruitment of co-activators and facilitate the recruitment of co-repressors and result in genetic silencing. And we always talk about genomic modifications of cancer, breast cancer, colon cancer, lung cancer, any other cancer. However, we never talk about epigenetic modification, which is quite important for gene silencing and for gene expression. So it's important for the expression or silencing of tumor suppressor genes or oncogenes. So here we have downregulation of the estrogen receptor function as a transcription factor because of loss of the acetyl group by histone deacetylases. If we add, and this results in endocrine resistance because the cell is no longer dependent on the estrogen receptor to function as a transcription factor. Now, if we have histone deacetylase inhibitors, they are inhibiting the histone deacetylases and freeing the estrogen receptor so that we have normal configuration of the chromatin structure, allowing recruitment of co-activators, and the estrogen receptor functions again, allowing expression of the estrogen-related genes, overcoming the resistance. Excuse me. As you can see here, this way, histone deacetylases can overcome resistance to endocrine resistance to the estrogen receptor induced by loss of the acetyl group. With this introduction, let's go to the abstract of interest. Etinostat is a class 1 selective histone deacetylase inhibitor. It is a specific deacetylase important for carcinogenesis. Very interesting molecule to be used in clinic because it's used once weekly because of its long half-life. And indeed, more than 2,000 patients have been enrolled in more than 50 studies around the globe so that we are familiar with its safety profile. The trial design is quite practical. Indeed, they enrolled pre- and post-menopausal women with advanced hormone receptor positive, HER2 advanced breast cancer, stratified by the use of CDK4/6 inhibitor, fulvestrant, chemotherapy, the presence of visceral metastases, and menopausal status to either very simple exemestane by itself or exemestane and etinostat once weekly with the primary endpoint of progression-free survival. Fast accrual, indeed, within a year, they recruited their patients and the follow-up was quite early at 1 year after the last patient was enrolled. They managed to enroll more than 350 patients, 2-to-1 to either exemestane with etinostat or by itself with placebo. Quite interesting, I thought. In the experimental group, 7 patients discontinued treatment because of COVID and 2 on the control group. Quite a bit of a number out of 354 patients if you consider that China is not reporting cases. I thought that was quite interesting. Baseline characteristics were well balanced between both treatment arms, or as you can see here, 40% of the patients have been given chemotherapy in the advanced setting, heavily pretreated population indeed, with almost 1/3 defined as having endocrine resistant disease, I'd expect progressing within 6 months. And 6% only had CDK4/6 inhibitors, with almost 1/4 of the patients given fulvestrant. Impressive improvement in progression-free survival, as you can see, indeed reducing the risk of progression by about 1/4, 3 months improvement in progression-free survival as assessed by the independent review committee. A trend for improvement in overall survival, but I think the median follow-up is still immature. As you can see here, the separation of the curves starts quite early at 1 year and is persistent and increasing even. Notice also one more thing with progression-free survival, it started after 1 month. When it comes to our response rate was also improved, quite interesting. It was quite improved both by the independent review committee assessment and investigator assessment. And duration of treatment actually, independent of assessment by investigator or independent committee, was improved, as you can see, with almost 7 months extra on the experimental group. If you look at the first blot analysis, everything was in favor of the experimental treatment etinostat. Interestingly to notice, patients who have been defined as endocrine resistant at least did benefit from etinostat, and patients who were exposed to fulvestrant tend to derive less benefit as compared to those who are not exposed to fulvestrant. CDK4/6 used, the numbers were quite small, but everything was in favor of etinostat addition to exemestane. And of course, no pain, no gain, but quite interesting, 99% had some adverse events as compared to 88% of the control group. But notice, please, because probably they had arthralgias, as compared to only as compared to only 16%, of the control group. Now, hematological adverse events were the major driver for toxicity with, as you can see here, neutropenia reported by 3/4 of the patients, but in good enough, 2% only had febrile neutropenia, despite more than 50% of that 3/4 having grade 3 neutropenia. Also, thrombocytopenia was seen in 2/3 of the patients. So 3/4 neutropenia, 2/3 thrombocytopenia, quite a bit, and anemia in 1/5. But notice also in the control group, 12% had thrombocytopenia and 7% had anemia, speaking for probably disease-related hematologic toxicity. So what did they conclude? Improvement in progression-free survival by the addition of etinostat among patients with hormone receptor positive, HER2 negative advanced breast cancer, about 3 months improvement in progression-free survival, yes, with significant hematologic toxicity that we can really handle, agree, we've been experienced enough to handle hematologic toxicity, and it proved to be of impact in a pivotal study in combination with aromatase inhibitors. Great. It really nicely affirms the role of histone deacetylase inhibitors as suggested in another Chinese trial for another histone deacetylase inhibitor called tosidinostat. As you can see, significant improvement in progression-free survival, whether by the investigators or by the independent review committee, 6 months in this particular trial with tosidinostat. But again, they are Chinese patients. So if you speak Chinese, you have a new alternative for your patients, simply because those positive results contrast with the negative results recently reported by the North American group in the E2112 study, reported just last October, without any benefit when adding etinostat to exemestane, whether on progression-free survival or overall survival. We cannot compare apples and oranges, but let's review the patient population included in the North American trial, and indeed 1/3 of those had CDK4/6 inhibitor exposure prior to the use of etinostat, and 30% fulvestrant as opposed to 25%. Not sure if the CDK4/6 exposure could have explained the lack of benefit in the North American trial, but one thing for sure that is noticeable also, the rate of adverse events, as I shared with you, in the Chinese trial was 99%. In the North American trial was only 50%, which actually suggests genetic and metabolic differences could be related to ethnicity. And indeed, the combination of etinostat and exemestane does improve the outcome in Chinese patients with advanced hormone receptor positive breast cancer, promising probably in all subsets of patients with breast cancer, currently extensively investigated in patients with triple negative breast cancer, HER2 positive breast cancer to overcome resistance. However, it remains to be confirmed if this positive role could be exploited in a biomarker selected population or in other breast cancer settings. And with this, I conclude and thank you for your attention.
Thank you, Dr. Sana, for your very nice presentation. And we'll have, I'm sure, questions at the end. But for this point in time, I'd like to invite Dr. Ahmed Rafai who's a consultant oncologist in International Medical Center in Jeddah. And I'd like to ask him to talk about the abstract, correlative analysis of overall survival by intrinsic subtypes across all the 3 Mona Lisa trials, which is 2, 3, and 7, studies of ribociclib plus endocrine therapy in patients with hormone receptor positive, HER2 negative advanced breast cancer. The podium is yours, Dr. Ahmed.
Thank you, Dr. Sajid. And first of all, I would like to thank the organizing committee and Dr. Khair for their kind invitation. Today, I will speak about the correlative analysis of overall survival by intrinsic subtype across the Mona Lisa 2, 3, and 7 studies of ribociclib with endocrine therapy in patients with hormone-positive, HER2 negative advanced breast cancer. The presentation just was done by Dr. Zacchary from North Carolina University. So ribociclib with endocrine treatment, we know it demonstrates statistically significant progression-free survival and overall survival in the 3 phase 3 trials, Mona Lisa 2, 3, and 7, in patients with hormone-positive, HER2 negative advanced breast cancer. And still up to now, the only biomarker for prescribing the CDK4/6 is hormone-positive disease. There was a prior pooled analysis of patients in the Mona Lisa trial showed significant progression-free survival benefit with ribociclib with hormonal treatment versus placebo in the luminal disease, luminal A, hazard ratio was 0.63, and the luminal B, hazard ratio 0.52, and also in the HER2 enriched population with hazard ratio 0.39. This was presented by Alex Part in the GCO in 2021. And there was also a meta-analysis published revealed the progression-free survival by intrinsic subtype in hormone-positive metastatic breast cancer among many of the trials, 7 trials, including many medications. One of them is chemotherapy. And so this is a retrospective ad hoc exploratory analysis evaluating the association of intrinsic subtype with overall survival using tumor samples pulled from the Mona Lisa 2, 3, and 7. Just we want to explore what is the effect of the subtypes, because usually in the clinic, we never request intrinsic subtyping. We just prescribe the treatment for patients with hormone-positive, HER2 negative, and we don't know about the intrinsic subtypes. So let us see what they did. The methodology in this trial, they just did gene expression profiling performed on the tumor samples, either the primary and also the metastatic, by using a customized nanostring encounter GX800 gene panel, including 36 out of the 50 genes used in the BAM50 by Prosigna. The intrinsic subtyping was performed using 152 gene set that was selected based on the ability to correctly, accurately identifying the BAM50 subtype in 48 independent tumors and the original BAM50 microarray training dataset. So the relationship between the BAM50 based subtypes, which we know the 4 or 5 subtypes, with overall survival was evaluated using both univariable and the multivariable Cox proportional hazard models, and they generate Kaplan-Meier curve, and median overall survival was estimated by the subtype and by the treatment arm. Multivariable models were adjusted for the known clinical prognostic factors, and p-value here generated as descriptive and not because of it was not adjusted for the multiplicity or the false discovery. Let us see the tumor samples. The tumor samples here is well representing both groups, a patient in ribociclib arm and in the placebo arm, and also well representing the 3 trials, the Mona Lisa 2, 3, and 7, as we can see the numbers. We can find that 71% of the tumor samples were from the primary tumor, while 30% from the metastatic setting. What about the subtype distribution? We find that find 54% of the samples were luminal A, and 28% from were luminal B, and less than 15% were HER2/neu enriched subgroup, and only 3% from basal-like type. But again, all of these patients were hormone positive, HER2/neu negative, regardless the subtype which we knew only with the analysis. Here we can find that these samples represent the groups, biologically, what about the behavior? Here the samples, 997 patients. Regarding the efficacy, we find here that the overall survival in those groups is almost similar to the parent trials. Here the hazard ratio is 0.75, while in the intention to treat was also 0.76. So these samples really represent both groups in the placebo arm, in the ribociclib arm, and also represent the intention to treat population regarding the efficacy and the behavior of this patient. Coming to the first question answered by this analysis, the effect of the intrinsic subtype as a prognostic for overall survival. Here we can see that the intrinsic subtyping has a prognostic effect on overall survival. We can see on the left-hand side, the luminal A group has median overall survival 55 months in the luminal A, and less with 10 months in luminal B, 45 months. If we look on the other side, also we'll find the same. Still, the prognostic effect of the intrinsic subtyping in the ribociclib arm, the luminal A, about 68 months, luminal B, 58 months, less with 10 months, and the HER2/neu enriched 40 months. We can see the drop in the survival with different intrinsic subtype. Coming to the basal-like subtype, it is the worst prognosis in both groups, those who received ribociclib and those in the placebo arm. Coming to the multivariate analysis, what about the significance of the intrinsic subtyping as a prognostic with the multivariable analysis? Again, we will find that it really significant here. If we compare the subgroup, luminal B, HER2/neu, and basal to the luminal A, hazard ratio 1, we can find that increase in the risk in luminal B versus luminal A in the placebo arm to be the risk 1.4 fold, and in the HER2/neu 2.8, and the basal-like 2.3. If we look to the left-hand side, the ribociclib, we'll find still, again, patient in luminal B, they did worse than the patient in luminal A, but with lesser extent. The hazard ratio here is 1.1 versus 1 in the luminal B, 1.8 in HER2/neu. And again, the basal-like, they didn't benefit from ribociclib. We can find the risk of this is about 7-fold the luminal A. So this intrinsic subtyping proved to become a good prognostic factor to make some granularity among the patient. All of them, they have the same trait, or HER2/neu positive and hormonal positive, HER2/neu negative. Coming to the second question, the effect of the treatment, the ribociclib over the treatment. Here in the univariate analysis, we can find an improvement. Adding ribociclib improved the survival in the different subtypes. In luminal A, the hazard ratio 0.75. In luminal B, even better, hazard ratio 0.69. In HER2/neu enriched 0.6. But it didn't show effect in the basal-like subtype. And if we look to the interaction test result between the subtypes and the treatment arm, it was statistically significant, p-value 0.16. But when you remove the basal-like subtype, you find that you lose this significance. Coming to the multivariate analysis, again, we will find still there is an overall survival benefit with ribociclib in the luminal A, luminal B, and the HER2/neu subtypes. And as we can see here, the adjusted hazard ratio is 0.77 in luminal A, 0.63 in luminal B, 0.53 in HER2/neu enriched. And we know that with other CDK4/6, mainly palbociclib, there was no benefit among those with HER2/neu enriched. So this is some sort of a little extra benefit for the ribociclib in such subgroup. But all of these are ad hoc analysis, so we cannot just draw a very solid conclusions. Coming to the conclusion, in this pooled analysis of the Mona Lisa 2, 3, and 7, there was consistent overall survival benefit with ribociclib hormonal treatment in the luminal A, luminal B, and the HER2/neu subtype. Patient with basal-like subtype, 3% in each arm, didn't derive benefit from the ribociclib. However, they were only 3% in each arm and overall 30 patients. The prognostic value of the BAM50 based intrinsic subtype of overall survival in patients treated with ribociclib plus endocrinal treatment and those treated with endocrinal treatment alone was confirmed, but I mean, we don't use such intrinsic subtyping in the daily practice in the clinic. The result of this analysis are consistent with those in the prior analysis of progression-free survival used in the pooled Mona Lisa dataset. The activity of ribociclib with hormonal treatment in the HER2/neu positive subtype, which has a poor outcome compared with the luminal subtype, is being further investigation in phase 3 Harmonia trial. In this Harmonia trial, they will examine if ribociclib has a particular impact on such group based on this clinical data and the preclinical data generated in the patient-derived xenograft model. A genomic profiling analysis, again, it was showed in another poster in the San Antoniao in 2021. And by this, I end my presentation, and there was, at the end, there was acknowledgement for the patient and for the investigator in this trial. And thank you.
Thank you so much, Ahmed, for the great talk. Now it's my pleasure to introduce and welcome the next speaker, Professor Khalid Saleh, who is a medical oncologist and the past director of Oncology Center at King Saud University Medical City. Khalid will take us through the abstract number GS201. We'll be talking about the overall survival subgroup analysis by metastatic site from the phase 3 Mona Lisa 2 study of the first-line ribociclib with letrozole in post-menopausal patients with advanced hormone receptor positive HER2 negative breast cancer. Khalid.
Assalamu alaikum, and thanks for the committee and Dr. Malkhair for inviting me to present this poster. Now, I mean, as you already know, we are really an exciting time for breast cancers, and we are having many new agents. Now, the question is always how we're going to select the best drug for the best case. Can we look at the group to show an improvement? Definitely, we're going to be testing new drugs, but it's truly an exciting time. And I'm going to share with you this actually Mona Lisa 3 poster, which is actually labeled as overall survival subgroup analysis by metastatic site from the phase 3 Mona Lisa 2 for the first line ribociclib, letrozole in postmenopausal patient with hormone positive HER2 negative advanced breast cancer, presented by Dr. Joyce Oshigansi. Now, this was the disclosure for all the authors. Now, we all know Mona Lisa 2 was a trial recently reported an overall survival. So just to remind ourselves, the initial report came in about 2016, looking at the progression-free survival. There was about a difference of 9 months, and they needed to wait for about 5 years to report the overall survival. Now, this is just give us a clue how effective is this therapy. To show a survival benefit on the first line of breast cancer hormone positive has not been done in a long time. To show this effect, this is remarkable, and we should always remember that. Now, we are able to show a survival benefit on the first line breast cancers. We were so settled that we were happy with the progression-free survival for a long time. First line, now we can show there's an overall survival. And actually, the overall was 63 months versus 51. So more than 5 years. The median survival we expect right now for a hormone-positive breast cancers is more than 5 years. This is remarkable. It used to be during my training, not a long time ago. You should remember that. It was actually about 24 months. This is about like 12, 15 years ago, 24 months. Now we are talking about more than 5 years to have a median survival in hormone-positive breast cancer. So in this presentation, now they are looking to the subgroup analysis. Now in the original report, which just came in December in the New England, so they did discuss some subgroups, but they expanded that. Now some of the subgroups were pre-planned, some of the subgroups has been added as a hypothesis generation. So this is actually the design of the study. They got postmenopausal ladies, no prior therapy, so they are de novo. Now prior neoadjuvant hormonal therapy, including TAM, is allowed, and the total number was 668. They are randomized 1-to-1 with the ribociclib and the standard dosing with the letrozole versus placebo with letrozole, and the primary endpoint was progression-free survival. The second endpoint was overall survival and looking at the safety and the quality of life. Now, you can actually see in the intention to treat analysis, 5 year, it was 52 versus 43%. At 6 years, 44% versus 32. And the B-value is 0.004. And this is a very impressive for a first line. Now, just to say, we have a similar result with the other CD4 K6, but this is very impressive for ribociclib. Now, they went back and they did a cut point for the data analysis, June 2021, and they looked for pre-specified subgroups before they opened the data, which is bone-only metastasis. If you have a visceral involvement, typically we say those cases are more tough to treat. If you have liver or lung, number of metastatic sites, prior chemotherapy or prior endocrine therapy. Now, you might imagine if you have prior endocrine therapy, people always say you do have a higher rate of ECR mutation, and all that does make it harder to treat. And they estimated the overall survival with Kaplan-Meier. Hazard ratio was estimated using stratified bone-only disease and a number of metastatic sites. Now, interesting thing, they did not power it enough. So they are looking for hypothesis generation, and it was not adjudicated for multiplicity testing. Okay, so let's look at the bone disease, bone-only disease. Now, we always typically, the typical teaching is if you have a bone-only disease, hormone-positive breast cancer, this is a more indolent course. And actually, do we see on the same data? So if you look at the placebo, bone-only disease, yes or no? So you can actually see on the left-hand side, there was actually slightly better, actually, but actually did not reach the statistical significant. And remember, this was underpowered for that versus the no bone disease involvement. So this tells us the overall survival benefit was equal between both groups, the bone and the non-bone metastatic site. If you want to look at the only liver metastasis, also you can see yes and no, and actually there was no much difference. So one was non-clinically significant, non-statistically significant. The other one actually just touched the significant side at 0.97. So the benefit was observed both in liver and non-liver, but actually was mostly with the liver one. If you look at the liver or lungs, so actually you can see the overall survival was also seen in both liver and lung if you're going to lump them all together. If you look at the metastatic site, so if you have, so always the classic teaching, if you have less metastatic site, you're going to have an easier to treat disease. So if you have less than 3 or more, and you can see it was overall survival benefit has been observed in both groups. So this tells you it does span this effect. If you have received prior chemotherapy, and actually you can see the overall survival benefit for the patient who had or had not prior neoadjuvant or adjuvant chemotherapy was consistent with the same overall survival group, the intention to treat analysis. Now, if you want to look at the prior endocrine therapy, and I think this is actually a very interesting one. If you look at the far right, so the no prior hormonal therapy, so you can see actually it's slightly better in the performance, and you might expect that because those patients has been just diagnosed. Typically, the rate of mutation of the estrogen receptor is slightly lower. But you can still see the patient overall survival benefit has been seen in across the cases who received or did not receive chemotherapy, hormonal therapy, or even no hormonal therapy in the past. This tells you the ribociclib is quite effective. So in conclusion, independent of metastatic sites, independent of the number of metastatic sites, independent of the prior neoadjuvant chemotherapy or endocrine therapy, this exploratory subgroup analysis have showed improved overall survival with the first line use of letrozole and ribociclib as per the Mona Lisa 2 trial. So the subgroup is consistent with the big group. And this was consistent at the 5 years or the 6 years mark. So Mona Lisa 2, 3, and 7 demonstrated that the overall survival benefit exists across all the subgroups and across the different population selection, premenopausal and postmenopausal. And with this, I'll conclude, and the acknowledgement has been done by the team to everyone who participated. Thank you.
Thank you very much, Dr. Khalid Saleh, for the excellent presentation. Now I will introduce our next speaker, Dr. Sharif Kulab, who is a consultant medical oncologist and he is also the program director at King Saud University Medical City. And he's going to discuss the abstract elacestrant, an oral selective estrogen receptor degrader versus investigator's choice of endocrine monotherapy for ER-positive, HER2-negative advanced metastatic breast cancer following progression on prior endocrine and CDK4/6 inhibitor therapy, result of EMERLAD phase 3 trial. Dr. Sharif, the mic is yours.
Thank you, Dr. Assalamu alaikum wa rahmatullahi wa barakatuh. First, let me thank Dr. Khair and the organizing committee for getting me this invitation, and especially to talk about this interesting topic today. This is the EMERALD trial. This is a phase 3 trial, positive phase 3, one of the rare phase 3 trial, positive trial that had impact on breast cancer management over the last few years, especially when we are talking about management of a luminary profile, HR-positive, HER2-negative metastatic breast cancer, using a new molecules for the first time, oral SERD selective estrogen receptor degrader, like Faslodex, but orally. And it has been compared here in this trial versus a choice of therapy at metastatic setting following progression on endocrine therapy using CDK4/6 inhibitor. And that was the first time presenting this trial. So in the background of this trial, as you know, the endocrine therapy associated with CDK4/6 inhibitor is now considered as the standard of care in the management of HR-positive, HER2-negative metastatic breast cancer since the first-line metastatic setting. And as you know, most of the patients with HR-positive metastatic breast cancer eventually will develop drug resistance on this treatment, either because they have a kind of negative predictive markers for response to hormonal treatment, like the MESR, or other biomarkers which are not yet identified. In treatment guidelines of metastatic HR-positive, HER2-negative breast cancer, we are using now sequence hormonal treatment after hormonal treatment until we exhaust all the hormonal treatment before starting chemotherapy. However, in post-CDK4/6 inhibitor, as we have seen this in some trials, mainly the SOLA-1, the median progression-free survival after failure of first line using single agent hormonal treatment with Faslodex or aromatase inhibitor is 1.8 to 2 months only. Again, when we are talking about one single hormonal treatment use. I want to remind you and myself as well that the last change in hormonal treatment, last molecules has been developed almost 2 decades back, and that was Faslodex more than 20 years back in the management of hormonal positive metastatic breast cancer. The elacestrant is like Faslodex. This is an oral SERD that block the estrogen receptor, and it has been shown to be like Faslodex, dose dependent. In phase 1, it has shown its efficacy and activity with higher dose, and it has been shown to be superior than Faslodex in terms of activity in phase 1, and in phase 2, the dose has been identified to be 400 milligram once daily. This is the trial design. In the inclusion criteria, we had men and postmenopausal patients only. The premenopausal patients were not included in this trial for some reason. Patients with ER-positive, HER2-negative, I mean luminal profile breast cancer, who had progressed after 1 or 2 lines of endocrine therapy with condition using of CDK4/6 inhibitor plus any hormonal treatment, or at least 1 chemotherapy plus this line of hormonal treatment, CDK4/6 inhibitor. The patients should be, as you expect, in good general condition, and they were randomized in the trial to receive either oral elacestrant versus any endocrine therapy as per investigator choice. The hormonal treatment here in question might be Faslodex, anastrozole, letrozole, or exrestan, according to what the patient has received previously. I mean, if the patient has received aromatase inhibitor with CDK4/6 inhibitor, initially at first line, here in the trial, he will be receiving Faslodex, for example. The patient will continue the same treatment, their treatment in the trial, until disease progression or withdrawal from the trial. Co-primary endpoints have been identified in this trial or re-specified in this trial: PFS for all patients and PFS for the subgroup of patients who are harboring resistance mutation MESR1. The CT scan was planned to be done here every 8 weeks, not every 3 months. That means that we were overlooking for metastasis in this trial, and this might participate in the interpretation of the results later on. The MESR1 mutation has been specified or found here according to the circulating DNA of a tumor in the blood. Again, I want to turn your attention to what I have just mentioned. Here we are conditioning, or they were asking to accept patients who have used CD46 inhibitor with hormonal treatment, but also patients who have received at least one line of chemotherapy and 1 line of hormonal treatment with CD46 inhibitor. The study design has been done, as we said, for the co-primary endpoints: PFS for all patients and PFS for the subgroup of patients MESR mutation harboring. And it has been the analysis plan has been done with one alpha error of 5%, two-sided, and the trial was powered for more than 90% to have PFS hazard ratio of at least 0.667 for all patients, and more than 80% to have PFS hazard ratio of at least 0.61 in the subgroup of patients who are harboring MESR mutation. The overall survival in all patients and also in the specific subgroup of patients with MESR mutation is calculated or counted at the time of analysis of PFS, but also the final OS survival will be given after at least 50% of the patients in the trial are dead. So this is the patient disposition in the trial. According to the flow chart in this patient for the trial, finally, they could have almost 477 patients who were randomized in 1-to-1 patient. 239 patients received elacestrant, and 238 patients received a selection of any endocrine treatment according to the investigator. All patients were continuing the treatment until disease progression. And as you can see, almost the majority of the patients, 84 to 85%, continued the treatment until having the disease progression. Very limited number of patients had adverse events, and a small number of patients withdraw from the trial. When we look to the demographic distribution of patients, it was balanced between both groups when it comes to the median age, gender, performance status, visceral metastasis, bone metastasis, and so on. However, I want to turn your attention here to two things. Number one, we are estimating that 70% of patients were having visceral metastasis, and almost 20 to 25% of patients had already received 1 line of chemotherapy. These two characters will influence again the results interpretation, because we are considering here an aggressive tumor patients. I mean patients with aggressive tumor. Now coming to the primary endpoint, the trial was positive and it met its primary endpoints. The progression-free survival, as you see, the green curve represents the elacestrant group, and the blue color curve represents the control group. The progression-free survival was significantly higher in the elacestrant group, and with reduction of 30% of the risk of reduction, a decrease of 30% in the risk of reduction of disease progression or death in all patients. When we look to the group of patients with MESR1 mutation, again, the trial was positive, and the elacestrant was associated with 45% reduction in risk of progression or death in this trial. This is an important slide showing the PFS at 6 months and at 12 months. Now, this is the PFS story at 12 months for all patients, and the patients with the MESR mutation. As you can see, initially, there is a quick drop in both curves, mentioning or showing that there is a high portion of patients representing a primary and secondary endocrine resistance. And we are treating only, or I mean following with clear clinical benefit only for 2/3 of the population. And in both groups, in all patients and in the subgroup of patients with MESR mutation, there was significant benefit in terms of PFS in favor of the elacestrant use. When we look at this benefit at 6 months and at 12 months, once the curves are separated, this separation is maintained all the time, showing that the benefit is becoming early. I mean, there is a proportion of patients with resistance at the beginning, if we can avoid, but after that, once we have the response, we are maintaining this response for a quite longer time. This benefit as shown here is clearly obvious at 6 months and at 12 months. Now, one thing to mention is in the group of choice of endocrine therapy, in the control group, they noticed that 70% of the patients were on phospholipix. That means that they were on aromatase inhibitor on the first line, and once they are randomized, 70% were on phospholipix. So they tried to compare here the PFS for elacestrant group versus PFS in the fulvestrant group. And this also was clearly, well, the PFS was clearly significantly higher in the elacestrant group in all patients, and more significantly in the patients who are harboring MESR mutation. When we look to the different subgroups, I mean, in the patient, regardless of the number of treatment that were received before, regardless of the age or sex, always, and all the other parameters, always there is a trend of benefit of progression-free survival in favor of elacestrant versus any other endocrine treatment. When we look to the overall survival, secondary endpoint, there is a trend of benefit of overall survival in all the population, and this difference was significant in the subgroup of patients who are harboring the MESR mutation. However, as you know, that was the first or interim analysis of this trial, and the final analysis is expected at the end of this year or early at the beginning of next year. In terms of safety, most of patients had at least one adverse event. And grade 3 or 4 were infrequent, only 1 digit, but also the number of side effects that led to discontinuation of the trial was also infrequent. And it is to mention that there was no treatment-related death in either of the groups. When we look to the type of side effects, the main side effects that has been reported in the elacestrant group was the nausea in almost 35% of the patients. However, the grade 3 and 4 was noticed only in 2.5% of the patients. For the other side effects, I mean the fatigue, the arthralgia, and the hot flash, it was similar among both groups. In conclusion, elacestrant is the first oral SERD that demonstrated a statistically significant difference and meaningful improvement in terms of progression-free survival, with the trend of improvement of overall survival when we are using it compared to any hormonal treatment as per investigator choice for treatment after failure of CD46 inhibitor and aromatase inhibitor, with 30% reduction in the risk of progression or death with elacestrant versus standard of endocrine therapy in all patients. And this reduction is estimated to be around 45% in the group of patients who are harboring MESR mutation. We are observing a higher PFS at 6 and 12 months for the treatment group. In terms of safety, as you have seen, the elacestrant was well tolerated and there was no exceptional side effects to be mentioned here. The final overall survival is expected within the end of this year or the beginning of next year. But there is a signal of improvement of overall survival by using this drug. Scientifically, this drug has proved its proof of a principle of superiority compared to phospholipix and any other hormonal treatment at this setting of treatment. And clinically, it might be the potential standard of care in the future to treat HR-positive, HER2-negative metastatic breast cancer after failure of CD46 inhibitor plus hormonal treatment at metastatic setting. Further study for combination with mTOR inhibitor and with CD46 inhibitor are ongoing, and still we are waiting results. Finally, there was an acknowledgement for the 17 countries or 228 centers in these 17 countries who participated in this trial. With this, I will end my presentation, and I'll thank you for attention.
Thank you, Dr. Sharif, for a very interesting presentation. Now I'd like to invite a final discussion where Dr. Naji Al-Saghir will discuss the biomarker-driven treatments and also the other three abstracts. So Dr. Naji is a professor of medicine and director of Breast Center of Excellence in Naif K. Basel Center, Institute, American University of Beirut Medical Center. So the podium is yours, Dr. Naji, to discuss these very interesting abstracts. Over to Dr. Naji.
Thank you very much, Mr. Chair, for introducing me. Can I share my screen?
Yes, we can see you, and it's there, right there.
Okay, very good. Let me just, this is like full screen. You have it full screen?
I do.
Okay, okay, that's better now. Okay, very good. Thank you very much. And I'd like to thank and congratulate first Dr. Khair for her persistence and organizing this meeting for the last 16 years. Congratulations. It has been a very nice meeting so far. My task is to discuss with you select abstracts at this Best of San Antonio Breast Cancer Symposium that was held last month in San Antonio, Texas. It was hybrid, and now in Riyadh is also a hybrid. I will be discussing two abstracts, the Mona Lisa 237 intrinsic subtyping in advanced breast cancer and the Mona Lisa 2 overall survival analysis by metastatic site, and talk about refinement and use of CDK4/6 inhibitors in advanced breast cancer, because I think Dr. Nadia Harbeck will talk later on about early breast cancer, or maybe all early and metastatic, overcoming endocrine resistance and treatment post CDK4/6 inhibitors with entinostat and elacestrant. And I'll mention a few other important things and conclude. We will start with the refinement and use of the CDK4/6 inhibitors with the overall survival analysis by intrinsic subtype of Mona Lisa 2, 3, and 7. As mentioned, as presented by Dr. Zacchary and Alex Pratt, and also our colleague, Dr. Ahmed Rifai, doing the PAM50, the Prosigna, what we know as Prosigna PAM50, shows that the hormone receptor patients are not always negative HER2 or not basal-like. Actually, 54% were luminal A. This is the, as mentioned earlier, I'm not going to go through all the details. It's like pooled for all the Mona Lisa trials on hormone receptor positive HER2 negative patients. Well, we have 54% luminal A, 27% luminal B, 14% were HER2 enriched, and 3% had basal-like intrinsic subtype breast cancer. First thing, when they looked at, the subtypes, really whether it's luminal A, luminal B, HER2 enriched, or basal, you see best survival in the luminal A, then B, then you have the HER2 enriched and the basal-like. So it really confirms the earlier observations, that Chuck Peru and colleagues have, put out about 25 years ago. So definitely, and we see in all subtypes a benefit for improvement, survival with ribociclib. Now, when they were separated by luminal A, B, HER2 enriched and basal-like, there was a consistent benefit observed in all of them. Luminal A, you see better ribociclib with endocrine therapy. Luminal B, HER2 enriched also significant. Her hazard ratio 0.6. But the basal-like, there was no benefit for adding ribociclib. So the conclusions of the authors is that this pooled analysis really shows that overall survival observed in A, B, and HER2 enriched subtypes. The basal-like, which constitute 3%, in each arm, and if HER2 positive constitute about 70% of all breast cancers, so this 3% maybe comes down to about 2%, which is significant. They did not derive benefit from ribociclib. We really need to find out how best to treat those patients. So the PAM50 really has been shown to have a prognostic value for overall survival, because you separate patients do actually benefit from ribociclib. Now, we also have, and I'll mention this, the other study with the palbociclib, and based on this study and the palbociclib study that was published by Richard Finn, that you also see, they had analysis from Paloma 2 and Paloma 3. There was a benefit, of course, from palbociclib. It was not affected by disease-free interval that they looked at, but the shorter the disease-free interval, the smaller the overall survival benefit. They observed they had only 142 patients with tumor tissue, metastatic tumor tissue, and whether it's luminal A or B, palbo improved progression-free survival when added to endocrine therapy. And based on really these trials, let me see if I can get this part of my screen is, I don't know. Okay. Now the new study, the Harmonia study that is launched, our previous presenter spoke about it. This is sponsored by Novartis. The lead are, Alex Pratt and Lisa Perry, and mostly this is a salty, trial. They will take the study already started. Actually, it was launched already, looking at patients with HER2 enriched and basal-like. So you take the hormone receptor positive patients, do the PAM50, the subtyping, and take the HER2 enriched group. They will be randomized to be given ribociclib with endocrine therapy or palbociclib with endocrine therapy, and followed until progressive disease or toxicity. The patient will turn out to be basal-like, will not be given hormonal therapy. They will be given paclitaxel, and they will be followed. And we will have, it's an important, trial. We'll see what we will get out of it, but definitely it really will teach us how to treat those 14% of the 70% who are hormone receptor positive, and the small percentage, 2% who have basal-like. The second abstract that I will be discussing is the analysis, subgroup analysis overall survival from Mona Lisa 2 by metastatic site. This is a reminder, as you well know, ribociclib with endocrine therapy versus a placebo with endocrine therapy. This is really the first study that showed 5-year survival with CDK4/6 inhibitors, ribociclib, in patients with hormone receptor positive disease, after, of course, the Mona Lisa 7 trial. And interestingly, as a reminder, really at 5 years, 52% patients are alive versus 43, and the benefit continues, almost also increases over time. It increases at 6 years. You can see the graphs continue to separate. They looked at the pre-specified subgroups, as Dr. Khaled presented, and we have seen benefit from ribociclib in all subgroups, even also by the number of metastases prior chemo or prior hormonal therapy. So the conclusions of this trial, yes, we do have improvement survival. First line ribociclib with letrozole in all subgroups. So what do we conclude out of this? First of all, we confirm that endocrine therapy is the preferred option. Those are the ABC guidelines, ABC 1 to 5, and also 6 that we held in November last year. Endocrine therapy is the preferred option for hormone receptor positive disease. You get 5 years overall survival improvement, and you have, as I mentioned, like 52% of the patients alive at 5 years or 44% at 6 years. You don't get that with chemotherapy. So definitely another argument, yes, endocrine therapy should be our first choice. I know that after ABC's guidelines, these guidelines have had a big influence on the management of patients with advanced breast cancer worldwide, and specifically for making people use, and rightly so, more endocrine therapy. Of course, unless you have visceral crisis or concern or proof of endocrine resistance. Even now, visceral crisis, or let's say near visceral crisis, we have a clinical trial, the Right Choice trial, that we now have completely recruited, and we will be following our patients, comparing them ribociclib with endocrine therapy and ovarian function suppression versus ovarian function suppression endocrine therapy alone in premenopausal women. Very important trial. We will be waiting for follow-up and the results. So what is the preferred first line? Of course, depending on the type and duration of adjuvant therapy, you can use either aromatase inhibitor, tamoxifen, or fulvestrant. And for the last several years, since 2015, actually, when the Paloma 1 was initially presented, we started using CDK4/6 inhibitors. It is now, with endocrine therapy, the standard of care in postmenopausal women and in premenopausal women and in men. CDK4/6 inhibitor with aromatase inhibitor in association with an LHRH analog. Now, should we use them in first line or second line? The majority of the panelists agree that it should be used in first line. So the standard of care in first line and second line is a CDK4/6 inhibitor. Now, are they one class of drugs? Yes, they are one class of drugs. Are they different? Do they have differences? Yes, they do have differences. They give equivalent progression-free survival, first line and second line, but there are pharmacological differences, toxicities. Now we have overall data survival difference, and also differences in the adjuvant trials in early breast cancer, as we heard earlier this afternoon. So which CDK4/6 inhibitor to choose, which endocrine partner to choose in the clinic? We have to consider clinical trial results and toxicity profile, and also availability. We have the ESMO magnitude of clinical benefit scores. We know this was presented, at ABC 6. It will be published soon. Actually, only ribociclib did get the score of 5 because we have improved progression-free survival, improved overall survival, and improved quality of life across the trials now. The others, of course, they got 4 and 3. You choose according to the clinical trial, clinical condition, and also toxicities in consideration. And I have this chart for you, palbociclib, of course, PFS benefit first line and second line. All of them actually have that. Now, the advantage that palbociclib has, of course, it is the first CDK4/6 inhibitor reported and first on the market, and the first one to use, and the one that we are mostly used to prescribe. That's important to be the first. It has an overall survival benefit in endocrine-sensitive patients in second line, but remember, also the group of patients were more heavily pretreated than other trials. We have very strong supportive real-world evidence for palbociclib, and we are awaiting for the Paloma 2 overall survival benefits. And I hear that we will be getting them soon, hopefully at ASCO and the most at San Antonio. Now, with ribociclib, Again, PFS, first line, second line. We have an overall survival benefit in premenopausal patients, the MONALEESA 7 trial. So there may be here an advantage to consider it in that situation. Now, overall survival benefit in MONALEESA 2, also 3 and 7 now. We have all overall survival in all the trial. And now we have seen it, whatever the metastatic site is, and the real world evidence data we have. And now this HER2 enriched subtype is interesting to pursue. That's something that will be pursued. As for abemaciclib, yes, progression-free survival first line and second line, overall survival benefit in second line, including patient with liver metastasis and primary endocrine resistant group. Those are important aspects to consider. We have activity also in refractory disease, as we have seen in the MONALEESA. Sorry, I mean the Monarch 1 study. That's an error. Sorry, there's no the Monarch 1. And also in the Monarch 3, the results are awaited. Again, you know, we hear that is going to be soon, either at ASCO or at ESMO or at San Antonio. Let me go for, okay. Now, that was the first part. The second part, overcoming endocrine resistance and treatment post CDK4/6 inhibitors. We have the entinostat and the elacestrant that were presented. Now, Dr. Sana Al-Sukhan presented the study of Dr. Bing Zhu, and he gave a nice introduction to the pharmacology and the epigenetics. Now, this study really included pre- and postmenopausal women, advanced breast cancer, hormone receptor positive, HER2 negative. 70% had visceral mets in China. This was a study that was done in China, as Dr. Zhu, of course, presented. Progressed on previous endocrine therapy. Look, 6% only had CDK4/6 inhibitor, 26% had fulvestrant, 38% had chemo, and primary endocrine resistance 31% of the times. They were randomized 2-to-1 exemestane with entinostat versus exemestane, and we have seen an improvement 6.3 months versus 3.7 months with a hazard ratio of 0.7, and all the subgroup analysis favored entinostat, and toxicity was rather manageable, expected and manageable. So we do have a study now for patients who have progressed on prior endocrine therapy. The second study that was presented, the elacestrant by Dr. Sharif, presented at San Antonio by Dr. Bardia. This is the background that went over. What we know is that elacestrant is an oral SERD that blocks ER in a dose-dependent manner, and the dose was identified in the best at 400 milligrams, okay? And we had this phase 1 studies initially. We have partial responses in heavily pretreated patients, including those with CDK4/6 inhibitors, prior fulvestrant, and also with the mutation ESR1 that we know they develop endocrine resistance and it develops over time. This is a list of all the oral SERDs, selective estrogen receptor degraders, downregulators in the clinical trials. The Emerald trial, this first one that came, phase 3 trial into light and was presented at San Antonio. Look, these patients, men and women, postmenopausal, advanced breast cancer, ER positive, HER2 negative, progressed on 1 or 2 lines of hormonal therapy. One of those lines had to be inclusive of CDK4/6 inhibitors. And they had 1 or less line of chemotherapy for advanced disease, randomized 1-to-1 elacestrant, or standard of care at that time was fulvestrant, anastrozole, letrozole, or exemestane. As was presented earlier, we have seen an improvement with elacestrant in the entire intent to treat population, patients, 2.7 versus 1.9 months, small, but statistically significant. And at 12 months, interestingly, 22% of the patients were still alive versus 8%. Now, in the patients who had ESR1 mutation, better results. We have 3.4 versus 1.8, hazard ratio 0.54, and the progression-free survival at 12 months, 26% versus 8%. So we have an improvement in the entire population, and also those who have an ESR1 mutation. So definitely this is a drug, and actually the toxicity, as we heard, was quite manageable. So it has the potential to become the new standard of care, as they mentioned, but I will be discussing this. This drug is not yet approved by the FDA. They did apply, so we hear, and we are waiting for results. Now, quickly, let me go over the other things that we have. If you have progression after CDK4/6 inhibitors, now, that was after the study was concluded, we have the SOLAR trial that shows that you test patients for PIK3CA, and alpelisib is the drug of choice in that area. This is the SOLAR-1 trial. And also after CDK4/6 inhibitors, the BILEAD study showed that alpelisib has activity post CDK4/6 inhibitors. The sequencing of those drugs, alpelisib, as I said, in patients with PIK3CA mutation, and the sequencing, we still, of course, do not know what is the optimal sequence, but we do sequencing, one after the other. And this is a slide that was presented by Dr. Siskan, who discussed those abstracts, the last two abstracts, I think the middle two abstracts at San Antonio. Very nice slide. If you can read it, you can have it. But let me go over one thing I think is important that was presented at San Antonio is the PADA-1 study. This is a French study that actually looked at patients with metastatic, breast cancer treated with aromatase inhibitor and palbociclib, and they followed them with a blood sample, a liquid biopsy, and they sequenced them for development of ESR1 mutation. When patients develop ESR1 mutation, they switch them to fulvestrant. And actually, we have seen an improvement in progression-free survival.
Dr. Nagy?
I think, Dr. Nagy, you have muted yourself. Dr. Nagy, we can't hear you if you can hear us.
Dr. Nagy? Dr. Nagy?
I think he's logged off. So I think for the sake of time, we might go to question answers if he doesn't rejoin quickly.
I think it's a good idea. Let's go ahead and we'll start the questions now. Would like to call the speakers to come to the podium, please, for the discussion. We will take the discussion.
Okay, I think for the time sake, we'll take limited number of questions.
Unmute. Can you please let me finish the last slide?
Sure. Sorry.
Yeah, please. Let me finish this last slide. It's important, okay?
Yes, please do.
Now, I know I was interrupted. Okay. Now, as a conclusion, okay, those are important data. Now, one thing I would like to say, in terms of entinostat, as Dr. Sana mentioned, we have US trials that were not as good as those. Maybe there are differences between, ethnic groups. Now, elacestrant is an important trial. However, look at the survival. It is quite short, and the patient only had less than or one line of chemotherapy. So I don't think it will be standard of care after failure in CDK4/6 inhibitors. We have, as I mentioned, the alpelisib, but also we can use chemotherapy. So there, the standard of care might still be chemotherapy. We don't accept overall survival only one, very short progression-free survival, 1 or 2 months. I think this study was a proof of principle that yes, oral elacestrant is very important, and it will probably replace the injections of fulvestrant for patients in earlier stages. The other thing important, of course, we check for PIK3CA, we check for germline mutations. These patients might go for a PARP inhibitor, okay? And now we have the drug conjugates. The DAISY trial with T-deruxtecan may be effective in HER2 1+ or 2+ only. So the future, yes, is much better. And remember the last slide, we may be, instead of checking CA15.3 and PET scan every few months, we may, and I think this will happen very soon, we'll do a blood test and check for biomarkers and change the treatment accordingly. And with that, I thank you for your kind attention.
Thank you very much, Dr. Naji, for the excellent summary and discussion of the abstracts. We'll take 1 or 2 questions before moving to the next session. So for the speakers. Okay. So I see no hands raised and no questions is asked. So thank you very much for joining us to this session. And I would like to thank all the speakers, also the discussant and the chairman of this session. And I hope you enjoyed the session. We'll ask Dr. Khair to introduce the next chairman of the next session. Thank you.
Nadia, have the issue online? I'd like to introduce Dr. Murfat Mahrouz, who will chair the next session. Dr. Murfat Mahrouz, consultant medical oncologist at Military Hospital Riyadh. The floor is yours, Dr. Murfat. You can introduce our next speaker.
Thank you very much, Dr. Khair, for introducing me. And first, I would like to thank you for the 16 Best of San Antonio. Congratulations for a very successful meeting and very exclusive and very eminent faculty. Very important day, and I think we had very interesting sessions. And it's my pleasure to moderate this session. So this session, the title is Emerging Adjuvant Therapy for Hormone-Positive Breast Cancer Patient, What is Ready for the Prime Time. And we have the pleasure to have our eminent speaker, Dr. Nadia Harbeck. Dr. Nadia Harbeck, she is known for everybody. Dr. Nadia Harbeck, she is the she is the head of the breast cancer and holds the chair of the conservative oncology at the Department of Pagani, University of Munich, Germany. Dr. Nadia, she will give us a very interesting talk about CDK4/6 inhibitors in ER-positive breast cancer patient. Professor Harbeck, floor is yours. Thank you.
So good evening, everybody. Thank you very much for inviting me again to this important meeting in your region. I would have loved to be there in person. We have to postpone this, but I still remember last time I was actually there in person, but I think the meeting was in Jeddah at the time. So I have 2 topics, and I don't know how you want to do this. I have a talk prepared where I include both of the topics I'm going to be talking about, and then we could take the questions at the end if you agree. So,
yes, absolutely.
So I will, because it fits very nicely together. So my topic is what's ready for prime time based on the data we saw in San Antonio. And I'm going to be talking about CDK4/6 and PARP inhibitors in the hormone receptor positive HER2 negative early breast cancer space. So here are my disclosures. if you ask me the question, I would probably say yes, they are ready for prime time, and then we could go on and have the discussion right away. But I think my two colleagues, Dr. Ingrid Meyer and Dr. Andrew Tutt, gave a wonderful emerging adjuvant therapy start at the night ballroom lectures in San Antonio. So I would just love to summarize what they told us in San Antonio and also add a little bit of my own thoughts to that. So if we look at the luminal early breast cancer space, we basically have to answer several questions. And the topic of today is who will need more than standard therapy, and are the approaches we've seen in clinical trials over the last year actually ready for prime time? And why do we need to talk about this? It's because we still have a remaining risk of recurrence in the luminal breast cancer space. This is data from the Oxford overview analysis, and we can see that there is relapses also after 5 years, and it's in all the three groups, but the higher the nodal burden, the higher the tumor volume, the higher the risk of recurrence. And we have the same data here from our German trials. When we look at luminal B high proliferating tumors, they actually do worse than triple negative ones, even though in the Plan B study, which is a very contemporary study, we treated patients with state-of-the-art chemotherapy and endocrine therapy. So the first talk I'm going to be highlighting is the talk by Dr. Mayer, and she talked about the CDK4/6 inhibitor problem. And what she pointed out was that in hormone receptor positive breast cancer, this is the most common subtype, about 65-70% of the patients. We have a wide variety of clinical behaviors of these tumors, as I just showed you also from our German experience. The ER/PR status is predictive of endocrine therapy benefit, though not optimally so. I will get to that at the end of my talk. And what we have to keep in mind that the risk of recurrence is there in the beginning for the high nodal burden patients, but it's actually there for the first 10 or 15 years or so. So we can never tell the patient, well, now it's going to be over, there will be no recurrence. The strategies we just heard by Naji very nicely being summarized from the metastatic setting next to all the different endocrine therapies, and very recently also more SERDs. We have SERDs beyond fulvestrant with the oral SERDs coming about in clinical trials right now. And then we have the added value with PIK3CA mutation antagonists and mTOR inhibitor or CDK4/6 inhibitors. And given the standard of care in the metastatic first-line setting is now CDK4/6, it's quite reasonable to look at CDK4/6 inhibitors also in the adjuvant setting. As we just heard, there's 3 of these drugs and they're given in a different way. Abemaciclib continuously, the other 2 with 3 weeks on, 1 week off. And we do have different side effects with abemaciclib having less grade 3 and 4 neutropenias, but more diarrhea. The data in the metastatic breast cancer setting, I would say, and that's also the way we phrased it in the recent ESMO metastatic breast cancer guidelines, the data in the metastatic setting between these 3 drugs is quite comparable. If we look here at the first line setting, obviously we have to say that ribociclib trials have read out, and they're both Mona Lisa 2 and Mona Lisa 7 have reached their primary endpoints, and there is an overall survival advantage also in these trials, and Paloma 2 and Monarch 3 have not yet read out, so we have to wait a little, but I think that these trials will read out over the next year or so. So I think there we will have some data on overall survival also for palbociclib and abemaciclib in the first line setting. The adjuvant trials that we've seen so far are 2 trials for palbociclib, 1 for abemaciclib, and the Natalie trial has been fully recruited yet it has a slightly different design. Let's look at the palbociclib studies first. The PALAS study was presented again at San Antonio by Professor Gnant from Vienna and published simultaneously the final analysis also in JCO. PALAS is a trial of 5,600 patients, 2 years of palbociclib versus just the endocrine therapy alone. And if you look at the risk profile of these patients, we have to say that they are at somewhat high risk, but not completely so. If you compare the PALAS collective to the Monarchy collective, PALAS has about 70% of the patients in PALAS have the same high clinical risk as the Monarchy collective. And interestingly, if you look at the histological grades, these tumors are not the most aggressive ones if you look at them, if you sort of correlate also grade and Ki67. The data we saw at San Antonio showed that there was no impact on IDFS or distant relapse-free survival of giving palbociclib in the adjuvant setting. And this absence of benefit was also there independent of clinical risk. So there was no indication that patients with high clinical risk benefited more than the ones with low clinical risk. Also, the other subgroups, there was no subgroup where we definitely could say that there is a high benefit. As you all know, the discontinuation rates in PALAS have been somewhat higher than in the other trials, not because the investigators didn't keep their patients on the trial, but because the protocol had very strict demands for dose reduction and then taking patients off the trial because of the neutropenia issue. And therefore, one of the investigations the PALAS trialists did was to look at exposure and discontinuation as a factor of efficacy. But as Professor Gnant showed us in San Antonio, there was no indication that this had anything to do with each other. In patients who stayed on palbo for the whole duration and had the highest dose intensity, there was also no indication of improved IDFS. The second trial with palbociclib in the early breast cancer setting is the Penelope-B trial, which is a bit unique because, first of all, it's only 1 year of palbociclib. Second of all, it's the only placebo-controlled trial in this setting. And third, because it took patients after non-PCR, after neoadjuvant chemotherapy, and not just any patient with non-PCR, but patients had to have a certain tumor volume left over as defined by the CPSEG score, which is also something that you will see later in the Olympia study was used. And here again, we see that Penelope-B, there was no indication that palbociclib impacted IDFS. And also, if you look at the different subgroups, there is no subgroup where we see that there could be a benefit. The third study that had reported out, and then the only study so far that had shown benefit of a CDK4/6 inhibitor in the early breast cancer setting is the Monarch-E study, which has a slightly different design because it prospectively also involved a biomarker, a Ki67 proliferation rate, and it had two cohorts. The first cohort was just patients with a high clinical risk, 4 and more lymph nodes or 1 to 3 lymph nodes, large tumors, grade 3. And the second cohort were patients with 1 to 3 lymph nodes and just high proliferation as defined by Ki67, 20% or higher. And this cohort has not been fully reported because it started about a year later than the rest of the study because the standardized test first had to be implemented and validated. So that's why in the Monarch-E study, there's a couple of different populations. We have the ITT population, we have a safety population, and then we have the Ki67 high populations. And all of these outcome parameters were pre-planned in the protocol. Again, in this study, about 5,600 patients, one-to-one randomization. We can see here if you look at the Ki67 determination. In all of the other tumors, if there was tumor tissue, the Ki67 was determined, and about a third of the tumors had low proliferation, and slightly over 40% had high proliferation. And as was not the inclusion criteria, except for cohort 2, there were also patients where there wasn't enough tissue to do Ki67 centrally. You've seen the efficacy analysis already. Dr. O'Shaughnessy presented them at an ESMO virtual plenary last September. And we did see that with the longer follow-up, now 27 months median, which is more than the treatment period for the first time, we see that the observed benefit that we saw in one of the earlier analyses was maintained, and there's about a third reduction in the risk of developing an IDFS or distant relapse-free survival event, with an absolute benefit at 3 years of 5% for IDFS and 4.2% for distant relapse-free survival. If we look at the subgroups, we do not see any subgroup where there is absolutely no benefit. There are some subgroups with very large confidence intervals, the smaller subgroups like the low grade, for example. But if you look at the hazard ratio over time, we see there's an increasing magnitude of benefit, and it's now maintained also beyond the study period. So unless unlike in the Penelope B study, there is no indication that the treatment arms are going to come back together again. If we look at the Ki67 cohort, what we see is here that in the high Ki67 population in the lower right-hand corner, you have an even higher benefit. These patients do a little bit poorer than the low Ki67 tumors, and you see here an absolute benefit of 7%. So Ki67 in the monarchy study is prognostic, but it's not predictive. So if we look at the trials and look at the differences, we have to say that the designs were different, the drugs were different, the patients who stayed on medication for the complete duration of the trial period was the lowest in the PALLAS study, but as far as we can tell, that didn't influence outcome parameters. And I think we need to have a lot of translational research, and that is already ongoing, as Professor Gnan said, in San Antonio. Then we have to see whether maybe just luminal B tumors benefit and not the luminal A tumors, but this is all hypothesis generating. So Dr. Mayer in her conclusion said that obviously the 2 years of abemaciclib did improve outcome in pre and postmenopausal patients. The question about the Ki67, which in the US hasn't been common so far, is how should we test it centrally, locally? There's a companion diagnostic approved by the FDA, but we don't know how EMA is going to see that. We expect a European approval later this year. And the question is whether only patients with high Ki67 should take abemaciclib, and Dr. Mayer said probably not, because there is no predictive effect of Ki67. They just have a lower risk of recurrence because the tumor's proliferation rates are lower. And the last question she asked, and that's why I decided to put my two talks together, because they sort of can be also discussed together, is how do we reconcile the adjuvant abemaciclib use with the olaparib use from the Olympia trial? And with that, I would just like to go into the second part of my presentation, where I looked at the topic Dr. Tudd summarized at San Antonio in his educational lecture about the PARP inhibitors. As we all know, PARP inhibitors work very well in BRCA 1 or 2 mutated cells, because there is already a part of the DNA repair missing. And then if you give a PARP inhibitor and inhibit the second way to sort of repair DNA damage, then the cell is killed. And there's a very nice example here in his talk with the table. If you take away 2 legs, then the table just collapses. If you're more interested in sports cars, you can also say you take away 2 brakes from a car, then that isn't safe to drive anymore. The reason why we looked at olaparib as a PARP inhibitor in the early breast cancer setting obviously comes from the metastatic setting, just like in the CDK4/6 inhibitor space, where we saw both for talazoparib as well as for olaparib that there was efficacy which was better than monochemotherapy in luminal metastatic breast cancer. So the Olympia trial looked at triple negative and luminal early breast cancer. I'm just going to focus on the luminal part, and the patients with hormone receptor positive tumors were included if they had a non-PCR and a CPS-EG score of 3 and greater. That means there wasn't just a little bit of tumor left, but node positivity and so forth. And the other tumors that were included were just hormone receptor positive disease with 4+ lymph nodes. Patients were randomized 1-to-1 olaparib for 1 year versus placebo. If you look at the BRCA mutation status, there's more BRCA1 mutation status than BRCA2 mutations. And if we look at the hormone receptor status, we have to sort of acknowledge that there is only about 20% of the patients which were hormone receptor positive. Patients did have standard chemotherapies, most of them anthracyclines and taxanes, so very state-of-the-art pre-treatment. And given that their mutation status was a prerequisite, there's obviously more pre than postmenopausal patients. You've seen the survival data. This is the primary endpoint. There's a significant and clinically meaningful improvement in invasive disease-free survival with a hazard ratio of 0.58. No doubt that that is significant. And if we look at the subgroups, we see that there is just less hormone receptor positive tumors. The confidence interval is very wide, but as Dr. Tutt pointed out at ASCO and now also in San Antonio, the test for heterogeneity is not significant. So there is no reason to believe that the hormone receptor positive tumors derive less benefit. If you look at the first IDFS events, there is a substantial reduction of distant recurrences, about half of the distant recurrences in the olaparib arm versus placebo arm, and distant recurrence in early breast cancer is something that patients will die from eventually. So this is a very, very clinically meaningful result. There were a couple of patients who already had a longer follow-up. The other data was presented rather early, and this is a median follow-up of 3.5 years, which is substantial for triple negative, probably not long enough for the hormone receptor positive population yet, but the hazard ratio is 0.61, so very, very stable results. As the IDFS was positive in this sort of statistical step-by-step design, then the other parameters could also be tested. The alpha was recycled for future analysis, and you can see here in distant disease-free survival, hazard ratio of 0.57, very strong benefit, and absolute difference is 7.1% at 3 years. And the overall survival, very early, fortunately, I have to say, for the patients, but still already we see about a 4% difference at 3 years. So it's going in the right direction. It's just very early. So the side effects is obviously important. If we change something in the early breast cancer setting, we can see here, we know what PARP inhibitors do, that there is hematological toxicity and a little bit more fatigue than in the control arm. And here we see that the very severe side effects that we are afraid of, like new malignancies or MDS, AML, there is no indication that that is increased in the PARP inhibitor arm. And I think the strongest data, one of the strongest data, is the quality of life, which we saw again at the San Antonio Breast Cancer Symposium, and there's just no difference between the curves. If we look at the distant disease-free survival with this strong impact, that was the reason that this is now included in several of the international guidelines. And again, if we look at the question, can we be certain about the hormone receptor positive population? I think the data from the metastatic setting, and this is from the Talazoparib trial, shows very nicely that there is just no difference. It's the BRCA mutation that drives the tumor aggressiveness, and that is being targeted independent of hormone receptor status. And then obviously for the future, what we have to keep in mind, and this is a very small but very important trial looking at different germline mutations, and we see that PALB2 mutations also benefit very nicely from olaparib. There's also from this trial data for the somatic BRCA mutations. And given the fact that there is no reason to do another randomized trial giving these results, I think we need to, once we have the approval for olaparib, we also need to extend the benefit to these patients. There's only going to be few patients that are being added, but I don't see a randomized trial being conducted. And with that, I would just like to take the summaries from Dr. Mayer and Dr. Tudd. And Dr. Mayer here suggested very nicely for the postmenopausal patients, if you just look at the right-hand side, in patients with high oncotype or high mammoprint risk or high clinical stage, that abemaciclib could be used, and olaparib for the BRCA mutation carriers. I agree with her on that. I don't agree on the use of mammoprint and what she writes about the oncotype. I think we should use short preoperative endocrine therapy in addition to the genomic tests in order to see who benefits from endocrine therapy before finalizing the individual treatment concept. And the same is true in the premenopausal patients, where again, I agree that we should use abemaciclib or olaparib, but I do not agree that we should give chemotherapy to most of these young women, because I think that this short preoperative endocrine therapy, which we did in ADAPT, or the English colleagues in the POETIC trial, is a way to save young women from chemotherapy. And just to close my talk, I would just like to remind you of the ADAPT concept, where we looked at oncotype and then 3 weeks of endocrine therapy, and then looked at surgery at the proliferation. And everybody who had an oncotype below 26 and good proliferation response did not get chemotherapy. This wasn't our invention. As I said, we looked at what our English colleagues had done. This is from the POETIC trial, where we see with the middle green curve, patients with initially high proliferation, 2 weeks of AI, and then proliferation response do very well compared to patients without proliferation response in the orange curve. And in the ADAPT trial, which was shown by my colleague Oleg Lutz at ASCO and is now going to be published in JCO very, very soon. If you just focus on the left-hand side, young women up to 3 lymph nodes and endocrine responsive tumors and an oncotype below 26, distant disease-free survival at 5 years of 97%. There is just no reason to think about giving them chemotherapy. And the chemotherapy treated patients with endocrine non-responsive tumors is the red curve. It wasn't a randomized comparison in the trial, but shows very nicely that endocrine response is something that makes the tumor aggressive and less responsive to endocrine therapy. In the older women over 50, there was just 15% who did not have endocrine responsive tumors. But if you look at how the curves sort of overlap, that at least saving them from chemotherapy is probably appropriate, and maybe some of the endocrine non-responders could have done without the dose-dense chemotherapy. If you forget to give these 3 weeks because the patient wants immediate surgery, you can always use this algorithm to calculate a probability for endocrine response. It's in the net, it's in the web, it's free of charge, and it's based on the ADAPT dataset. So with that, I'm just going to come back to tell you that there is more trials ongoing with CDK4/6 inhibitor. It's the ADAPT cycle trial, which based on ADAPT, and it's also looking at chemo versus endocrine-based therapy with ribociclib, and ADAPT late based on Monarch E, but targeting patients who are already 1 to 6 years out from their initial start of endocrine therapy in order to see whether we can also avoid late relapses by adding abemaciclib for 2 years. And our English colleagues are looking at endocrine non-responders and adding abemaciclib in these patients. So in summary, high-risk luminal early breast cancer is an unmet medical need. I think the Monarch E data nicely shows that abemaciclib is a new therapeutic option. Similarly, I think the Olympia study shows that olaparib in the BRCA mutation carriers in the luminal breast cancer space is also a good therapeutic option. We don't have registration yet outside of the US, so we have to wait for European registration. But I think that we can already start in very high-risk patients. At least that's what we do in Germany. We ask for reimbursement on an individual basis from the insurance companies. So in summary, are these ready for prime time? I would say yes. There's a lots of buts. We still need regulatory approvals. We need reimbursement, and we need trials to address the remaining open clinical questions. And with that, I would just like to thank you for inviting me again to your meeting, and thank you all for your attention.
Thank you, Professor Harbeck. It was fantastic. We have a couple of questions, but I will start first with the first question regarding that. You presented nicely for the first talk regarding that. We have 3 studies regarding the hormonal therapy, CDK4/6 for early breast cancer, and you presented as well that we do have the Panoply and PAL study. It was negative study. However, the abemaciclib, it was the study which has showed that those patients can benefit from it with IDFs, and still we don't have overall survival. So my question that this confusion is we now will move from the metastatic setting to the adjuvant setting for hormonal patients, and you specified for the high-risk population as well. So this is not make any confusion that we do have 2 studies came negative, and it was also in the subgroups about 29% in the PAL study, there was patient with high risk. However, the majority it was pre-specified in the ABEMA study, and this may explain the point that if we are moving now from the metastatic to the adjuvant, and we know that we have a toxicity profile hard for this medication, we are confident to starting use CDK4/6 for this patient, and also we do have the exemestane, and also we have letrozole for this patient. We have the SOFT study. We have plenty for the high-risk population regarding hormonal. So what do you think? Can we start it from now in our clinic, or we have to wait?
I think I mean, I'm prejudiced because I'm in the executive committee of the Monarch E study, but I think the data are ready for prime time for the high-risk population. I do not agree with the FDA. I don't think Ki-67 should have been a decisive factor because there is no prediction of benefit. It's just that the slowly proliferating tumors, the relapses will come later, so they do a little bit better in the beginning. But abemaciclib also works in tumors with low proliferation. So I think abema is ready for prime time. I think it's also ready for prime time in the young women. I know in your region you have a lot of young breast cancer patients, and we're right now preparing a disclosure on the premenopausal patients, looking at the different endocrine therapies that were used and also the specific benefit in these young women. So probably by mid of this year, we will have some data there that you may find interesting. And I'm not confused by the palbociclib data. I think the data we've seen are very clear. There is just no benefit. And I mean, if you look at the metastatic setting, there is slight differences between these drugs. The abemaciclib works in endocrine resistance, be it primary or secondary endocrine resistant patients, but the Paloma-3 study, the only efficacy with regard to survival is in the secondary endocrine resistance, so not in the primary endocrine resistance. So maybe there is just a difference in these drugs, and what we're seeing is exactly that. And also the continuous schedule may be important in the early breast cancer setting. So I think we should offer this, because patients with a high risk luminal breast cancer, they don't do so well despite chemo and endocrine therapy. The curves are dropping, and also patients with a high risk genomic test in the RxPonder study or in the MindAct study, the tumors are not doing so well. So I think we need to improve here, and abemaciclib seems to be a good way to do that.
Thank you, Dr.
And why 2 years, not 3 years?
The 2 years, I mean, the 2 years we chose, I can only speak for the monarchy, but probably the other colleagues had the same idea. The 2 years we chose because this is sort of what we say defines a primary versus secondary endocrine resistant. We cannot give these drugs forever, and we will see whether 2 years is optimal. The Natalie study is investigating 3 years. So we'll still need more information. Now we have one positive trial, but we still need more information about subgroups, about duration, like you point out, whether ribociclib is also effective in this setting. So there will be more trial data coming.
Thank you, Dr. Nadia. We'll keep the question till the end of the session. Now I am too pleasure to introduce our last speaker today. Is our teacher, Dr. Tahir Tuwaijri. He's a medical oncology consultant, senior medical oncology consultant in Faisal Hospital and Research Center in Riyadh. He will speak about triple negative update, biology and management. So the floor for your doctor.
Slide. We start while we back to ready? Yeah, I think that discussion was nice. Anyway, first of all, I would like to thank Dr. Malkhair for organizing this. I am part of scientific committee also and organizing committee. At the same time, I would like to take the thank to Gilead company for this satellite symposium. But I promise you, this satellite symposium is more teaching for our patient population. There is not much controversy, and you feel at the end of this talk that you learn something very, very important for your patient. Now, over the next 30 minutes, I'm going to talk about a new kid on the block. At the same time, the title of this talk is Thanks Monkeys. So we have monkeys also in this talk. First of all, this is my conflict of interest, and you can add one of them. Advisory rule is the new company, which is called BOMA. I am involving in basic research with them. This is my disclaimer. For the company, they have nothing to do with the content of any of this talk. And you have to know that the medication, which is SASI, is not approved at any country in the Middle East. So it is good to learn about this molecule. Other things which is for all of you, this is the first time that we are going to talk about the new pathway, new signaling. For the last maybe 30 years, we are talking about the tyrosine kinases. Now the tyrosine kinases era is gone. We are starting a new era for teaching our juniors what is the signaling pathway in this area. So today, this is the first talk from myself to the community at the Kingdom of Saudi Arabia to learn about the new signaling. Now, first of all, as you can see here, this is the classification-based treatment. And as you see, today, all our talk is there any pointer? Well, no pointer. As you can see here, the spectrum, yeah, okay. So here we are, this one, yeah. It's not working. Anyway. Yeah, it is, I think that, okay, sure. Today, all our talk is on the spectrum of the breast cancer from, as you can see here, from Lumina A, Lumina B, and HER2 positive disease and triple negative. So today, my talk, it is only on triple negative, which is the spectrum, which is known as high mutational load. Now, any tumor with high mutational load, they have, when you are targeting them with the chemotherapy or target therapy, they have something which is called the DNA damage. And then the DNA damage response activate very certain cells, which are natural killer cells. We have a delta and gamma T cells, macrophage, and natural killer T cells. Once that it is appear or activated, they go to the cancer cell and they kill them. What happens with that, the lymph node or lymph nodes or lymphatic system in general, they are generating the CDK8 and CDK4 T cells. And just it is a circle of treatment maneuver for killing the cancer cell. So this is for any high mutational load, which is such as the triple negative and some of the HER2 positive disease. Now, the strong pressure from the immune system, as you can see here, leading to activation of the BDL1 and BD1, and then the CTL4, and all of them, leading to activation of the signaling pathway and kill the cancer cell. Now, we know that the triple negative disease is highly heterogeneous. Well, the most important that the benefit of standard chemotherapy is far from the satisfactory. We know that. Now, just today, I'm going to share with you 3 kits. The first one, I'm talking about triple negative established. I'm not going to talk about the emerging, but I will tell you where are the emerging are today and how far from reality in the clinic. So the PARP inhibitor, which is BRCA-associated cancer, this is kit 1, which is olaparib. And then we have immune checkpoint inhibitor, which is Pembro. And the kit number 3, which is the youngest, is sacituzumab, which is the antibody drug conjugate. And the emerging, as you can see here, it is class of PI3KC, AKT, mTOR, and so on, androgen receptor. And the new era today, we are the first time that we are talking about it, is CAR T cell therapy. And I will show some of this study. And we are at King Faisal. We have the unit and the setup now for the CAR T cell. And we have a very good opportunity to involve with the triple negative in this. And I am trying hard to involve in this maneuver. And I will show you some of slides at the end. Now, this is, as you can see here, it is nicely triple negative heterogeneity. We know that. What we have a conventional chemotherapy, as you can see here. We have a target strategy. We have a novel formulation, and we have immunotherapy. Now, when we are looking for the one has been established, as you can see here, is PARP inhibitor. This is established. And then the second one is the Bembro for the BDL1. And then we have the SASI as antibody drug conjugate. Anything else you see around this is emerging, right? And it is coming soon, maybe 5, 10 years, 15 years from now, but they are emerging. I will show you the big picture of it. Now, the other thing is, which is very important, that this is now we classify the cancer cell, as you can see here. We are classified to cancer cell intrinsic feature and cancer cell extrinsic feature. For the one which is inside, as you can see here, we have 2 confirmed, which is BRCA1 and BRCA2 mutation. And I am not involved with the NTARP fusion today, but we are going to talk about olaparib for BRCA1 and BRCA2. The other things that for the BDL1 and the tumor cells as well, the TROPO2 has been established. So today we are going to say what is established and what is emerging. This is the big picture. The big picture of this, as you can see here, the BRCA inhibitor, which is BRCA mutation, olaparib in details. And if it is tomorrow, I'm going to talk on details about the PARP inhibitor evidence to date. The other things which you see here, the immunotherapy, which I am talking about the Bembro. And then we have a couple of antibody drug conjugate, at least 6 or 7 in clinical trial. The first one has been rich, is SASI, but you look for the trastuzumab deruxtecan, which is in HER2. It is another kid coming on the board soon. And then we have the TARC inhibitor. I am not going to involve this, but look for the whole picture. You have the BI3KT, for the high vulnerability for the triple negative disease. We have the AKT, we have the mTOR, we have the MYC, we have the androgen receptor pathway, and we have a CHEK1 and CHEK2, we have a WAY, we have a CDK4 and 6, and so on. So as you can see from here, we have today 3, but we have at least 6 or 7 other classes. It will be emerged soon in the treatment of triple negative, and a majority of them in phase 1 and phase 2 clinical trial. Now, when we are talking about triple negative, which is a remain area of unmet need, okay, this is the data from the French statistics for more than 20,000 patients. As you can see here, for the triple negative, the median overall survival is 14 months, while the patient who is HER2 positive disease, the median overall survival is about 50 months. But for the one who is HER2 positive, HER2 negative, the median is about 43 to 44 months. Again, as you can see here, triple negative is a big issue. Now, this is the treatment landscape, and I'm just talking, guys, on the metastatic. The single agent, as you can see here, this is what you are doing for the last maybe 20 or 25 years. We are giving taxane, capecitabine, vinorelbine, eribulin, and so on. Today, we are adding to them Bembro and olaparib, and then the most importantly, the new kid is the sacituzumab. Now, is there any optimal first-line chemotherapy? So far, the benefit of standard chemotherapy is far from satisfactory. You don't believe, and myself and Dr. Dahsha Jaram and the others, we are believing that the first line for progression-free survival, it is about 2 months if you have first line, or 3 months, and then second line is 2 months. And if you are giving the combination, it's 3.5 months. And if you are giving second line, it is about 1.8. Now, given the fact the overall survival, as you can see here, in general, first and second, it is between 8 to 12 months. So that means this is dismal to some extent. Now, Is there any platinum agent preferred for triple negative? Now, we have a clinical trial that showed that the progression-free survival, for paclitaxel and exapicolone, it is about 9 months. Now, when we are using the combination, and we are using this one in our clinic, using Gemzar cisplatin or paclitaxel cisplatin, the median overall survival, it is about 16 months. So that means it is still, we have a problem, with this patient. Now, the first thing that I am going to share with you, the one who has been established, the kid number 1, which is olaparib. As you can see here, it is BRCA1 and BRCA2 mutation. Tomorrow, we are going to do this exercise in full details, including the biology. Now, as you can see here, who has been approved by the FDA? Olaparib is number 1, ovarian, breast, pancreas, prostate, and the Talazo is breast. Rucaparib, it is only ovarian, and niraparib, all of them, it is just one molecule. Tomorrow, we are going to say, or we are talking why it happens like that. Now, this is the Olympia trial. It is phase 3 clinical trial, patient with metastatic breast cancer. As you can see here, a patient with HER2 negative, ER positive or PR positive, and the triple negative, they have a germline mutation, not somatic. And then, they have less than 2 prior chemotherapy and, 1 or more of the endocrine therapy. And they're randomized for olaparib versus chemotherapy. And the primary endpoint, as you see here, the progression-free survival. We will go quick on this. If you see that olaparib versus the best of the physician choice, 7 versus 4.2 point for the patient with the progression-free survival. And then this is the spectrum of the side effect. I'm going to talk about this tomorrow in full details. And this is the update or overall survival. And as you can see here, the overall survival for olaparib, it is about 19 months versus 17 months with the hazard ratio of, I cannot see that, where is, and the hazard ratio of 0.84. This is the whole spectrum of progression-free survival versus overall survival. As you can see here with the chemotherapy versus no prior chemotherapy, and still the hazard ratio in the range of 0.65 and 0.56 if there is no chemotherapy in progression-free survival, and there is no benefit prior chemotherapy for the overall survival. However, if there is no chemotherapy, the hazard ratio is 0.5, and there is a difference 14.7 versus 22 in favor of olaparib. This is the conclusion, just, as mentioned, that, olaparib established as a management of breast cancer, who has a BRCA mutation proven as a germline one. Now, the second one that it has been established, as I said, is the Bembro. And the Bembro, this is a clinical trial of immune checkpoint inhibitor, advanced stage triple negative. This is the monotherapy. As you can see here, the overall survival, it is rich between 5 to 18% in the majority of cases of the pembrolizumab. Here, the one that Pembro versus Atezo, as you can see here, the first line, both of them, complete response and partial response is 23, and it is 4.7 for second line, and Atezo the same thing, which is not that great. Now, when you are looking for the whole things, for the whole patient population, for the monotherapy, as you can see here, the median progression-free survival is small, between 2 months up to maybe 4 months. And also the overall survival and the median survival also, it is in the range of 11 to 14 months. Now, the largest study that looked for the Keynote 119, where there are 622 patients has been randomized, as you can see here. The overall response rate, it is almost about the same. It is 10 versus 10. And you know, the median progression-free survival, 2.1 versus 3.3, and about 10 months for median overall survival, indicating that using as a single agent is not great. Now, this is the keynote. We have Impassion 130, Impassion 131, and I am going to talk about the 355, which is the Pembro. Since, you know, as you know, that Atizo has been removed by, you know, the company, and it has been removed by the FDA, that they are not going to be used anymore. This is the 355, where you have a patient with centrally, it is triple negative. Previously non-treated, it is first-line metastatic, but they allow for neoadjuvant and adjuvant more than 12 months. And they are randomized for Pembro plus chemo versus placebo versus chemo. And then the progression disease survival, that's, you know, the first primary endpoint. Here, just to show you one thing which is very important for us, that in this clinical trial, I mean, the PD-L1 positivity, who is more than 10%, is about 38.9. So we are expecting in your clinic that you have this number. Our data from the King Faisal, that we have about 28%, which is more than 10%. And again, here, de novo is about 30, less than 12 months, primary resistance, secondary resistance, 22 and 47. As you can see here, intention to treat, it is about 7.5 versus 5.6 in progression-free survival. And if it is more than 10, the positivity of the PD-L1, it is about 9.7 or 10 months versus 5 versus around 6 months. Again, here, if you are looking for the one, it is between 10 and 19. It is around 9.9 versus 7.6. And the one there, if it is more than 20, it is 9.8 versus 5.4. So this is the overall survival, as you can see here, 17.1 versus 15.5 with the hazard ratio of 0.89. And then if it is more than 10, it is become higher, which is 23 versus 16.1. And the hazard ratio, it is about 0.73. Now, this is the adverse. Tomorrow we are going to talk about this in more details. And the summary conclusion based on this data, the Pembro has been approved, and it is approved, you know, for metastatic breast cancer. And we are using the CBS more than 10, and you are expecting that, you know, it is around 25% of your patient you see that they are going to be eligible for this. 75, it will not be, which is important for calculation of the budget. So this is the Pembro, you know, chemotherapy versus triple negative. It has been published in 2020 recently in December. Now, the one that it is emerging as a new kid, it is sacituzumab. So just a little bit of concentration about this, because this is a new, all this is a new data. First of all, to learn about the science, first of all, this is the number of antibody drug conjugate created for a human since 1997. And which has been approved, as you can see here in the blue, is 1 in 2011 and 1 in 2013 and 2 in 2017 and 3 in 2019 and 2 in 2020. After this hard work in the lab, as you can see here, some of the antibody drug conjugate in 2018 and 19 reached about 23. The total budget of this exceeding $90 billion to initiating such this study, okay? So look for the antibody drug conjugate since 1997 until now. We have a few of them. And indeed, For breast cancer, we have the TDM1. We are using everyone. Now, we are talking today about the beautiful new kid, SASI, and the trastuzumab deruxtecan. It is coming soon. So we will have 3. Now, other things which is very important, as you can see here, for the SASI has been accelerated approval for the need of triple negative. It is not of the drug, but the FDA approved this molecule because of the need. And that one, it was in April 2020. And then the final regular approval, it happened in April 2021. Now, I need you just to concentrate about this is the next maybe 4 or 5 slides. It's very important for every physician in this country. Now, the other antibody drug conjugate, as you can see here, antibody, a linker, biload, and the conjugation. Who is the antibody? It is target antigen selectivity. We will see that. No immunogenicity, stable in plasma, has the facility for internalization. Who is the linker? Stable in plasma, degradation or of releasing biload after internalization, and it should be ideally hydrophobic. Now the biload, it is sub-nanomolar toxicity. It should not be there, stable in target cell. The conjugation site, it is non-interruption of antigen binding. And the conjugation, they have to have all these character, high conversion, mild condition, and so on. So this is what is the ADC in our future practice. Now, when we are coming to a mechanism, structure and mechanism, as you can see here, a monoclonal antibody, it should be humanized or fully human. Linker, is it cleavable or non-cleavable? The biload, which is anti-mitotic agent, and for SASI, it is SN38. Now, it is very simple. The key factor, high potency, high cancer cell specificity, low immunogenicity, and so on. Now, how they work? Binding to surface antigen, endocytosis of antibody-drug conjugate complex, lysosomal degradation, release of active biload, in our case is SN38. And then DNA or microtubule disruption. I think that it is very clear and easy, the mechanism of action. Now, I would like to tell you about the TROP2 now, okay? This is maybe a 30 minutes talk for the biology of the structure of TROP2 mechanism. One point I want to look at it exactly. First of all, you see 8193 to 8214 until 2022 get SASI. It takes from 1981. It is very important to know there are 3 parts: extracellular epidermal growth factor like repeat domain, as you can see there, and there are 274 amino acids. And then we have a transmembrane domain, which is 22 amino acids. And then we have the cytoplasmic tail, which is 25, amino acids. You see that? Now, so we have a single peptide, which is about 26 amino acids. Very interesting, this molecule, they have a cysteine-rich and a resistant-poor domain. And all of them, they have a different amino acids. And then we have a thyroglobulin type 1 domain. Now, the most important part of this, you see the whole mechanism of action that we are doing in the clinic based on the phosphorylation of 303, which is the serine. Anything else is garbage. This is the only side make the drug is working. If it's not able to phosphorylate there, it will not work. So from whole picture, how the human being creating the antibody drug conjugate based on 1 amino acid, which is 3.3, as you can see there. Now, to finish this is the TROP2. TROP2, it is a humanized RS7. Remember this? They have SN38 biload,
And the linker is also, the linker is SN38. And this is the picture of it. It is one of the strongest antibody drug conjugate that we have to point. First of all, it is high drug to antibody ratio. It is 7.6, which is more stronger than the TDM1 by 2 times. It have bystander effect, as you can see here. All of this from SN38. Just to tell you one thing which is very important. Now, if you are looking for here the humanized monoclonal antibody, which is RS7, and then we have the SN38, and the linker is called CL2A. So you have to remember these three. The humanized, that's okay. That you see that, you know, the RS7, SN38, and then the CL2A linker. So you see that, you know, the linker. So the sacituzumab is binding to TROP2, they will inside. They do the lysosomal degradation, they release the SN3, they go to do a single strand and double strand DNA break, and I am going to talk about this tomorrow, and they are releasing to kill the cell. In the same time, they have a strong bystander effect to the neighbor cells. So this is the first time that we have a strong antibody drug conjugate. For humans, they have this function. Now, who is SN38? How it come the CL2A linker? As you can see here, this is which is called Tank's monkey. This is the first time in history that monkey give us a drug for treatment, okay? So what happens here? They have two SN38 derivative, which one the SL2, SN38, and CL2A. So the first one doesn't work. They tested in 5 different solid tumor, and specifically for which is called cynomolgus monkey. And this monkey, as you can see here, shown the similar tolerability, as well the pharmacokinetic as in human exactly. So they move from monkey to humans to have the sacituzumab. This monkey is unique. This is the weight of this one. This is a female, and the weight of them is 4.8 for female and about 7 kilo for the male. So for this clinical trial, this monkey has been used to generate the sacituzumab for humans, okay? Now, how is the mechanism of action? This is the first time that we hear about a molecule that it is extracellular, intracellular, as you can see here. This is the TROP2. They are causing cell growth, invasive angiogenesis, cell cycle progression for the first time through the modeling of the calcium cascade. So the calcium cascade for the first time that we are talking for the management of cancer, that leading to activation of RAS-RAF mitogen activated protein. In the same time, I'm not going to talk about much because, you know, also this TROP, they are activating something which is called RAC1, and in the same time has the facility to activate or reducing the fibronectin adhesion and activate the beta-catenin and increasing the cyclin D1. So basically, this is the first time that we have a molecule working like this. We never heard about it. Calcium signaling, fibronectin, and, you know, integrin and beta-catenin. We never heard about this. This is the first in breast cancer. Now, this is the trial, as you can see here. Sacituzumab, 10 milligram day 1 and 8 every, metastatic triple negative. They have more than 2 chemotherapy. Other, you know, use whatever for capecitabine, eribulin, and so on. The primary endpoint was progression-free survival. Now, this is the first time that we are not using tables. Where you can see, this is the total of patient of 529. Patient without brain metastasis is about 335 versus 233 for who received chemo. And patient who has brain metastasis, 32 versus 29. Now, this is a unique, again, as you can see here. The patient they receive at least, maybe 4, some of them from 2 to 17 lines of therapy. Progression-free survival, performance stats is excellent. As you can see them at around 50 in terms of the median age. BRCA mutation are very small. Triple negative, as you can, 70% at the diagnosis, and the who has been converted is about 36. The majority, they have lung and liver metastasis. Now, when you're looking for the progression-free survival, here it is easy to see that it is for the patient. This is the group without pre-metastasis. As you can see here, it is 5.6 versus 1.7, 59% reduction in the chance of disease getting. A patient who has pre-metastasis, they are 4.8 versus 1.7. Again, here the overall survival, 12 point, it is almost the double, which is 52 reduction in the chance of dying. Who has, with or without, it is 11 or 12 months versus 7 months with 40%, 49% reduction in the cancer of dying. Now, the tumor response, as you can see here, it is very important. And again, this is the first time that we see something like this, 31 versus 4%. Now, when we are coming to the safety, as you can see here, the majority, 98 and 86, they have at least one event. Now, when we are looking for the percentage who have serious, or you can say dose reduction, it is 22 versus 26, it is less in sacituzumab. And the percentage of the patient is, as you can see here, who stopped the medication is a 5 and 5. This is a very important slide, guys, where, as you can see here, diarrhea and nausea is almost about 59 versus 12 and 57 versus 26. And there is alopecia, fatigue, and anemia, and all of this we need to know how to deal with that. Neutropenia is 63%, and again, in the one which an experimental arm, and the physician choice is about 43%. Now, side effect severe, life-threatening, as you can see here in numbers. So there is some concern about toxicity that we need to learn about it, and I will come for that. And this is the spectrum of the sacituzumab: fatigue 51, diarrhea 59, vomiting 51, and nausea 74, and anemia it is 55 in generally. But grade 3 and grade 4 are less than that. Now, when we are coming to survival outcome, the progression-free survival, this is in curve, as you can see here, less than age of 65, it is 4.6 versus 1.7. As you can see here, the hazard ratio is 0.46, which is amazing. And then who is above age of 65, 7.4 versus 2.4, and the hazard ratio is only 0.22. Now, again, when you see for overall survival, this is something which we're the first to see in triple negative disease, that it is 11 months versus about 7 months, and the hazard ratio is 0.5. And then the patient who is more than 5, it is the hazard ratio is 0.37, and again, 15 versus 8 months. Now, when we are looking for the whole spectrum here, the progression-free survival, comparing SASI versus eribulin, capecitabine, GEM, and so on, as you can see here, the hazard ratio in favor of SASI by 0.41. And then here, the overall survival, 12, and the others is almost about 50% reduction in death comparing with the others. Overall, and again, the response rate, as you can see here, is dismal for the chemotherapy versus the sacituzumab, which is almost about 35%. Now, this is, they look for the TROBO2, high versus medium versus low, and you can see from this that the higher that, the chance of response is higher. Now, this is a very important for, remember this. Now, for the patient with acute diarrhea, it can happen immediately during the infusion.
So please, you have to have onset. That's okay. No, that's fine. So the onset of during or shortly after the infusion, you have to have atropine 0.2 milligram IV every 15 minutes. We are giving for 2 to 3 doses if required. Subsequent doses of the atropine, additional prophylactic with atropine, and so on. Now, the one that they have delayed onset, okay, start loprimide, 2 milligram after, which is the routine of us, and then you have to look for the diet. Now, the diarrhea resolved, yes versus no, we go for that direction. But importantly here, if you have grade 3 where to consider hospital administration and begin intravenous, you have to give octreotide in these molecules. So that means, here, addition of octreotide for the management of diarrhea is essential for somebody who has a diarrhea issue. Now, when we are looking for the neutropenia, they have a very special program based on FDA approval. If you have, NCA less than, they want how you are looking for this, day 8, how you are looking for this, how to hold the treatment, severe diarrhea, you are held until the grade and so on. And I think something like this should be, just take a print of it, give it to the nurse, education of the patient. It is required, to use this medication. But I think, generally speaking, it is well-tolerated medication. So this is the studies. So one now it is running, as you can see here, when we are looking for SASI with the other clinical trial, it is almost about 25 of them. This is how the publication in the triple negative, and this is the ASCO guideline. It is very simple, easy. You have metastatic first line PDL positive, yes, we go for Pembro. No, you can go for single agent chemotherapy if you want. And then there is a progression disease. You test for BRCAs. Yes, you can use olaparib. If no, you are going to use the SASI. Recommendation, patient with metastatic triple negative cancer who have received at least 2 prior chemotherapy should consider sacituzumab. Don't go 4, 5, 6, 7 lines. It is not going to work. You are going to spend 100,000 of reals for nothing. Start early as per indication. Now, this is the ESMO guideline. Again, it is almost the same. Now, the new era is the CAR T cell. The CAR T cell is a new era for management of triple negative. Now, what we have here, we have a target, as you can see here, like a TROP2. We have mesothelium, we have a MET, we have a MUSA1, and so on. And then, you have to have a CAR delivery. And then, using you mean that you are taking the blood from the patient, you are preparing for them, and then you are injecting, and then so on. So it is a long program. But anyway, all of this is phase 1 trial. There is no much of phase 2 trial. At King Faisal now, we have this unit, but they suggest that they cannot do the phase 1. We need to go for phase 2. This is why we are looking for something like that. Now, we are interested in the following. We are interested with the mesothelin, we are interested in CMET, we are interested in MUSA1 and the TROP2. And all of this, if there is any, we are looking for any who is the clinical trial, on clinical government trial, okay, and with the company, that maybe we have to start the program even for the whole kingdom for triple negative disease, if you wish to do that. But it is really area of interest for the CAR T cell in patients who fail at least 3 or 4 lines of triple negative disease. I think that at this point, just I show you, this is, forget about this, because this is the same tag. You are taking, this is the tumor, this is the cartel, and then you have vehicle low versus high, isolate and genetic engineering of the T cell injected in the blood, and how this is how it is working in the system by blocking the signaling pathway. Now, this is the whole spectrum, as you can see here for breast cancer, first line, second line, and more than second line. Now you can add chemo and Pembro. We can give chemo now and Pembro. Here we can use Pembro as second line. AKT, it is a lot, and BI3K in the clinical trial, and the PARP inhibitor, it can be used in the first line for the metastatic. At this point, and also Trovo can be used after 2 lines of chemotherapy. Now, this is taking home message. Thank you for standing and stay all the day here. The optimal treatment strategy for patient remain a major unmet need, and we know that. The molecular heterogeneity of the disease has provided the basis for the development of novel effective therapeutic options such as PARP inhibitor established, antibody drug conjugate, which is our kid today, SASI, and immunotherapy, which is Pembro for sure, who has BDL1 more than 20% or more than 10%. And again, adding to this, clinical trial for CAR T cell should be considered, along with the chemotherapy and new therapeutic scenarios, a full potential to improve outcome of patients. It is coming soon. From the emerging, as I mentioned, the emerging trend, which is at least more than 70 or 80 clinical trial going in for the triple negative, a better coordinate and unify understanding of the intrinsic and the extrinsic feature of triple negative, as we mentioned the second or third slide. And I think that this is the major step toward better outcome. Now, remember one thing, it is very important that this is what you are going to see soon. This is 2024 and 2029, that mainly, okay, it will be the PARP inhibitor and Tropo2. So we are talking about between 30 to 35 billion a project for AstraZeneca and Gilead. Also, as you can see here, the BD1 and BDL1 inhibitor, it is taking a part of 2029. This is only for United States of America. Imagine, the rest of the world. Okay, thank you.
Thank you very much, Dr. Tahir, for fantastic presentation. Please, can we have a seat for open the discussion?
Sure. With the exception of the TDM1, they have a different molecular pathway. We never heard about it. Any question?
Any question?
Thank you. Yes, I do have a question for Dr. Tahir. Thank you very much, Dr. Tahir, for your excellent presentation and comprehensive as well. My question regarding SASI in the triple negative patients. So the main point that we didn't see which subgroup of patients who benefit more from the treatment. So we know that the study was definitely better than the other chemotherapy, either capecitabine, gem, or Replin or levinabine. But when we look at the median, it's not much, about 2 to 3 months regarding the overall survival and the DFS. And the point that who is subgroup benefit from the treatment more? We don't have biomarkers, as you know, and we're still treating triple negative based on that, the sequence of treatment, as you pointed out.
Is this question for Dr. Tahir?
Yes, my question, who is subgroup benefit from the SASI, the triple negative patients? Who is benefit more? How we know?
This is Mervat.
Yes.
Yes.
أهلا ميرفت كيفك؟
ازاي حضرتك؟ اهلا بيك.
Allah يسلمك. And I didn't know you are asking about subtype. We never have subtype for triple negative. All what you see on the slide.
No, I'm asking about the subgroup.
There is no
the group of benefit from the treatment.
Who is subgroup? I mean that, the classification, it is triple negative disease who has been exposed to 2 lines of chemotherapy. They are going to be a 3rd line. It will be the antibody drug conjugate. We don't have a biomarker and we are not going to see it, the number 1. Number 2, the classification that has been published. So the immuno versus non-immuno, all of this, it has not been reached to the clinic. Even the people that are fighting now for the subclassification of the triple negative. We don't have subclassification. I don't think that in near future, Mirvat, we will have something to the triple negative to tell who's going to respond or not respond. This is the same as anything in the breast cancer.
I think she's pointing to TROP2 amplification.
TROP2, TROPO, it has been done, and it has been said that patient who is overexpressed, which is there are more than 40, more than 60, less than 20, but it has no any of authors or regulatory that suggests that we are going to use this. So far, maybe in future that we are going to look for, and in fact, Mirvat, the question about the sacituzumab in terms of the mechanism of resistance, as I said today, this is the first time that we are hearing about the new pathways. We never heard about the calcium modulators. We never heard about RAC1. We never heard about the fibronectin. We never heard about the beta-catenin. All of this, it is out of question. Now, people, they are thinking, where is the mechanism of the resistance? And we need people to work on this. But if you have a patient, he has more than or 2 lines of therapy, this is the perfect patient today to give sacituzumab with no further concern.
Yes, absolutely, Professor Tar. So the other issue that the study was included patients who received chemotherapy before, but now, as you pointed out, the strategy for the triple negative, including patient who's receiving immune therapy or patient receive PARP inhibitor. Do you think those patients as well, they can be candidate for SASI as well, because it was not on the study?
No, that has been not included, but I think that even the one that who has received even immunotherapy, chemotherapy, and it's considered to be as 1 line. Sahih, it is for sure that it has not been included in a clinical trial. But this is, today, if somebody, you have BDL1 positivity, 1st line, and as I said, based on our data, it is about 25% of our patients. It is not that much. Remember, at King Faisal, we are seeing about 70 case triple negative per year based on 500. 60 of them are early and 15 are late. It is not that much. If these 70 patients, I am doing for them BDL1, I am expecting that it is only 14 or 15 going to be fit for the Pembro. It is not more than that.
We'll take another question.
Yes. My question is for Dr. Nadia Harbert. Thank you so much. Huh? She's here?
I think she left.
I think she left.
She left? Oh,
she left.
Yes.
But just ask us questions.
We can ask a question. My question is in early breast cancer. My name is Sada Rifai. I'm a medical oncologist, National Guard in Riyadh. So in early breast cancer, in the BRCA positive patient, N2 disease, but the Ki-67 is low. Would you start her an abemaciclib or olaparib?
And I think that to answer your question about the abemaciclib, has been discussed at King Faisal, and Dr. Dahsha Jeremy is here. It has been rejected as early for the breast cancer. Now, as I said in the morning, there is issue with the Ki-67 testing. And Nadia, she wants to tell us that because, you know, the FDA until this moment, they have to find out, and the European Union, how to use that cohort 2. You know, there are 2 cohorts, cohort 1 and cohort 2. The cohort 2 is related to the Ki-67. Nobody talk about it. And the company, they are just staying and waiting what they are going to do with that. Now, the other one, the cohort 1, okay, you have to patient have more than 4 positive node, or the tumor size is more than 5 centimeter in imaging, plus, and that could be grade, any grade. You understand what I mean? Now, if you have somebody who is 1 to 3 positive node, tumor size is more than 5, they have to be grade 3. This is the group that may consider using abemaciclib. Anything beyond this, I will not think about it. So that means it is high risk group, really high risk group. Olaparib, I mean that again, you know, for somebody who is neoadjuvant or adjuvant, okay. Now for the neoadjuvant group, if you have no BCR or positive node, you know, I mean that the RCB is more than 2 or 3 or so, and so on. This is the group, and they are germline mutation that you are considered to use olaparib early. Now we are waiting for, you know, the Saudi FDA for the approval. Adjuvant, the same thing, you know, tumor size large, and you know, positive node, and then there is score, which is called PSK, which is more than 2 and 3. So it is very clear in the early stage.
What she means, if you have hormonal positive BRCA mutant and high risk with 4 nodes, for example.
Olaparib.
Olaparib rather than abemaciclib.
Yes, absolutely. Germline, and I will go for olaparib. Yes, absolutely. But I want to tell you about the abema. Don't be risk. High risk is high risk. 5 centimeter, 4 more than positive, grade 3. But don't they tell me that 1 positive node and the Ki-67 more than 20%, I will give abema. Forget about that.
Any more questions?
Thank you so much, our Professor Dr. Taha, for this very interesting presentation. I have 2 questions. One of them, Dr. Sidan has the same question. Another question for you. This repeated question to gain the opinion of experts as you. 4 cases of metastatic triple negative breast cancer, positive for PD-L1 and BRCA mutated.
They are positive for BI3K?
No, BD1.
BDL1.
And the same time mutated BRCA positive. For this case, start with immuno or PARP inhibitor first.
Okay, so that means you have a patient with metastatic disease.
Yes.
They are hurt.
BRCA positive, BDL1 positive.
BRCA positive and BDL1 positive.
Start with.
Okay. And I can tell you, I will start with the Bembro with chemotherapy. Why? I will leave the olaparib for second lines.
Is another chance to start with olaparib?
يعني شوف انك انت يستارت olaparib يعني في الميتاستاتيك احنا عارفين they need at least more than 2 line of therapy.
Yes.
ازاي؟ لكن it is if the de novo one and both BDL1, this is the patient that they benefit from both. I start immune first, and then when they progress, maybe I will consider, olaparib.
Is there any significance to start with immunotherapy over PARP inhibitor?
Both, you mean?
Is there any significance to start with immunotherapy
for this patient?
For this patient.
As per guideline, yes. De novo patient, yes.
Okay.
Yes.
Another question?
Thank you, Dr. Tarek, for this nice presentation.
Today you ask very important question about the bone metastasis, right?
Yes, oligometastatic disease.
Yeah, I know the bone. Don't use CDK4 and 6.
So I can treat the patient as curative intent first.
What's that?
The patient, I asked
that you are saying that the bone
bone
alone, and then give CDK4 and 6 or give hormonal?
aromatase inhibitor with CDK.
No. If she's post-menopausal, just give fulvestrant.
And for surgical intervention?
No, I will not use it.
Okay.
Anaconda, I would like to tell you that.
Okay, thank you.
Next.
Any more?
Just I have a question about, you said that we use PARP inhibitor as, it's approved as adjuvant in BRCA mutation, as adjuvant therapy in triple negative BRCA mutated. Just I want to ask, you said it's...
No, just you said that approved in the United States, not for us.
Not for us here.
No, early not, in here not.
My question is, it's approved only for germline mutation or for also somatic mutation?
Okay, and so you are coming tomorrow?
Yes.
You are going to hear about this.
Okay, thank you.
Okay.
I have one more question for you, Dr. Tahir. If you have one patient triple negative and receive Pembro with chemotherapy, and still there is residual disease, you will prefer Xeloda or continue on Pembro or both?
Again, so you have a patient
Triple negative.
Yes.
New adjuvant with Pembro.
New adjuvant with Pembro, yes.
There is a residual disease.
Residual.
Yes, you will prefer Xeloda or Pembro or both, as Tahir to Ejri.
Okay, now first of all, and I will tell you about the issue of neoadjuvant Pembro, okay? Now we decide, okay, if the patient, they receive chemotherapy and Pembro and they achieve BCR, okay, no further Pembro after that, we decide about this. So we are not going to follow the FDA because the data is very short, and then the same time, the benefit is 2%. Now we will come to the issue that the patient who has no PCR, that you need to continue the Pembro for 9 cycles. Now your question is give Pembro alone or give capecitabine plus Pembro?
Yes.
I don't think that we have a data for this, but it is according what we have today. Okay, either you will give only the Pembro. You cannot join these two together. There is no data.
But we have good data on Xeloda alone.
Yeah, we have a good data for survival. Yes. Right? So that means you start neoadjuvant, and then you have no PCR, you stuck. Right? So you have to complete, and there is no other thing like that. But I cannot recommend now, based on no data, to give Pembro and capecitabine. But the other thing is, which is very important, just to emphasize on this, that today talk, okay, is opening the window for new signaling, opening the window for new knowledge. We are behind the tyrosine kinases in general, and we are going to see more antibody drug conjugate, more strong than the SASI and Enhertu soon. Okay.
Thank you very much. Thank you very much all. Thank you, Dr. Mirfat. Thank you all. We will conclude the last session for Thursday. Thank you very much.
Thank you all. Thank you.
Thank you all for, thank you for the attendee until the end of day 1. And I hope to see you all tomorrow at 11 o'clock. We will start tomorrow, 11 sharp. I hope to see you again tomorrow for day 2 of Best of San Antonio. And we'll see you now, inshallah, with us in the gala dinner. Thank you.